Super Speciality Hospital. Suswagatam, Suswagatam, Suswagatam. We are about to begin with the inaugural ceremony with the lamp lightning. So we will take 10 minutes more for beginning the function.
respected seniors. I, Dr. Pallavi Jadhav Dodke, pathologist, cordially welcome you all for this multidisciplinary scientific session. To begin this symposia with the auspicious lab lightning, I would like to invite Honorable Organizing Chairperson, Dr. Praful Patil sir, Dr. Vidya ma'am, IMA President, Dr. Anil Kaner Patil sir, MMC Observer, Dr. Raj Gopal Kalani sir, IMA Secretary, Dr. Sanjay Khilare sir, speakers, Dr. Ketki Patil Maske ma'am, Dr. Ajinkya Patil sir, Dr. Abhitej Maske sir, Dr. Daitankar sir, Dr. Siddeshwar sir, Dr. Bhosle sir, Dr. Katneshwar sir, and Dr. Omanwar sir. I request to all dignitaries for lamp lighting and felicitation. So please. Okay. Extremely sorry, Dr. Dattatreya Magar sir. Now I would request to Dr. respected all dignitaries on dais. Request to all for lamp lighting. I request to all dignitaries for this session lamp lighting. Dr. Bhosle sir, Dr. Katneshwar sir,
Dr. Abhitej Maske sir,
Dr. Abhitej Maske sir,
Dr. Ketki ma'am,
Dr. Ketki Maske Patil ma'am.
Dr. Katneshwar sir, please come on dais. I request Dr. Katneshwar sir. Yes. Sir, please come on dais. Dr. Bhosle, sir, please come on dais. Respected Dr. Bhosle, sir. After the Dhanvantari Pujan, I would like to request all the dignitaries for lamp lightening. Dr. Sagar More, sir, please come and join for the lamp lightening. Dr. Bhosle, sir, please join us for the lamp lightening. Dr. Chandak, sir, please join. Dr. Anita, ma'am. Dr. Anita Navandar, ma'am. I request all the dignitaries to take their seat so we can proceed for the felicitations. I request Dr. Ambegaonkar sir. I request Dr. Ambegaonkar sir to come on the stage for the felicitation of respected Dr. Anil Kane Patil sir, IMA President. Dr. Ambegaonkar sir. I request Dr. Praveen Patil sir. I request Dr. Praveen Patil sir to come on dais for the felicitation of Dr. Kane Patil sir, IMA President. Dr. Praveen Patil sir, please felicitate Dr. Magar sir. Dr. Magar sir. I request Dr. Vijay Bonde sir for the felicitation of Dr. Magar sir. Dr. Katneshwar sir, please join us on that. I request Dr. Sagar More sir to felicitate Chairperson Honorable Dr. Prafulla Patil sir. I request Dr. Anita Navandar ma'am to felicitate Chairperson Honorable Dr. Vidya Patil ma'am. I request Dr. Kondawar sir to felicitate Honorable Dr. Khillare sir, IMA Secretary. Honorable speakers, Dr. Ajinkya Patil sir, Dr. Abhitej Maske sir, Dr. Ketki ma'am, please come on dais. I request Dr. Pallavi Dodke ma'am to felicitate Dr. Ketki Maske ma'am. I request Dr. Nilesh Pawar, sir, to come on stage for the felicitation of Dr. Abhitej Maske, sir. Yeah. I request Dr. Vijay Sai Shelke, sir, to come on dais for the felicitation of Dr. Ajinkya Patil, sir. I request Dr. Chaitanya Khillare, sir, to come on dais for the felicitation of Honorable Dr. Ajinkya Patil, sir. I request Dr. Daithankar, sir, to come on dais for the felicitation of Dr. Katneshwar, sir. I request Dr. Prasad Magar, sir, to come on dais for the felicitation of Dr. Oman Bar, sir. Thank you so much, all of you. I would like to invite Honorable Dr. Vidya Patil, ma'am, for the inaugural speech. Okay. I request Dr. Siddheshwar, sir, to come on dais for the felicitation of Dr. Sagar More, sir, organizing committee, organizing secretary. Dr. Bharat Devsarkar, sir, please come on dais for the felicitation of Dr. Vijay Bonde, sir. Dr. Bharat Devsarkar, sir, please felicitate Dr. Vijay Bonde, sir, organizing secretary, IMA. With the kind permission of honorable dignitaries, we will proceed for the inaugural speech of Dr. Vidya Patil ma'am.
Good morning, everyone. Respected dais, Honorable Dr. Magar sir, IMA President Dr. Kane Patil sir, Dr. Praful Patil sir, Dr. Katneshwarkar sir, Dr. Omanwar sir, Dr. Khilare sir, Dr. Chandak sir, Dr. Bhosle sir, all my colleagues and seniors. I would like to invite you all for this warm CME, which is arranged by Dr. Praful Patil Multi-Super Speciality Hospital in collaboration with IMA. Actually, we have started practice 30 years back. And I remember when we started practice, so since then, IMA is helping us at every step of our professional career. And when I was president in 2011, we got our accreditation for MMC in 2011. Since then, the IMA is having so many CMEs and programs. I remember when I was president and Dr. Bhutada was secretary, we organized 35 programs in a year. And that was the highest number, I think. And that was just because of support of IMA and all seniors. So I'm grateful to IMA always and henceforth. मला आठवतं की नेहमी जेव्हा आम्ही प्रॅक्टिस सुरू केली त्यावेळेस सर मला विचारायचे, म्हणजे मी सरांना जेव्हा विचारायची की आज कॉलला कोणाला बोलवायचं, तर सरांचं एकच असायचं की नेहमी जे ज्युनियर्स आलेले आहेत, जे न्यू कमर्स आलेले आहेत त्यांना चान्स द्यायचा. मग ते पेडियाट्रिशियन असो, अनेस्थेटिस्ट असो, एनीबडी. आणि तोच ट्रेंड आता पुढे पण चालू ठेवलेला आहे. डॉक्टर प्रफुल्ल पाटील मल्टी सुपर स्पेशालिटी हॉस्पिटलमध्ये पण आपण मॅक्झिमम लोकांना इन्व्हाइट करतोय की हे हॉस्पिटल एक परभणी जिल्ह्याच्या दृष्टीने महत्त्वाचा टप्पा आहे. आणि ते शेवटी IMAच्या सपोर्ट शिवाय आणि IMAच्या सगळ्या मेंबर्स शिवाय त्याला शोभा येणार नाही असं मला वाटतं. आणि ही जी CME आहे, ह्या प्रकारच्या CME वी वुड लाईक टू कंटिन्यू इन द फ्युचर विथ IMA. Once again, I would like to thank you IMA and Dr. Praful Patil Multi Super Speciality Hospital, all my organizer, all my team who work hard of SDDC and PPMSH family. Thank you so much. Thank you, dignitaries.
Thank you so much, ma'am. Now, I would like to invite Dr. Kane Patil sir, IMA president, for sharing his thoughts.
Respected Magar sir, Katneshwarkar sir, Bhosle sir, Chandak sir, Omanwar sir, my colleagues, Dr. Praful Patil, Khilare, and all on the dais and off the dais. Actually, this is our privilege that first multi-speciality super specialty hospital in Parbhani, Prafulla Patil Hospital, is taking CME with us. And their enthusiasm gave us really a thought that there must be super specialty hospital in Parbhani. This was the first thought of Prafulla Patil, and he is having vision, and that's why instead of starting a general hospital or a simple hospital, he started specifically the super specialty hospital, and he is giving nice services with the help of government programs. I think that is Mahatma Phule is you are having, no? And many people from the Parbhani are being treated there with no fees, and this is really a grateful for us in Parbhani. Actually, प्रफुल्ल पाटीलनं खरोखरच आपल्या परभणीचं डेव्हलपमेंट केलं म्हणायला हरकत नाहीये, कारण की पहिलं डेंटल कॉलेज का होईना परंतु त्यांनी परभणीमध्ये आणलं आणि त्यांनी दाखवून दिलं की हुशार माणसं असले किंवा क्वालिफाईड माणसं असले की त्यांची थिंक वेगळी असती, विचार वेगळे असतात. त्याच पद्धतीने आता सध्या आपले जे आमदार आहेत ते सुद्धा त्याच याच्यावर आहेत की त्याच ट्रॅकवर आहेत की त्यांनी सुद्धा परभणीच्या डेव्हलपमेंट बद्दल विचार केलेला आहे, आणि हे खरोखरच म्हणजे वाखाणण्याजोगं आहे किंवा ऍक्सेप्ट करण्याजोगं आहे की क्वालिफाईड लोक जर त्या पदावर गेले तर काय होऊ शकतं. आता मला त्यात स्पेसिफिक हेही सांगायचं आहे की आपण पॉलिटिक्सचा सहभाग घ्यायला हरकत नाही, परंतु आपल्या IMA ला सोडलं किंवा आपल्या पॅरेंट्सला सोडलं तर फार जास्त डेव्हलपमेंट होत नाही, कारण की खरे विचार तुमचे इथूनच आलेत आणि तुम्हाला सगळं बेस इथूनच आहे. त्यामुळे तुम्ही इथेही तुम्ही अटॅचच राहायला पाहिजे. पॉलिटिक्स मध्ये मी पण आहे, नावंदर सर पण आहेत, प्रफुल्ल पाटील पण आहे, सर्वजण आहेत, परंतु आपल्या IMA ला आम्ही तर कधी सोडलेलं नाही. आणि गेल्या मला वाटतं जसं मी 98 पासून इथे आहे तसं एकही 26 जानेवारी 15 ऑगस्ट एकही मी झेंडावंदन मिस केलेलं नाही. त्याच्यामुळे मला IMA बद्दल अभिमान आहे, त्यामुळे मी IMA मध्ये आहे. आय एम ऑलवेज देअर. आणि जे आज जी काही छान आपली CME होत आहे, इथे सगळे सुपर स्पेशालिटी डॉक्टर्स आहेत, चांगले चांगले स्पीकर्स आहेत, हे यांनी प्रफुल्ल पाटील यांनी अरेंज केल्यामुळं खरोखरच मी त्यांचा आभारी आहे. IMA इज ऑलवेज विथ देम. त्यांनी कधी आम्हाला हाक द्यावी, आम्ही त्यांच्या सोबत आहोत. थँक्स.
Thank you so much, sir. Now, I would request respected Dr. Prafulla Patil, sir, for sharing his valuable thoughts with us.
इंडियन मेडिकल असोसिएशन परभणी शाखेच्या आणि आपल्या मल्टी सुपर स्पेशालिटी हॉस्पिटलच्या सर्वांच्या हॉस्पिटलच्या संयुक्त विद्यमाने आपण आज हा कंटिन्यूइंग मेडिकल एज्युकेशनचा दिवसाचा सत्राचा कार्यक्रम आयोजित केला आहे. संपूर्ण दिवसामध्ये आपण 9 जागतिक दर्जाचे स्पीकर्स, ज्यांचा अख्ख्या महाराष्ट्रामध्ये देशामध्ये काही स्पीकर्स तर आंतरराष्ट्रीय 10-10 वर्ष युरोप आणि आयर्लंडमध्ये काम करून आलेले आहेत, अशा सर्वांची एक अकॅडमिक फीस्ट मेजवानी आजच्या दिवशी रविवारी आयोजित केलेली आहे. सदर या संपूर्ण CMA ला महाराष्ट्र मेडिकल काउन्सिलचे ॲक्रेडिटेड पॉईंट्स आहेत. तो एक तांत्रिक भाग झाला, पण शेवटी या मागची भूमिका आहे की आपलं वैद्यकीय नॉलेज, आपले ॲडव्हान्सेस या क्षेत्रामध्ये होणाऱ्या सगळ्या गोष्टी, दिवसागणित शास्त्र बदलत असतं, दिवसागणित विचार बदलत असतात, दिवसागणित तंत्रज्ञान आणि कौशल्य तुम्हाला त्या पद्धतीने बदलावं लागतं. आणि त्याच धारणेतून ह्या ज्या काही स्टॅट्युटरी बॉडीज आहेत आपल्या, त्यांनी हे CME चे ॲक्रेडिटेड पॉईंट्स कंपल्सरी केलेले असतात. पण तो कंपल्सरी पार्ट जरी वेगळा ठेवला तरी आपल्या दिवसाच्या प्रॅक्टिसमध्ये आपल्याला अद्ययावत काय चाललंय, आज जगाच्या पाठीवर काय चाललंय याचं ज्ञान आपल्या कानावर पडलं पाहिजे. त्यातलं आपण आपल्या शहरात कुतपत करू शकतो याचा विचार करून आपण ती यंत्रणा आपल्या शहरामध्ये आपल्या रुग्णांपर्यंत पोहोचवली पाहिजे. आणि हाच या कंटिन्यूइंग मेडिकल एज्युकेशनचा हा मुख्य उद्देश असतो. आणि आज हे 9 वेगवेगळ्या क्षेत्रातले स्पीकर्स या ठिकाणी येऊन आपल्याला विचारांची देवाणघेवाण करणार आहेत, अकॅडमिक एक्सचेंज करणार आहेत. त्यामुळं ही एक सुंदर इंटरॅक्टिव्ह CME आजच्या दिवसाची होईल आणि IMAच्या अनेक CMEमध्ये अजून एक CMEची भर पडेल. IMAचे अध्यक्ष डॉक्टर अनिल काने पाटील, आपले ज्येष्ठ सर्वांचे गुरुवर्य आदरणीय दत्तात्रय मगर सर, कृष्णा कातनेश्वरकर, डॉक्टर ओमनवार सर, डॉक्टर GM चांडक, डॉक्टर हनुमंत भोसले सर, इथे जमलेले सर्व सिनियर लोक, विलास देशमुख सर, नावंदर मॅडम, संस्थेच्या सचिव आणि IMAच्या माजी अध्यक्षा की ज्यांच्या काळात IMAला खूप काम करायला संधी मिळाली आणि त्या IMAच्या कामाच्या सार्वजनिक आणि वैद्यकीय क्षमतेमुळे त्यांना महाराष्ट्र शासनाने कैलासवासी आनंदीबाई जोशी हा पुरस्कार दिला. त्यात IMAचं क्रेडिट जास्त आहे आणि मॅडमचं आणि आमचं क्रेडिट कमी आहे, कारण IMAच्या व्यासपीठावरून त्यांनी त्या वर्षामध्ये खूप सारे प्रोग्राम घेतले आणि ती एक उपलब्धी समाजासाठी महाराष्ट्र शासनाला वाटली. त्या डॉक्टर विद्या पाटील मॅडम आज आलेले IMAचे सेक्रेटरी संजय खिल्लारे सर, क्लिनिकल सेक्रेटरी सागर मोरे अत्यंत उत्साहाने वडिलांच्या पावलावर पाऊल टाकले त्यांनी. मोरे सरांचं नाव एक सुंदर अकॅडमिशियन आणि एक क्लिनिशियन म्हणून अख्ख्या महाराष्ट्रात घेतलं जायचं. मेडिकल कॉलेजमधून आम्ही जेव्हा बाहेर पडलो त्यावेळेला जे अकॅडमिक नावं घेतली जायची त्यामध्ये मगर सरांचं नाव तर असायचं, पण पेडियाट्रिक्समध्ये मोरे सरांचं नाव असायचं. ऑफ्थॅलमध्ये तर आजही भोसले सर डायनॅमिक आहेत, GM चांडक सरांचं असायचं. जरी आपलं शहर छोटं असलं तरी आपल्या शहरात प्रॅक्टिस करणाऱ्या लोकांचं नाव हे अख्ख्या महाराष्ट्रामध्ये त्यांच्या क्षेत्रामध्ये आहे. ही आपल्या सगळ्या जिल्ह्याला अभिमानाची बाब आहे. फक्त आता ज्या कमतरता आहेत त्या शहराच्या रूपानं आहेत, किंवा या शहरामध्ये एक डॉक्टर रिलेटेड ट्रेंड होता की बाबा पेशंट हा डॉक्टरकडे जातो की मला कात्नेश्वरकरांना दाखवायचं, मला डॉक्टर प्रफुल्ल पाटलांना दाखवायचे, मला डॉक्टर मगरांना दाखवायचे. तो जिल्ह्याच्या पातळीवरचा ट्रेंड असतो आणि ते स्वाभाविक पण आहे. पण आता एकंदरीतच शासनाचं धोरण, आंतरराष्ट्रीय बदल वैद्यकीय क्षेत्रात होणारे, त्या दृष्टीनं सगळ्या केंद्र शासनाने घेतलेल्या भूमिका याचा विचार जर केला तर आता आपण बघा, ग्लोबल हॉस्पिटल विकल्या गेलं, मॅक्स हॉस्पिटल विकल्या गेलं, मुंबईमधले मोठमोठी कॉर्पोरेट हॉस्पिटल 1000 बेडच्या वरची होती ती सगळी विकल्या गेली. आणि ती कोणी विकत घेतली? तर सिंगापूर आणि मलेशियाच्या शासनाने विकत घेतली. गव्हर्नमेंट ऑफ सिंगापूर आणि गव्हर्नमेंट ऑफ मलेशिया हे आपल्या भारतामधली मोठमोठी हॉस्पिटल विकत घेत आहे. तुम्ही म्हणसाल की त्यांना रोखलं पाहिजे, पण आपण जागतिकीकरण स्वीकारलेलं आहे त्यामुळे आपण त्यांना रोखू शकत नाही कायद्यानुसार, त्यामुळे ही प्रक्रिया थांबणार नाही. तुम्ही म्हणाल की मग त्यांनी का विकले विकणाऱ्यांनी? आता उदाहरणार्थ चारू आपटे माझे मित्र आहेत, त्यांनी सह्याद्री हॉस्पिटल टेक ओव्हर केलं. ते आपल्या हॉस्पिटलचा जो काही खर्च असतो 100 कोटी 200 कोटी 500 कोटी 1000 कोटी, त्या खर्चाच्या दुप्पट रक्कम ते लोक देतात. शिवाय तुमचा शेअर्स 49% ते ठेवतात. त्यामुळे कुठल्याही कॉर्पोरेट सेक्टरला वाटतं की माझा पैसा दुपटीनं निघून गेलेला आहे, मला या स्ट्रेस आणि स्ट्रेन मधून बाहेर पडायचं आहे. भारतातल्या सामाजिक लोकांचा दृष्टिकोन डॉक्टरांकडे पाहण्याचा बदललेला आहे. हॉस्पिटलवर हल्ले होत आहेत, मृत्यू झाला की त्याला डॉक्टरच जबाबदार, ही धारणा लोकांमध्ये हळूहळू वाढत चाललेली आहे. त्याच धारणेला इतर लोकही स्टॅट्युटरी बॉडीज सुद्धा त्याच अँगलने विचार करतायत. ह्या सगळ्या बदलत्या परिस्थितीमध्ये आपण सगळा देश हा एका संक्रमणावस्थेत जात आहे की प्रॅक्टिस करायची कशी. एक काळ असा होता की डॉक्टरकडे काही झालं तरी माझं नशीब म्हणून रुग्ण घरी जायचा. आज असा काळ आहे की डॉक्टरकडे काही झालं तर रुग्ण राहतो बाजूला आणि समाजातले सगळे घटक, तो रुग्ण कसा बरोबर होता आणि डॉक्टर कसा चूक होता, या धारणेकडे जाण्यासाठी आपण अनेक उदाहरणं देशामध्ये रोज पाहतो, व्हॉट्सअपवर पाहतो, टीव्हीवर पाहतो. मग याला उत्तर काय? याला उत्तर असं आहे की ही जी संक्रमण अवस्था आहे आपल्या देशाची, की पाश्चात्य कंपन्या भारतामध्ये येत आहेत, त्यांच्या हातामध्ये पुढच्या 10 ते 15 वर्षामध्ये सगळी मोठमोठी हॉस्पिटल गेलेली असतील. भारतातली छोटी मोठी लोक म्हणजे जी की त्यांच्या दृष्टीने छोटी मोठी आहेत, अंबानी झालं, टाटा झालं, यांची काही रुग्णालय सस्टेन होतील. आणि मग जिल्हा लेवलला ना ही मोठी पाश्चात्य कंपन्या येतील ना टाटा अंबानी येतील. जिल्ह्याच्या लेवलला तुम्हाला जर टर्शरी केअर द्यायची असेल तर तुम्हाला लोकांना एकत्र आपल्याला यावं लागेल आणि आपण येऊन त्यांच्या दर्जाचं इन्फ्रास्ट्रक्चर आपल्याला द्यावं लागेल. तरच आपला रुग्ण म्हणणार नाही की मला त्यांच्या हॉस्पिटलमध्ये जायचंय. आणि त्याचाच एक छोटासा प्रयत्न करण्याचा मी प्रयत्न केला. वास्तविक पाहता माझ्या कार्यक्रमाला अनेक लोक आली. राजकीय पक्षांपेक्षाही माझे वैयक्तिक संबंध सगळ्याच पक्षातल्या लोकांशी असतात, कारण त्या माणसांकडनं आपल्याला प्रत्येक भेटीमध्ये काहीतरी शिकायला मिळतं अशी माझी धारणा आहे. शरद पवारांचा माझा अनेक वर्षाचा सहवास होता, आजही आहे. गडकरींनी जेव्हा माझं हॉस्पिटल पाहिलं त्यावेळेला त्यांनी भरभरून कौतुक केलं की डॉक्टर ऑरेंज सिटी आमच्या नागपुरांपेक्षाही तुमचा ॲम्बियन्स खूप सुंदर केलेला आहे आणि पब्लिक प्रायव्हेट पार्टनरशिपमध्ये आम्ही महाराष्ट्रात आणि देशात प्रयत्न करतोय. तुम्ही या महाराष्ट्रातले 25 हॉस्पिटल चालवायला घेऊ शकता का? मी त्यांना हात जोडून सांगितलं, साहेब माझं काम हॉस्पिटलचं 2-3 वर्ष मला करू द्यात आणि या गोष्टी काही मला झेपणाऱ्या नाहीयेत. अर्थात त्या गोष्टी अजून PP हॉस्पिटल मॉडेलमध्ये झाल्या नाही. सांगायचं तात्पर्य शासनाचंही धोरण असं आहे की शासन आणि कॉर्पोरेट हॉस्पिटल एकत्र येऊन सेवा दिली पाहिजे. त्यामुळेच क्लिनिकल इस्टॅब्लिशमेंट ऍक्ट आणला की जेणेकरून छोट्या छोट्या रुग्णालयांना ते नॉर्म्स मेंटेन करणं शक्य होणार नाही. मग या सगळ्या परिस्थितीला जर आपण बाजूला ठेवलं, आंतरराष्ट्रीय पातळीवर बाजूला ठेवा, देश पातळीवरचं बाजूला ठेवा, आपल्या जिल्ह्यासाठी आपण सगळ्यांनी एकत्र आलं पाहिजे. त्यासाठी आपल्याला एका चांगल्या इन्फ्रास्ट्रक्चरची गरज होती. तेवढीच पायरी मी केलेली आहे. ही खूप प्राथमिक स्टेज आहे. फक्त आपण एक इन्फ्रास्ट्रक्चर उभं केलं की तिथं 7 ऑपरेशन थिएटर आहेत, सगळे मॉड्युलर ऑपरेशन थिएटर आहेत. आता चारू आपटेची टीम आता पुढच्या महिन्यामध्ये येऊन ऑर्गन ट्रान्सप्लांटचा पहिला प्रयोग इथं करणार आहेत. त्यासाठी त्यांचं पेशंटचं स्क्रीनिंग चालू आहे. आपल्याकडे काल शनिवारी 5 अँजिओग्राफी 5 अँजिओप्लास्टी झाल्या. आपल्याकडे जॉईंट रिप्लेसमेंट आता सुरू करतायत. डॉक्टर अभितेश मस्के येत आहेत. 10 वर्ष त्यांनी आयर्लंडमध्ये काम केलेलं आहे. डॉक्टर अभितेश मस्केंचं नाव मला माझे फॅकल्टी म्हणून कळलं नाही, मला मुंबईतल्या लोकांकडनं कळलं की साहेब आमचं जॉईंट रिप्लेसमेंट 35 मिनिटात केलं. कोण ते डॉक्टर आयर्लंडचे आहेत. माझ्या वडिलांचंही औरंगाबादला जॉईंट रिप्लेसमेंट झालं. 1.5 ते 2 तास लोकांना ऑपरेशनला लागतात. अत्यंत नवीन आयर्लंडचं टेक्निक शिकून आले. ज्या हॉस्पिटलला त्यांनी काम केलं त्या हॉस्पिटलला रोज 5 ते 10 अगदी प्लॅन्ड सर्जरी असतात आणि वेटिंग असतात. इट इज द टॉप मोस्ट सेंटर इन द युरोप. आणि तिथं अभितेश मस्केंनी कंटिन्युअस 10 वर्ष काम केलं. त्यांना तिथली FRCS पदवी मिळाली MS ऑर्थोच्या नंतर. खूप मोठी आणि कष्टाची किमया त्यांची आहे. त्यांच्या मिसेस ज्या आहेत केतकी मस्के यांनी इथं इंडियामध्ये MD गायनिक केलं. त्यानंतर त्यांनी MSc एम्ब्रिओलॉजी केलं. IVF मधला सगळ्यात ॲडव्हान्स स्ट्रक्चरमध्ये त्या गेल्या. आपण कुठपर्यंत ऐकलेलं असतं ICSI इंट्रासायटोप्लाझ्मिक स्पंज इंजेक्शन आपण ऐकलेलं असतं, फ्रोझन एम्ब्रिओ ऐकलेलं असतात. पण त्याच्याही पुढीकडे त्यांनी कम्प्लीट फ्रोझन एम्ब्रिओ, जेनेटिक स्क्रीनिंग, जीन ड्रिलिंग ह्या सगळ्या स्किल्समध्ये त्यांनी केलेलं आहे. त्यांच्या भाषणामध्ये आपण त्यांचा सगळा अनुभव आणि त्यांनी लाईफलाईन हॉस्पिटलला सुदैवाने त्यांच्या वडिलांचंही खूप मोठं काम गेल्या 30 वर्षामध्ये आहे ते करतायत. आणि एकदा ते फ्रोझन एम्ब्रिओ घेतले की फर्स्ट प्रेग्नन्सी त्याच एम्ब्रिओनी, सेकंड प्रेग्नन्सी त्याच एम्ब्रिओनी, थर्ड प्रेग्नन्सी त्याच एम्ब्रिओनी, तिसरी पिढी सुद्धा त्यांच्या लाईफलाईन हॉस्पिटलमध्ये घेते. म्हणजे पुन्हा आपल्याला एक कलेक्शनचा खर्च नाही, पुन्हा एम्ब्रिओ फॉर्मेशनचा खर्च नाही, फक्त एम्ब्रिओ ट्रान्सफर. त्यामुळं लोकांचं कॉस्ट सेव्हिंग होतं. 3 IVF ला जेवढा खर्च लागतो तेवढा त्यांनी फ्रोझन एम्ब्रिओ ठेवल्यामुळं, जसं आपण फ्रीजमध्ये ठेवतो त्या पद्धतीनं विकसित केलेलं 20 वर्षापासूनचं वडिलांचं तत्त्वज्ञान ते अजून पुढे घेऊन जात आहेत. आज अजिंक्य पाटील आपल्यासोबत आहेत. अजिंक्य पाटील MCH न्यूरोलॉजी आहेत. अख्ख्या मुंबईमध्ये म्हणजे साऊथ बॉम्बे सोडून द्या, लीलावती हॉस्पिटल आणि साऊथ बॉम्बेचा एरिया कोकिलाबेन अंबानी हे 2 हॉस्पिटल सोडता अख्ख्या इकडच्या नवीन बॉम्बे, वाशी, पनवेल, रायगड या एरियामध्ये पहिलं लेझर हे डॉक्टर अजिंक्य पाटलांनी अद्ययावत आणलेलं आहे. आणि I expect a big applause for him. He has done a phenomenal work in last 6 months. किडनी ट्रान्सप्लांट करतात, रिट्रोग्रेड किडनी करतात. मला त्यातलं फार ज्ञान नाही, पण मला एवढं कळतं की जे स्टोन इम्पॅक्टेड असतात, जे खूप डिफिकल्ट असतात काढायला मॅन्युअली, की ज्या ठिकाणी डॉक्टर कृष्णा कातनेश्वर कॅन अंडरस्टँड हिज हायलाइट्स मोर ॲज अ चेअरपर्सन. पण ते सगळं तंत्रज्ञान त्यांनी केले. आज लाईफलाईन हॉस्पिटल, अपोलो हॉस्पिटल आणि अख्ख्या महाराष्ट्रामध्ये ते जात आहेत. आणि आपल्या परभणीला या तिघांनाही मी गळ घातलेली आहे की तुम्ही तिथं तुम्हाला जास्त पैसे मिळतील, पण माझ्या लोकांना 2 पैसे कमी मिळाले तरी तुम्हाला घरची पुरणपोळी खायला मिळेल. तुम्हाला महिन्याला इथे यावं लागेल आणि माझ्या ऑर्थोपेडिक सर्जन्सला, माझ्या गायनेकोलॉजिस्टला आणि माझ्या इथल्या युरोलॉजिस्टला सपोर्टिंग म्हणून तुम्हाला इथं काम करावं लागेल. आणि त्यांनी ते मान्य केलेलं आहे. त्यामुळे ह्या फॅकल्टीज आपण ड्राईव्ह करू. सरतेशेवटी पाटील मॅडमने एक उल्लेख केला. मी जेव्हा प्रॅक्टिस सुरू केली तेव्हा मलाही खूप लोकांनी एनकरेज केलं. मी MD गायनिक झालो आणि पहिल्या दिवशी प्रॅक्टिसला आलो. पानट मॅडम माझ्या टीचर होत्या आणि मगर सर त्यांना भेटले. आपल्या छोट्याशा गोष्टीचं कौतुक आपल्या क्षेत्रातल्या माणसाने केलं की खूप भरून येतं. मॅडमला सर म्हणाले की प्रफुल्ल हॅज सरपास्ड ऑल द डॉक्टर्स इन परभणी. त्यांचं वाक्य खोटं होतं, मी बिगिनर होतो, पण त्यांनी मॅडमला सांगितलं, माझ्या टीचरने मला कौतुक केलं, मला उभारी आली. आपल्या यशामध्ये अशा छोट्या छोट्या लोकांनी बोललेल्या नैतिक शब्दांचा, उभारीचा खूप मोठा वाटा असतो. मी पहिलं VVF केलं, मला माहित नव्हतं VVF आम्ही करतो. डॉक्टर अजिंक्य त्यावेळेला आम्ही गायनिक VVF करायचो, तुम्ही युरोलॉजिस्ट खूप अवेलेबल नसायचे. सरांनी येऊन प्रेस कॉन्फरन्समध्ये माझं कौतुक केलं की 100 सिझेरियन्स करण्याचा मान हा एका VVF मध्ये आहे. त्या दिवशी प्रेस कॉन्फरन्समध्येच माझ्या डोळ्यात पाणी आलं होतं. तर असं करत आमचा प्रवास होता. ज्युनियरला उभं करायचं, ज्युनियरला उत्तेजन द्यायचं, ज्युनियरला प्रोत्साहन द्यायचं, ही संस्कृती परभणी शहरामध्ये आहे. परभणी शहराच्या डॉक्टरांमध्ये जे वातावरण आहे ते अख्ख्या महाराष्ट्रामध्ये कुठेही नाही असं जर म्हटलं तर तेव्हा अजिबात वावगे ठरू नये. प्रोफेशन जेलसी हा जरी ह्युमन नेचर असला तरी त्याचा स्तर हा अत्यंत मर्यादित आपल्या परभणी शहरामध्ये आहे. डॉक्टर ओमनवार अर्ध्या रात्री कधी यायचे. मला राजकारणाची आवड होती, मला समाजकारणाची आवड होती. मी राजकारणात याच्या अगोदर अण्णा हजारेच्या सोबत 5-6 वर्ष फिरायचो. सभा लागायची, सिझर येऊन असायचे 2, इमर्जन्सी एक टोपिक यायची. कधी सर म्हणायची तू बॉस तुम चिंता मत करो, तुम तुम्हारा करो, मॅडम निपटले ते. एकेका दिवशी 7 कंटिन्युअस OT मी हॉस्पिटलच्या बाहेर असताना करायचे. कधी पैशाचा विषय नाही, कधी आपल्याला काय चार्जेस मिळतील याची धारणा नाही. ह्या भावनेतून या सगळ्या शहराची प्रॅक्टिस डेव्हलप झालेली. कृष्णा आणि गणेश चव्हाणनी कधी ऑपरेट केल्यावर मला आठवत नाही की त्यांनी मी दिलेले पैसे कधी मोजले. त्यामुळे आपण एकमेकांकडे जाताना त्याला क्रायसिसमधून कसं बाहेर करायचं हीच धारणा असायची. अर्ध्या रात्री 2 वाजता मगर सर, इव्हन प्रसाद सुद्धा स्वतः ड्रम घेऊन पळालेला मी कित्येकदा पाहिलेला आहे. किंवा त्यांच्याकडे ड्रम नसला तर त्यांना विनाकारण एक्सपोज करायचं की तुमच्याकडे हे नाही त्या नाही, त्याच्यापेक्षा बाबा आपण आपला ड्रम घेऊन जाऊ, असं करून प्रसादने ड्रम आणलेला आहे, सरांनी ओपन केलेले आहेत आणि PPHच्या वेळेला अनेक लोकांचे वाचवलेले आहेत. अशी ही आपल्या पूर्ण परभणीची संस्कृती आहे. आणि त्या संस्कृतीला अजून पुढे नेण्यासाठी सगळे सिनियर्सचा आधार घेऊन मध्यम फळीमधले जे आम्ही लोक होतो ते आहोत. पण आमच्या नंतर तुमची जबाबदारी वाढलेली, जी नवीन पिढी आलेली आहे त्यांना IMAचा प्रवास कदाचित माहीत नसेल. हा हॉल कसा होता, ही जागा आपल्या नावावर नव्हती, तो हॉल मिळवण्यासाठी काय करावं लागलं. अक्षरशः विलासराव देशमुखांचा हात धरायला आम्ही गेलो होतो. भक्कड होते, चांडक होते, उमाकांत चांडक आम्ही होतो. 8-10 जण जाऊन पकडलं तर ते एकदम म्हणलं की काय विषय, तुम्ही मुंबईला मी करून देतो. ते मुख्यमंत्री असताना मुंबईवर एकही कागद नव्हता, हात धरून करून घेतला. त्याचं नोटिंग जर वाचलं तर मुख्यमंत्र्याच्या विशेष अधिकारामध्ये कुठलेही कागदपत्र न असताना सार्वजनिक संस्था म्हणून देण्याचे प्रयोजन करण्यात यावे. हा प्रवास आहे. अनेक लोकांनी इथं देणगी दिली, हा हॉल सुंदर उभा राहिला, हा प्रवास आहे. पण या नवीन लोकांनी ह्या सगळ्या प्रवासाला विसरून चालणार नाही. या सिनियर लोकांनी जे योगदान दिलेलं आहे क्लिनिशियन म्हणून एका कौटुंबिक वातावरणाचं, त्याला विसरून चालणार नाही. प्रोफेशनल जेलसी अजिबात ठेवण्याचं कारण नाही. ज्याच्या कपाळावर जेवढं दिलेलं असतं तेवढं जरूर मिळतं, परंतु जॉईंट व्हेंचरचा जमाना आलेला आहे. सगळ्यांनी एकत्र यावं. मी आज या ठिकाणी जाहीर आवाहन करतो, IMAच्या अधिकृत व्यासपीठावरून. IMAचे प्रेसिडेंट आहेत, सेक्रेटरी आहेत, क्लिनिकल सेक्रेटरी आहेत आणि सगळे ज्येष्ठ लोक आहेत, मीडियम रेंजमधले लोक आहेत, मध्यम फळीमधले आणि ज्युनियर आहेत. ज्यांना कुणाला कुठलंही जॉईंट व्हेंचर करण्याची इच्छा, मी त्या हॉस्पिटलला कुठलं तरी नाव द्यायचं म्हणून माझं नाव दिलं. 2-4 वर्षात मी असं करेल की त्याला वेगळंच काहीतरी नाव देऊन टाकेल. नावासाठी मी ते केलेलं नाही, परंतु काही गोष्टी कॉर्पोरेट कंपन्यांमध्ये कराव्या लागतात म्हणून मी ते केलेलं आहे. हे माझं हॉस्पिटल नसून हे आपलं हॉस्पिटल आहे, याचा तुम्ही अनुभव घ्या. फॉर एक्झाम्पल, मी आता मगर सरांना बोलत होतो, उमनवारांना तुम्ही हक्काने बोलू शकतो की तुम्ही गायनिकची टीम उभी करा, गायनिकच्या लोकांना एकत्र आणा, त्यांचा MOU करा, काय तुम्हाला फायनान्शियल टर्म्स करायच्यात त्या करा. मी फक्त तिथं सही करेल, मी त्याच्यामध्ये इंटरॅक्शन पण करणार नाही. पेडियाट्रिकचं युनिट सागर मोरेने उभं करावं. तुमच्या प्रॅक्टिसला धक्का न लागता, ज्या पेशंट्सला आपल्याला इथं करायचं नाही किंवा आपल्याला टाइम इफेक्टिव्ह नाहीये, कॉस्ट इफेक्टिव्ह नाहीये किंवा स्ट्रेस इफेक्टिव्ह नाहीये, की हा पेशंट आपण करू शकतो पण न्यूसन्स क्रिएटिंग माणसाचा आहे, पैसे न देणार आहे किंवा कॉम्प्लिकेशन होऊ शकतो, जॉईंट व्हेंचरमध्ये स्ट्रेस शोल्डर करण्याची गरज आहे, तो माप तुम्ही फक्त तिथं करा. कन्व्हेन्शनल जे सगळ्या तुमच्या प्रॅक्टिसेस आहेत त्याच्याकडे तुम्हाला दुर्लक्ष करण्याची गरज नाही किंवा ही इन्सिक्युरिटी पण वाटण्याची गरज नाही की मी जर तिथं ऑपरेट केलं तर माझा पेशंट तिथं जाईल, कारण तिथले पण बोर्ड ऑफ डायरेक्टर्स, अकॅडमिक डायरेक्टर्स तुम्हीच असणार. तर असे विविध टीम आपण तयार करू. डॉक्टर अजिंक्य पाटील आणि डॉक्टर राजू राठोड गेल्या 3 वर्षापासून ऑपरेट करतायत. त्यांनी न्यूरोलॉजी क्लिनिक करावं. प्रवीण पाटील ऑपरेट करतायत, अनेराव ऑपरेट करतायत, अनेक ऑर्थोपेडिक सर्जन ऑपरेट करतायत, विलासचे पेशंट्स असतात, सगळ्याच ऑर्थोपेडिशियनचे असतात. त्यांनी डॉक्टर अभितेश सोबत करून जॉईंट रिप्लेसमेंटचा पूर्ण शेड्यूल तयार करावा. गायनेकोलॉजिस्टमध्ये आहुजा सर आज आलेले दिसत नाहीत, पण उमरवार सर आहेत, आहुजा आहेत, मगर सर आहे, प्रसाद आहे, सगळेच गायनेकोलॉजिस्ट आहेत. त्यांनी IVFचं युनिट ॲडव्हान्समध्ये कसं करायचं करावं. मी कॅपिटल इन्व्हेस्टमेंट करेल, मी तुम्हाला मॅनपॉवर देईल, मी तुम्हाला ॲडमिनिस्ट्रेटिव्ह मॅनपॉवर देईल, मी तुम्हाला ॲडमिनिस्ट्रेशन मार्केटिंग पूर्ण जिल्ह्यामध्ये नव्हे महाराष्ट्रात करून देईल. आपल्या हॉस्पिटलची इमेज जी आहे वस्तुस्थिती, सीइंग इज बिलिव्हिंग, ती लोकांना दाखवेल. ऑक्टोबर महिन्यामध्ये एक पूर्ण मराठवाड्याची मोठी कॉन्फरन्स 2 दिवसाची घेईल की जेणेकरून मराठवाड्यातल्या सगळ्या हॉस्पिटलमधले CEO आणि सगळ्या हॉस्पिटलमध्ये टॉप फॅकल्टीज ह्या परभणी शहरामध्ये येऊन त्यांनी ते हॉस्पिटल पाहिलं पाहिजे आणि शहरामधलं वातावरण कसे इथे लोक प्रॅक्टिस करतात असा एक आदर्श महाराष्ट्रामध्ये नेऊन दिला पाहिजे. आणि असा जर आदर्श ठेवला तर सामाजिक जे काही एलिमेंट्स आहेत की जे न्यूसन्स क्रिएट करतात त्यांना वाव मिळणार नाही. आणि हे निश्चितच आपल्या सर्वांच्या हातात आहे, कारण या सगळ्या सिनियर लोकांनी ती संस्कृती आमच्यापर्यंत आणून पोहोचवलेली आहे. ती संस्कृती तुमच्या नवीन पिढीपर्यंत पोहोचवण्याचं नैतिक कर्तव्य आमचं आहे. आणि IMAच्या व्यासपीठावरून मी ही आज सर्वांना कळकळती विनंती करतो की परभणी शहराची प्रॅक्टिस ही एक कौटुंबिक प्रॅक्टिस म्हणून आपण आजपासून सुरुवात करूया. ऑलरेडी आपण ती केलेली आहे आणि त्यासाठी आपल्या कुटुंबाचं एक हॉस्पिटल आहे जिथं 350 बेड आहेत, 7 ऑपरेशन थिएटर्स आहेत, वाटेल त्या सुविधा आहेत, कम्प्लिटली क्वालिफाईड स्टाफ आहे. आणि सुदैवाने माझा डेंटल कॉलेजचा जवळ 25चा स्टाफ हा MBA झालेला आहे. या मुली तुम्हाला दिसतात त्या MDS आहेत, पण त्या सगळ्या MBA झालेल्या आहेत हॉस्पिटल ॲडमिनिस्ट्रेशनमध्ये. मीही टाटा इन्स्टिट्यूट ऑफ सोशल सायन्समध्ये मागच्या वर्षी MBA पदवी घेऊन आलो. तिथं मी राहायचो, महिनाभर माझे क्लासेस होते. सकाळी 7ला आमचे क्लासेस सुरू व्हायचे, रात्री 11ला संपायचे. वेगळ्या पॅटर्नमध्ये ते सगळं कोर्स चालतो. मी तिथं स्वतः तो करून आलो. त्यामुळं हॉस्पिटल इंडस्ट्री पुढच्या 10 वर्षात, पुढच्या 20 वर्षात, पुढच्या 40 वर्षात कुठं जाणार आहे याचं भान ठेवूनच आपल्या पुढच्या पिढीला आपल्याला लॉन्च करावं लागणार आहे. नसता पुढची पिढी ही हॉस्पिटलचा एन्जॉय करण्यापेक्षा तो स्ट्रेस घेऊन बसेल आणि त्या स्ट्रेसची किंमत केवळ आपल्यालाच चुकवावी लागते. कुठलाही टॅक्स दुसरा भरू शकतो, पण आपल्या स्ट्रेसचा टॅक्स आपल्या आयुष्यात आपल्याला भरावा लागतो. त्यामुळे स्ट्रेस शेअर करा. तुमचा फायनान्शियल गेन अजिबात शेअर होणार नाही, उलट तो मल्टिप्लाय होईल. त्यामुळे कॉर्पोरेट हॉस्पिटलच्या एका अमरेला खाली येऊन आपल्या हे सगळ्या कुटुंबाचं हॉस्पिटल आहे या स्पिरिटने करा. हे करताना जर तुम्हाला कुठं वाटलं मनामध्ये खंत पैशाची किंवा कशाची, तर तुमच्या क्षेत्रातल्या डायरेक्टरला तुम्ही बोला. गायनिकचं असेल तुम्ही ओमनवारांना बोला, सरांना बोला, मगर सरांना, तुमच्या क्षेत्रातलं बोला. त्यांना पूर्ण अधिकार ॲज अ डायरेक्टर म्हणून मी देतो, कागदावर देतो, मोरली देतो, व्हर्बली देतो, प्रॅक्टिकली डे टू डे ऑपरेशन्समध्ये देतो. आणि याचा लाभ घ्या. आणि आपल्या इतर जिल्ह्यांपेक्षा आपल्याकडे एक सुंदर अपग्रेडेड इन्फ्रास्ट्रक्चर आहे. पुढच्या 25 वर्षामध्ये काय लागणार याचा विचार करून तयार केलेलं जे इन्फ्रास्ट्रक्चर आहे त्याचा आपल्या समाजाला उपयोग होऊ द्या आणि तुम्हालाही त्याच्यातून नाव, प्रसिद्धी आणि समाधान मिळू द्या. ही गजानन महाराजांच्या चरणी मी प्रार्थना व्यक्त करतो. आज इंडियन मेडिकल असोसिएशनच्या वतीनं हा जो कार्यक्रम झाला त्याला इतकं सगळे व्यस्त असतानाही सगळे लोक आले. मी सगळ्यांना फोन करू शकलो नाही, त्याची मला खंत होती, कारण कालच आमच्याकडे नवीन बॅचचं वेलकम फंक्शन झालं. सोमवारी आपल्याकडे आपण MDSला इन्क्रीज इन सीट जातोय, त्यामुळे त्याचं आपलं इन्स्पेक्शन आहे. त्यामुळे खूप माझा या आठवड्याचा कार्यक्रम हे आहे. आणि हळूहळू मी आता परभणीमध्ये 20 दिवस असतो, 5 दिवस मी औरंगाबादला असतो आणि 5 दिवस मी मुंबईला ऑफिस घर केलेलं आहे. मुंबईमध्ये पण आपण कॅम्पस डेव्हलप करत आहोत रायगड जिल्ह्यामध्ये. तर या सगळ्या वाटचालीमध्ये तुम्हा सर्वांचे आशीर्वाद आहेत, तुम्हा सर्वांचं पूर्ण योगदान आहे. आणि माझ्या प्रत्येक यशामध्ये माझा IMA, माझा परभणीचा डॉक्टर हा सिंहाचा वाटेकरी आहे. मग ते राजकीय क्षेत्र असो का सामाजिक क्षेत्र असो का माझं कॉर्पोरेट क्षेत्र असो का माझं डेंटल कॉलेज असो का माझं हॉटेल असो, यामध्ये भरभरून आशीर्वाद आणि प्रत्यक्ष योगदान हे माझ्या प्रत्येक डॉक्टर जातीचं आहे. त्यामुळे मी IMA पासून कधी दूर गेलो नाही. काळाच्या ओघात मुलींचे लग्न, मुलींचे नीट यामुळे मला काही कौटुंबिक जबाबदाऱ्या कराव्या लागतात आणि जेव्हा आपल्याला कार्यक्रम वाढवायचा असतो त्यावेळेला काही ठिकाणी नवीन ठिकाणी राहावं लागतं. त्यामुळे माझी नाळ ही परभणीशीच आहे. आपल्या सगळ्यांचा अंत परभणीतच होणार आहे. त्यामुळे ही आपली काळी माती आपण कधी विसरणार नाही. आणि सर्व डॉक्टर लोकांना माझं विनंती आहे की आपण हॉस्पिटल बघावं आणि हॉस्पिटलच्या बाबतीमध्ये आपापल्या डायरेक्टरशी संपर्क करून आपला MOU करून आपण काम सुरू करावं. माझ्या कुठल्याही परमिशनची किंवा माझ्याशी चर्चा करायची आवश्यकता नाही. असे सर्व अधिकार मी IMAला देऊन माझी जागा घेत आहे. धन्यवाद.
धन्यवाद सर. Now I would request Dr. Dattatray, respected Dr. Dattatray Magar sir. रिसेंटली त्यांना स्वर्णकन अवॉर्ड पण मिळालेला आहे आणि अशा व्यक्तीचे थॉट्स आपण सगळ्यांना ऐकायला नक्कीच आवडेल. तर मी सरांना विनंती करते की त्यांनी यावं आणि आपल्या सगळ्यांना 2 शब्द सांगावेत. थोडा चेंज, सॉरी. डॉक्टर ओमनवार सर, रिस्पेक्टेड डॉक्टर ओमनवार सर, प्लीज या आणि तुमचे थॉट्स शेअर करा आमच्या सगळ्यांसोबत.
आदरणीय मंच, उपस्थित सर्व माझे सहकारी मित्र, बंधू भगिनींना, मागच्या 2 वर्षाचा कोरोनाचा कठीण काळ संपल्यानंतर आपण आता रिसेंट ही फिजिकल CME चालू केलेली आहे. ऑनलाईन CME कोरोनाच्या काळामध्ये सर्वांनीच अटेंड केली आहे. पण आजची CME 9 लेक्चर पाहता ही मिनी कॉन्फरन्स म्हणायला काही हरकत नाही आणि उत्तम नियोजन आहे आणि बऱ्याच दिवसानंतर संधी मिळाली. एवढं झालं तरी आज उपस्थिती पाहता थोडी खंत वाटते की अशा CME होत असताना IMAच्या सर्व सदस्यांनी उपस्थित राहावं आणि त्याचा लाभ घ्यावा आणि आपलं कॉन्ट्रीब्यूट करावं. असो, CMEचा कार्यक्रम असल्यामुळे मी काही जास्त भाषण करणार नाही. ऑलरेडी सगळं झालेलं आहे. प्रफुल्ल पाटलांनी सर्व सांगितलेलं आहे. मी काही फक्त 2 ओळीमध्ये मी माझं मनोगत संपवतो. सगळ्यात पहिलं की परभणीमध्ये जन्म घेणाऱ्या माणसांनी मोठी स्वप्न बघू नये असं मला वाटतंय. पण हे चुकीचं आहे हे प्रफुल्ल पाटलांनी दाखवून दिलं. आणि जगात जर्मनी, भारतात परभणी हे सगळ्यांनाच माहिती आहे. पण त्या परभणीला सुधारण्यासाठी आपण काय केलं पाहिजे हा विचार कोणी करत नाही, तो प्रफुल्ल पाटलांनी केला. तिसरी गोष्ट की आपल्या सगळ्यांना माहिती आहे आपण आता मोबाईल यूज टू झालेलो आहोत. आणि मोबाईलच्या कंपनीमध्ये सगळ्यात आधी जर कोणती कंपनी असेल मोबाईलची आठवत असेल तर कोणी नाव सांगा. नोकिया. आणि आज ती कंपनी कुठंच नाहीये. म्हणजे ज्या कंपनीने पहिल्यांदा मोबाईल आणला, जी कंपनी ब्रँडेड म्हणून मोबाईलच्या नावानं प्रसिद्ध होती, जगभरामध्ये एवढूसा फिनलँड देश त्यात निर्मिती केलेली, त्या फिनलँडमध्ये मोबाईल कंपनीमध्ये नोकिया सारख्या कंपनीमध्ये भारतातले 72 लोक काम करत होते. म्हणजे भारतात टॅलेंटची कमी नाहीये. आणि ही कंपनी आज जर तुम्ही विचार केला तर कुठंच नाहीये. म्हणजे मोबाईलच्या जगतातून नोकियाचं नाव हद्दपार झालं असं म्हणलं तरी काही अतिशयोक्ती होणार नाही. पण जगात जर्मनी आणि भारतात परभणी ही जर म्हण काढून टाकायची असेल आणि परभणीचा नोकिया होऊ द्यायचा नसेल तर प्रफुल्ल पाटलांनी जे काम केलं ते करायला पाहिजे. म्हणजे परभणीचा नोकिया होऊ नये म्हणून मला आठवते मी एक दिवस गुरुवार होता, फॅमिलीचं जास्त सगळं लक्ष आहे किंवा श्रद्धा आहे पूर्ण गजानन महाराजावर. गुरुवारचा दिवस होता आणि सीझर होतं काहीतरी, आणि सीझर संपवलं आणि प्रफुल्लच्या कॅबिन मध्ये बसलो होतो आणि नेमकं सांगितलं की अशी अशी जमीन घेतलेली आहे आणि तिथं कॉलेज चालू करायचं आहे, डेंटल कॉलेज चालू करायचं आहे. म्हणजे एक तर पहिल्यांदा असा प्रश्न पडला की परभणीतले एवढे लोकप्रतिनिधी आलेत, पण ज्यांच्या डोक्यात हा विचार आला नाही तो विचार पहिल्यांदा प्रफुल्ल पाटीलच्या डोक्यात आला. आणि ते म्हणे बॉस आपल्याला जायचंय. स्कूटरवर मी आणि प्रफुल्ल पाटील आम्ही दोघं जण गेलो, महाराजांचा फोटो ठेवला, उदबत्ती लावली, नारळ फोडला. त्या दिवशी थोडं मनात आलं की एवढं मोठं स्वप्न आपण इथं पाहतो, खरंच जाईल का ते पूर्णत्वाला. पण ते छोटस लावलेलं रोप आज एवढा मोठा वटवृक्ष झाला. आणि डेव्हलपमेंट करायची असेल तर नुसते तुम्ही वल्गना करून चालत नाही. त्या अस्तित्वात आल्या पाहिजेत, ते अंमलात आल्या पाहिजेत, त्याच्यावर काम केलं पाहिजे आणि त्या पुढे कशा गेल्या पाहिजे ह्याच्यावर विचार करायला पाहिजे. म्हणून फक्त डेंटल कॉलेजवरच न थांबता प्रफुल्ल पाटलांनी मल्टी स्पेशालिटी हॉस्पिटल तयार केलं. आणि आज मला अभिमान आहे की मी परभणीमध्ये राहतो. आज 25 वर्षापेक्षा जास्त झालेत माझे परभणीमध्ये प्रॅक्टिस करून. ज्या पद्धतीनं परभणी डेव्हलप होते आहे, इंटेलेक्च्युअल लोकांनी जे पुढाकार घेऊन परभणी डेव्हलपमेंटमध्ये सहकार दाखवला आणि आपलं कर्तव्य त्याच्यामध्ये सिद्ध केलंय. बोंडे सुद्धा असेल, RT-PCR नांदेडमध्ये होत नाही पण परभणीत मध्ये होते, याच्यासाठी मला गर्व वाटला. म्हणजे हे जे नवीन आहे जनरेशन, आणि यांच्याकडून काही ना काहीतरी आपण घेतलं पाहिजे, त्यांच्याकडून मार्गदर्शन घेतलं पाहिजे. आणि त्यांनी जे उभं केलंय ते जपणं नाही, त्याला वाढ करा आणि त्यांना सपोर्ट करा. एवढे 2 शब्द सापून मी माझं काम. धन्यवाद.
थँक्यू व्हेरी मच सर. आता मी डॉक्टर कात्नेश्वरकर सरांना विनंती करते की त्यांनी आपले व्हॅल्युएबल थॉट्स शेअर करावेत आम्हा सगळं.
Respected dais and all my friends. Initially, I was feeling very awkward with this sports shirt. That is why I was trying to hide myself. But looking at the attitude of Praful Patil, audience and dais, you showed me the definition of sportsmanship. Now that fear has gone. The way we see the running status of every train in our life, if you Google and see the running status of medical profession, what it is rapidly progressing. It requires updation. The newcomers, that is super specialty, is coming very fast, which is a must, mandatory. We welcome all specialists, super specialists. We intend to update ourselves also. Try to interact with them and increase our knowledge to help the society. That's why the CME and the progress of doctor is meant for. to talk about Praful Patil, in one sentence, I would say extraordinary, versatile brilliance. Magar sir is backbone of our IMA and overall medical fraternity. I wish good luck for the CME and take my seat. Thank you very much.
थँक्यू सो मच सर. आता सगळ्यात सिनियर मोस्ट डॉक्टर दत्तात्रय मगर सर यांना मी विनंती करते की त्यांनी येऊन त्यांचे विचार मांडावेत, सर्वांना मार्गदर्शन करावं. रिसेंटली सरांना अवॉर्ड मिळालेला आहे, त्याबद्दल एक जोरदार टाळ्यांचा हे होऊन जाऊ द्या. थँक्यू.
प्रथम मी प्रफुल्ल पाटील, त्यांचे इन्स्टिट्यूट आणि त्यांचा सगळा स्टाफ त्यांनी हे अरेंज केले आणि IMA केलेलं ह्या गोष्टीला मी पहिला अभिनंदन करतो. आणि सगळ्या वक्तव्यावरून आपल्या लक्षात आलं की परभणीच्या प्रोग्रेसचं सगळ्यात जास्त श्रेय हे इथल्या डॉक्टर्स लोकांना आणि इंटेलेक्च्युअल लोकांना आहे. त्यामुळं त्या पद्धतीने आपण जसं म्हणतो ना, प्रफुल्लनी जे सांगितलं त्याच्यामध्ये की विवेकानंदांनी एकदा म्हटले होते की मी अमेरिकेमध्ये एका गोष्टीच्या प्रेमात पडलोय आणि ते म्हणजे त्यांचं कमिंग टुगेदर, एकत्र येऊन काम करणं. हा कमिंग टुगेदर आहे पहिली गोष्ट, त्याच्यानंतर वर्किंग टुगेदर आणि त्याच्यानंतर वॉकिंग आणि रनिंग टुगेदर. ह्या तिन्ही चारही गोष्टी जर आपण एकत्र केल्या तर बऱ्याच काही गोष्टी करू शकतो. त्यामुळे आपल्या परभणीमध्ये त्यांनी जे सजेशन केलेलं आहे आपण एकत्र येऊन त्या पद्धतीने काम करू. आपलं कॉपरेशन आहेच, पण त्याच पद्धतीने एकत्र येऊन काम केलं तर अजून जास्त प्रकारचं तसं केलेलं आहे. मोरेश्वरांनी डॉक्टर वडसकर इथे येऊन त्यांनी सुरू केलं, त्याच्यामध्ये सर्जन्स वगैरे एकत्र झालेत. त्याच पद्धतीने आपण ह्या हॉस्पिटलच्या मध्ये जे जे काही फॅसिलिटी अवेलेबल करू त्या पद्धतीने आपण ते काम करूया. मला एक खूप छानपैकी ह्या प्रसंगी हे आठवतं की स्टार्ट फ्रॉम व्हेअर यू आर with whatever you have, make something out of it and never be satisfied. कारण आपल्याला हे कारवारचं वाक्य आहे आणि तो म्हणतो की आपल्या ह्या चांगल्या कामामध्ये वी शुड बी नेवर बी सॅटिस्फाईड. काय शेवटी काय काय घेता येईल असं आपल्याला करणं जरुरी आहे. त्याच्यामध्ये इंडियन माणूस असं आहे की आपण जर नासामध्ये गेलो तर नासामध्ये तिथे एक पिक्चर आहे नासाच्या त्या याच्यामध्ये, त्या पिक्चरमध्ये सगळे इंडियन चेहरे दिसतात. त्या काळामध्ये त्या लोकांनी ग्रहाचं अंतर्ग्रहावर कसं युद्ध करता येईल याचे पिक्चर आहे त्याच्यामध्ये. त्यामुळे ह्या देशामधले अशी लोक आहेत की इतकी दूरदृष्टी ठेवणारे, म्हणजे गर्भसंहितेमध्ये जे आपण गरुड पुराण वाचतो त्याच्यामध्ये एम्ब्रियोलॉजी पासून ते माणूस कसं तयार होतो याच्यापासून जे सुरू केलेलं आहे त्या सगळ्या गोष्टी या देशाच्या ब्रेनमध्ये आहेत. त्या फक्त वी हॅव टू गेट इट आउट. मग एज्युकेशन असं म्हणतात की इट इज ड्रॉ आउट, बाहेर काय काढायचं ते महत्त्वाचा भाग आहे त्याच्यामध्ये. आणि त्यासाठी आपण सगळे झटूया. ह्या CMEला आणि IMAच्या एकंदरीत ह्या सगळ्यांना शुभेच्छा व्यक्त करून माझे 2 शब्द संपवतो.
धन्यवाद. आता आपणा सर्वांची परमिशन घेऊन आपण पुढील फर्स्ट सेशन स्टार्ट करूया. त्यासाठी मी डॉक्टर पल्लवी दोडके यांना अँकरिंगसाठी बोलवते. पवन सर, आनंद सर, अजून कोण आहेत आपले आलेले? वैद्य मदतीला या बरोबर. त्यांना मदत करा थोडंसं चॅरिंग. पैकी कोण?
स्पीकर आहेत डॉक्टर केतकी पाटील मस्के मॅम. त्यासाठी मी आपले आजचे चेअरपर्सन डॉक्टर ओमनवार सर, डॉक्टर दत्तात्रय मगर सर आणि डॉक्टर प्रसाद मगर सर यांना स्टेजवर स्थानापन्न होण्यासाठी विनंती करते. आजचे आपले पहिले स्पीकर डॉक्टर केतकी मस्के मॅडम. यांच्याबद्दल मी थोडीशी माहिती देते. शी हॅज डन MBBS, DGO and MS. She had pursued her higher studies in MSc Embryology from Ireland. She specializes in advances in IVF. अशा हुशार आणि सुंदर डॉक्टर केतकी मस्के मॅडमला मी त्यांच्याजवळ असलेलं अमूल्य ज्ञान आमच्या सोबत शेअर करण्यासाठी आमच्या सर्वांतर्फे विनंती करते.
Those who have joined online through GD Shield app, all your questions are requested. Those were taken after the completion of the talk. Thank you.
Pointer. Pointer is not. Lights off करू शकतो.
Okay, good morning to everyone. I'm Dr. Ketki. Thank you for the fine introduction. At the outset, I would like to thank IMA, Parbhani, and Dr. Praful Patil sir, Dr. Vidya madam, IMA president, for giving me an opportunity to speak with you here about recent advances in IVF and ICSI. And just sorry, excuse my voice, माझा आवाज बसला है, घसा बसला है, but I will try to do my best. So I'm a consultant obstetrician and gynecologist and an infertility specialist. I'm practicing in Lifeline IVF Center in Panvel. Ours is a 3,000 square feet state-of-art facility with all the latest equipment for IVF, and it's been in place for the last 25 years. Coming to my topic, let's talk about ART before I go to IVF and ICSI. I would say assisted reproductive techniques is what is needed in this era. But what are the types of ART is would be ovulation induction and planned relations, which most of the gynecologists might be practicing in Parbhani, and rather in all the smaller places, bigger places, every gynecologist practices ovulation induction and planned relations. IUI has become much common these days. IVF, ICSI, IMSI, and embryo biopsy. These are the assisted reproductive techniques. Who needs these? Healthy couples. Who needs ART? Healthy couples who are staying together for at least 1 to 2 years and having a regular intercourse for about 2 to 3 times a week. People with male factor infertility, a female factor infertility, and people fertility preservation for cancer patients who want to preserve their fertility before they start their radiotherapy or chemotherapy. And nowadays, same-sex couples are also opting for ART. So moving on to ICSI and IVF. When do we need IVF? Am I audible? Am I clear? Okay. Okay. So when do we need IVF and ICSI in a couple? Mainly female and male infertility. Female infertility, most common cause in the Indian scenario is bilateral fallopian tubes are blocked. Long-standing infertility is very less, but in the metros, it is growing because of career preferences. People are trying to conceive later in their life, but in smaller places, you wouldn't see that. People start conceiving straight away once they get married. So long-standing infertility, more than 35 years of age in a female, poor ovarian reserve, low AMH, where they go into primary ovarian failures, recurrent pregnancy loss, these people would go for IVF and ICSI. Abdominal tuberculosis, which is another most common cause in India for causing infertility, and psychosexual problems like vaginismus, which we are coming across more frequently than ever before. In males, obviously, oligospermia of more than less than 15 million sperms, asthenospermia, where the motility of these sperms is less than 40%, teratospermia, where more than 4% of the sperms are abnormal. A combination of all the three of them is OAT, which is oligo, astheno, and teratospermia. In men, the psychosexual problems, erectile dysfunction, premature ejaculation have increased. When I see 10 couples in my clinic for infertility, 6 of them are due to male infertility. Women have become more aware of their fertility these days because of probably social media, or they are more aware of their menstrual cycle. They look at it when they turn 18 or once they get their menarche. Their mothers are more proactive and they look at them. But male infertility remains undiagnosed till the couple comes to you for conception. So which has become a major problem these days as compared to female infertility. So what is IVF and what is, just in a nutshell, what we do in IVF is ovarian hyperstimulation, which leads to on day 14 of the periods of the female, we take the eggs through a transvaginal sonography. We remove the oocytes from the ovaries. We prepare the semen of the man, of the male partner. 2 things. Sometimes we co-incubate the oocytes and the sperm together to produce embryos, that is IVF. And in ICSI, which is done more frequently these days, that is we take the oocytes and inject every oocyte with a sperm using a huge microscope called a micromanipulator. And after that, after ICSI, on day 18 to day 21st, we have well-formed embryos, which are about day 3 or day 5 embryos, which are transferred into the women's uterus. After 21 days, we do their tests to see if they're pregnant or not. This is just the basic gist of IVF. What has changed? I'm supposed to talk about recent advances. What has changed? Stimulation protocol, that is where we start inducing more. How do I get more number of eggs from this female? We started with urinary hormones, which were derived from menopausal urine of older women, which moved to highly purified hormones. And now they have moved to recombinant FSH. What is the cost and what is the success rate when you're going up the ladder? Urinary costs are high. Of course, IVF in general is a expensive therapy. So if you go for cost, it is high. Success rates are good with urinary, highly purified. The cost is a little higher, but success rates are definitely higher. And if you go up the ladder, that is to recombinant FSH, when I was in Ireland and when I was in UK for the last 10 years, I was working in a private fertility clinic for 4 years. There, we only use recombinant FSH because it was a norm. But in India, it is 3 times more expensive than highly purified FSH. So but the cost is very high and the success rates are comparable. I wouldn't say that they give you extremely good success rates if you use recombinant FSH. Coming to male infertility, TESA, that is testicular sperm extraction, is what we usually perform for males. PESA is percutaneous epididymal sperm aspiration. Microtesse, it is under a microscopic guidance. We extract sperm from the testes. These are in patients with oligospermia. The focus of treating male infertility has shifted completely from the male to the female because of the advent of ICSI. ICSI has changed everything about male infertility, that if we get around 5 sperms and 5 oocytes, we are happy and we get our embryos and we get good success rate. So the whole focus of oligospermia, asthenospermia has gone down. All we need is just a few sperm to produce embryos. So IVF and ICSI, traditional IVF, traditionally that was 20 years back. No, I hardly know anyone who does IVF. Some countries in the UK, some countries in the Europe still do IVF, but it doesn't give you as much success rate. So transvaginally, we take the oocytes and they're co-incubated with the sperm. So you get an oocyte, get a sperm, put them together and let the sperm enter the egg on its own. But the success rates are hardly 20%. Then came up ICSI, which is intracytoplasmic sperm injection, which was discovered by mistake in 1991 in Singapore. And it diverted all the attention. It just completely cured male infertility. The success rate has jumped up significantly because of that. What do we do in ICSI? Oh. Video nahi play honar. मला video आहे हा play होईल का? It changes the slide. Oh yes, good. So you can see here, okay, it's not playing in my this. So if you see here, this is under a micromanipulator, a huge micromanipulator. The round is the oocyte. You can see a small tiny sperm in the other pipette. A large pipette is holding with a small suction the oocyte, and you can see the sperm is injected slowly into the oocyte. And this is ICSI. This is where fertilization takes place. A little bit of an aspiration in the needle and then leave the sperm inside the cytoplasm of the oocyte, which makes things more accurate in having better embryo quality. I think it stopped. It's okay. I'll move to IMSI. So this was ICSI and IVF. Now, as you see in the previous slide, the size of the oocyte was huge. You could actually appreciate every part of it. You could see the polar body. But when you look at the sperm, it was very tiny because that was just under 200 to 400 magnification. So somewhere we couldn't see the sperms which we are injecting into the oocyte. To judge the quality of the sperm, we had to magnify the sperms somewhere to get good sperms and good eggs and then good embryos. So in patients with oligo, astheno, teratospermia, where oligo means very less sperms, astheno is where the motility of these sperms is bad, and terato is where they have anomalies. If you see the structure of a sperm, sometimes it's a double-headed sperm, which is an abnormal sperm. It has two tails, that is another abnormal sperm. So we had to identify if there are any defects in these sperms. So this is the magnification which we get for sperms. And here we could really appreciate if there are any vacuoles, if there are two tails, if the body is the midpiece, if we say the midpiece is affected, the cytoplasm is affected, all these things could be noticed in IMSI. And so it does definitely improve when we do an IMSI, select the proper sperm and then do an ICSI and inject it into the oocyte, we get better embryos, better quality embryos. How successful is it? Yes, it is definitely very successful in patients with oligo astenospermia, but not with every patient. A patient with a good count does not need MC. A good count and a good motility with hardly any teratospermia, less than 4%, you don't need to go for ICSI. This is only in selected patient. It gives very good results. Coming to another improvement which we are looking forward in our center also, that is a time-lapse imaging, where it is an incubator. When we make, so after ICSI, we made our embryos. Where do we store them? We store them in an incubator. Every time, so traditionally what we do is we go on day 2, open up the incubator, take them out, put it under the microscope, have a look, have they fertilized? What is the stage? Is it a day 3 embryo? Is it a day 5 embryo? How are they growing? But this is this incubator has automated photographic image collection, which is usually every 5 to 20 minutes. And that gives you a real-time image of the embryo, how it is growing. So what you can keep and so helps you score the embryos without taking them out of the incubator, exposing them to the environment, to the AC in your lab, to the other environmental pollutants, and also helps in selecting the embryo which develops at a right pace. So slow and steady, which develops in proper fission. So I'll show you in my next video. So this is a beautiful video of time lapse, where you can see right from fertilization to 2PN and how they split. So all these recordings are for around 5 days. And the 5th day, you can see how beautiful a blastocyst is formed. It will come shortly. And when you know that the embryo is growing really well in the incubator for the last 5 days, you can expect it to be growing well in the mother's womb also and give you better pregnancy rates. So you can see the fission, the splitting of the cells, reaching a morula stage. And we could always notice, where did it stop? Why did it stop? So in the next cycle, if you're planning, you can always stop. If the embryo stops growing on day 4, you can always transfer it on day 3. And this is a beautiful blastocyst, which we can transfer, which is a day 5 embryo, which gives you very good results. The next would be laser-assisted hatching. It has been there for quite some time. Laser was used for hatching. Like if you see in the first picture, that is an embryo which is hatching out of its zona. Zona is a thick layer outside the embryo. After it is formed a blastocyst, it hatches and then it attaches to the uterine cavity. So with laser, we make, when the outside thickness is more than around 17 microns, we try to reduce it so that its hatching becomes difficult. It's just basically when you try to crack an egg, and if you give it a hit, crack is there, it hatches easily. So where does this zona, this doesn't need to be done in every patient. Patients only who have had frozen cycles where the thawing has hardened the zona, So if you freeze these embryos and again thaw them and ask them, try to move them, put them into someone's uterus, the hatching does not take place that easily. So that's when this help is needed. Patients whose oocytes who are more than 35 years old, their zonas are thick, where again they need this kind of help. The laser punctures which are made thin out the zona up to 0.5 to 1 micron, and that helps in hatching. So better implantation rates and better pregnancy rates, it is controversial. Recent studies show not every time laser assisted hatching has given you consistent rates. Rather, sometimes laser has not been as good. So people are slowly moving away from laser assisted hatching. Pre-implantation genetic screening and pre-PGD. So pre-implantation genetic screening is where we do a trophoectoderm biopsy. So if you look at that, that is an embryo, that is a blastocyst embryo, where the thicker part, it suggests, and there is a thinner outer rim. The thinner outer rim is the trophoectoderm. Trophoectoderm is responsible for the formation of placenta. So taking a few cells from the trophoectoderm does not affect the growing embryo, which has been a big misconception that if you do PGD or PGS, you're taking cells from the embryo, the baby which is formed might not grow that well, is a complete misconception. So you just take 5 to 6 cells. I'll play this video for you. So again, in the same micromanipulator, the embryo is placed with a tiny suction on the left-hand side pipette. And a hatching embryo, you could always take 5 to 6 cells from the trophoectoderm, and you can subject it to next generation sequencing, where you get whether it is a 46XX or a 46XY. All we could do in India right now is only 46. There is no XY, nothing. You don't get any idea about the gender. It's only if you have any trisomy or aneuploidies, which will be detected. But it has helped many couples in getting pregnant. So there, this is how we pull it out. It is a very mechanical process. It is nothing chemical. It is actually pulled out, as you see here. This is in a higher magnification. And the cells are cultured to see if they are euploid embryos or not. So if I have about 8 embryos with me, and if I subject each embryo for an embryo biopsy, I could get only 2 or 3 euploid embryos. The rest of them are not euploid. So that is how, even if we make 8 embryos and still you did not get a pregnancy, because not all embryos are euploids, that is 46XY or XS. Most of them are trisomies or aneuploids. So either they're 41, 42 abnormal chromosomes. So that's why IVF is not successful with every cycle. So the success rates go down because they are not euploid embryos every time. Embryo biopsy, this is a case study which I would like to discuss, where we had performed biopsy for this young couple who was married for 4 years, a history of first-degree consanguineous marriage, and they were both healthy, male and female, but they had a history of repeated miscarriages. The last miscarriage reported trisomy 18 in their last miscarriage. So the plan of action for them was for ICSI followed by a trophoectoderm biopsy. We got around 8 embryos, but out of them only 246. I couldn't disclose so it is written QQ. Only 2 good euploid embryos were found. We transferred them and the patient delivered a healthy baby boy last month. So such patients, it is very helpful. Another similar case of a non-consanguineous marriage where the female and male both were around 34 years old, married for 6 years, history of 4 miscarriages. They were suggested just IVF, and they did IVF for 2 cycles. ICSI was done, but no pregnancy in both these. Not even a pregnancy. Forget about miscarriage, not even a pregnancy. But then an ICSI was planned with a day 5 trophoectoderm biopsy. We identified 4 euploid embryos, transferred 2 in the first cycle, and the patient delivered a healthy baby girl. So when it is done, embryo biopsy is done in indicated patients, especially patients with repeated IVF failures, miscarriages, it makes a huge difference in the results. Though you pay a little extra for that, it is expensive. I wouldn't say it is not expensive. It is expensive, but undergoing multiple cycles of IVF and not getting results is always better that you go for an IVF, go for an ICSI cycle, biopsy, and you get firm results what is going to happen, because there was no problem in this patient to conceive. She was having conception, so there was no implantation problem. It was just the problem with the embryos. So we have to detect where is the problem and then solve that. Cryopreservation, this we do routinely and we have been doing for the last 15 years now in our center. Cryopreservation, where when we get about 8 to 8 embryos or maybe 6 embryos, we split them into 2 parts, about 3 to 4 in one and another 2 in another one, another 2 in another one. So 2 to 3, as Dr. Praful Patil sir said, that we divide it and we give the couple multiple embryo transfer cycles. So if we give them the stimulation is at the age of 32, but till the age of 34 and the next 2 years, she can utilize her embryos at any stage. So even when she's 34 and we're transferring embryos, the embryo quality is of a 32-year-old, which is very good. And that gives you better results. Some patients have actually had a baby in the first attempt. They've come back to us after 2 years where we have cryopreserved their embryos, and they have landed up with a second baby in 2 years time without any expenses, without any hyperstimulation of the ovaries, no more undergoing the same injections and the whole cycle of IVF, just ready embryos transferred into the uterus. So it does improve your success rate when you get multiple attempts to transfer embryos. So this had to come right at the start, but pre-IVF hysteroscopy is one thing which we do in all of our patients as a thumb rule, where if you always have to look at the uterus before forming any embryos. What is the size of the uterus? How is the uterus? Are there any adhesions, any septums, any fibroids, any polyps? Everything. So this is just a quick video of septum and how we hysteroscopically, usually we do scratching of the uterus and simultaneously take off the septums. So this was a small band at the cornu, and this is a huge septum in between the 2 ostia, which was with micro scissors and an operative hysteroscope. We just give it cuts and leave it there. We leave a 14 gauge Foley's catheter in the uterus for the next 8 days so that it does not stick back again. After 8 days, the patient is called, has put on oral contraceptive pills so that she doesn't bleed. And after a month, when she gets her periods, we put her in for IVF. So this mainly improves your pregnancy rates. It decreases your miscarriage rate and preterm birth rate. This is one addition to the hysteroscopic. So patients in India, the tuberculosis and thin endometrium, scanty menses is a huge problem where implantation failure does occur. So in patients with scanty menses and thin endometrium, we subject them to PRP, which is platelet-rich plasma, where we take the patient's blood, centrifuge it, take the buffy coat, which has cytokines and VEGF, which is a good endothelial growth factor, and it is injected subendometrially with hysteroscopy to have a better endometrium. After a PRP, hysteroscopic subendometrial PRP, the next cycle, the patient comes to us with she's like, I usually bleed for 2 days, but this time I bled for 3 to 4 days. And how is that possible? That is possible because of PRP. PRP has been used for skin treatments, has been used for hair transplant, has been used for multiple, even in joints, people use PRP. So we did try it on thin endometrium patients, and it has worked wonders. Donor cycles has been in, especially with higher age group women with low AMH. We have been using donor eggs, donor sperms. donor embryos, which is called snowflake donation, where I have, suppose I've had a patient who has had 2 babies and her embryos are remaining. They would like to donate it to people. So instead of adopting a child, we say you adopt an embryo, and we give a complete embryo to a couple who has less affordability. So they don't have to go through all the injections and the procedures of IVF. The cost is also low. The cost comes to less than half when we go for donor IVF. So that is economy IVF. It was started off with by my own dad in I think 20 years back. Whenever he had extra embryos, he used to work in a small rural area where people could not afford IVF. And that's when he started economy IVF, where wherever all the extra embryos with the patient's consent were given off to other unaffording couples, and they have conceived because of that. So in the society, all the female had to face was, I have delivered the baby. It doesn't matter if the genetics are from someone else. So that did help, and that is still helping. So many people from all over Maharashtra come down to Panvel to us just for donor embryos. And people have been kind. Couples who have had their own cycles and who have had their babies, they have been really kind to give away those embryos. Okay, fine, we don't matter, we don't mind, just don't tell us whom have you given them, and that's good enough. Other advanced techniques, the last slide, I'm taking too long. The last slide is mitochondrial donation, not available in India right now, but we used to do it in Oxford, where it's called three-parent IVF, where the mother's mitochondria, the oocytes mitochondria, is affecting the formation of a good embryo. So it's called three-parent IVF. We take a cytoplasm of another woman, and the spindle is from another, and there is a sperm. So that's called a three-parent. Ovarian tissue cryopreservation is coming up in India now, where patients who go for this happens for oncofertility, where patients who want to go for radiotherapy or chemotherapy, we take small strips of their ovarian tissue and we preserve it like we preserve our embryos. We cryo-freeze it. Once the patient is cancer-free, we get those tissues out, we re-implant it or stitch it back to the ovary, and we have stimulated these patients and have got healthy babies out of them. But this has happened in Oxford when I was training over there. We haven't seen anything in India yet. Endometrial receptive array, another very expensive test. It is just to determine when do you transfer the embryo. So it's a 40,000-45,000 rupees test in India, where it will just tell you when do you transfer the embryo to the womb so that you get better fertility rates. Not much of it hasn't been used as much in our practice. Mitochondrial DNA content, again, as I explained, three-parent IVF and uterine transplant. So the first uterine transplant in India has taken place. It has been taken with Dr. Shailesh Puntambekar sir, and it was a huge success. With the new ART bill, where donor embryos, donor sperm, and surrogacy has stopped, patients are left with no option other than a uterine transplant, where uterine transplant will make a huge comeback because it has stopped now. But it is a cumbersome process and it is an expensive process to go through all over. People would prefer adoption to uterine transplant, but some people who really want to have a child from their own tummy would go for uterine transplant. And that's quite it. Thank you so much. I hope I have been clear enough, and I would like to take any more questions.
Thank you, Ketki madam.
Thank you, sir.
What
Thank
a
you so
nice
much, sir.
presentation in advances in IVF. I think this is good presentation and easy for understanding for everyone. Take home message is very clear. And
Thank you.
again, thanks for finishing your talk within a time. Already we are high.
Yes,
Time.
thank you, sir.
So I think anybody has got question, it is better to discuss during lunch
During
time.
the break. Yes.
I think it is better. So because it is high time to finish the all lectures. Thank you.
Thank you, sir. Thank you.
Just one question.
Yes, sir. Of course, of course.
Yeah. You said if PGD is normal,
Mhm.
then what are your implantation rates?
Yeah. Implantation rates
Yeah.
or take home baby rate.
Yeah, and also take home baby rates.
I would say so implantation rates still depend, even if PGD is normal and all the other factors are normal, I would say it is 40 to 50%. And that to a female under 35.
And as you are talking about advances,
Yes.
are there any advances of screening the genetic material in sperm?
Screening DNA fragmentation test is
Yeah,
there.
that's a indirect, that's an indirect test.
That's a very indirect
But
test.
that doesn't tell you that whether this sperm is abnormal or normal or giving good embryo.
Not that I know of, or which we practice in our clinic or any other.
So only
clinic for
we
that
are
matter.
phenotypically screening.
Phenotypically, yes. And DNA fragmentation does help because we do a DNA fragmentation for every semen analysis we do. So if it is fragmented, I know my embryos are not going to be good right at the start. So it is worth it. It is a 3,000 rupee test, but I know that I can give my patient a realistic value that this is how your embryos will be formed. And would you need a donor or not right in advance?
Thank you. Thank you.
Thank you.
Just extended.
Yes, yes.
Is it possible that you can use any other DNA material rather than sperm material, whether the science has reached up to that stage, a DNA material of any other cell of the male rather than sperm material? Is it experimental?
So that goes into cloning processes, but it is not approved anywhere around the world. Not yet.
Not in
yet.
Europe also.
Not in Europe. No. That is all under experimental. Even the mitochondrial has been approved just 2 years back, where the mitochondria was affecting the child, and there was a certain disease which was passed down because of the mother's mitochondria. So that exchange has just been approved, but clinically approval we are not getting for anything.
Ectogenesis also is not approved yet.
No, not yet. No designer baby.
Approved in the world, no? At least some places.
It is there in the animal models. It is there in the animal models, but
Okay.
not
in human
not
models.
in human models.
Anywhere
Not
in the world.
approved.
Okay.
Not
Thank you.
approved yet.
Thank you.
What is your experience? Did you have any genetic error despite the screening in your ICSIs or say another procedures?
Despite screening, so after screening, these are usually euploid embryos. So we know that they're not going to have any chromosomal anomaly at all. Developmental anomalies are possible, but we haven't faced any because embryo biopsies are done in very few patients. The affordability. Just for chromosomal anomalies. Yes. For now, we're there. That's it. Thank you very much. Thank you, chairpersons.
मी डॉक्टर दत्तात्रय मगर सरांना विनंती करते, त्यांनी आपल्या पहिल्या स्पीकरचे आपलं सन्मान चिन्ह देऊन त्यांना फेलिसिटेशन करावे. मी डॉक्टर विजय बोंडे सरांना विनंती करते, त्यांनी आताचे चेअरपर्सन डॉक्टर दत्तात्रय मगर सर, डॉक्टर ओमनवार सर आणि डॉक्टर प्रसाद मगर सर यांचं फेलिसिटेशन करावे. ह्या सेशनचे आजचे दुसरे स्पीकर आहेत डॉक्टर अभितेज मस्के सर. He is a renowned joint replacement surgeon. He has done MS Ortho, FRCS. He is a fellow of European Board of Orthopedics. He has also achieved a fellowship in primary and revision joint replacement. And he is currently working at Lifeline Hospital, Panvel. मी डॉक्टर अभितेश सरांना विनंती करते. हो. आणि आत्ताच्या सेशनचे चेअरपर्सन डॉक्टर प्रवीण पाटील सर, डॉक्टर निलेश पवार सर, डॉक्टर विलास देशमुख सर यांना मी विनंती करते, त्यांनी स्टेज डायसवर येण्याची विनंती करते.
Hello, 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 hello.
मिळेल का? ते येतच नाही. Good morning, everyone. Good morning, everyone. I'm myself, Dr. Abhidesh Maske, and I thank IMA Parbhani and Dr. Praful Patil Hospital, Dr. Vidya Patil ma'am, for inviting me for this talk on joint replacement and its advances. After a kind of interesting session with all the micro things, now we go to the real things, which is orthopedics with hammers and saw. So I'll just quickly introduce about myself, although I've been given a nice introduction. So I have been in UK and Ireland for the last 10 years, and recently in 2020, I came back to India. So on the top left over there, I'm with the two consultants, John O'Byrne and Professor Keogh. So these are the two very good knee replacement and revision surgeons, best of the Ireland. And below in this photo, I'm with Mr. Niall Hogan. So an interesting thing about him, he's another good knee surgeon. But apart from being a surgeon, he was the captain of the national rugby team. So after his MBBS, he chose rugby, was captain of the national Irish rugby team, and then chose orthopedics. And after retiring from rugby, became an orthopedic consultant. So briefly going to the anatomy of joints, I know it people are from different specialities, but roughly we'll talk about hips and knees. So with regards to knees, tibia, femur, patella, these are three bones constitute the knee joint, and there is the articular cartilage at the end of these bones, and which is very smooth and it glides properly, which creates smooth movements without any pain. Similarly in hip, the head of the femur and the head of the the head of the femur. Better now? Check. 1, 2, 3, 1, 2, 3. Okay. So what exactly is arthritis? So arthritis basically is degeneration of the articular cartilage. तर बेसिकली आपण पेशंटला सांगताना म्हणतो की झीज झाली आहे गुडघ्यांची. म्हणजे काय होतं की जे कार्टिलेज आहे, सो द कार्टिलेज इट इरोड्स ओव्हर टाइम अँड देर इज दॅट इज बिकॉज ऑफ मेनी reasons it can erode. And the first and the basic thing is primary osteoarthritis, where it happens due to age related processes like loss of water content in the cartilage, and त्याच्यामुळे हळूहळू fragmentation होतं. And when the articular cartilage is lost, the bare bone underneath is exposed, which is quite painful. And that's why patients with arthritis get a lot of pain when the medial side bone is exposed. Similarly, in hip, same thing happens. The articular cartilage is lost or eroded. The bare bone is exposed, causing pain. So what are the causes of arthritis? Basically, we can divide it into two causes: primary osteoarthritis and secondary osteoarthritis. Primary means age related. There is a role of genetics as well. Like patients, you must have seen आई-वडिलांना पण त्रास होता गुडघ्यांचा, मला पण आहे. So that happens in primary osteoarthritis. And secondary osteoarthritis happens due to some reason. Mostly inflammatory conditions such as gout, rheumatoid arthritis, ankylosing spondylitis, or sometimes post-traumatic, post any fracture around the knees or fracture around the hips can cause secondary arthritis as well. Symptoms of knee arthritis. Commonly you see patients walking असं बाक असलेल्या गुडघ्याने चालत असतात पेशंट आपल्या गावाकडची लोक वगैरे. सो दॅट इज बिकॉज ऑफ डिफॉर्मिटी हॅपनिंग अँड मीडियल पार्ट ऑफ द नी तिथे पेन असतो. डिफिकल्टी सिटिंग डाऊन ऑन द फ्लोर, क्लाइम्बिंग स्टेअर्स, डे टू डे ऍक्टिव्हिटीज मध्ये डिफिकल्टी होणं. सो ऑन अँड ऑफ स्वेलिंग अँड ग्रॅज्युअल बोईंग अँड डिफॉर्मिटी, नंतर क्रॅकिंग साऊंड इन द नी जॉइंट्स. दीज आर द symptoms of knee arthritis. This is a brief X-ray radiographic classification of what or how to determine the extent of arthritis. Mostly the arthritis starts from the medial side of the knee. So initially you can see in grade 1, the medial and the lateral joint space are all normal. And gradually as you go to grade 4, the joint space is all gone. So basically the joint space that you see is the cartilage, which is translucent. So you don't see cartilage on X-ray, you see only the bone. So that's why that bone on bone is where all the cartilage is gone, and that's why the bone is rubbing on bone, causing extreme pain. Hip arthritis is a little bit different than knee arthritis because the symptoms may not be in the hip, and people usually misinterpret this is the hip, but actually hip pain is there in the groin going down to the thigh and to the knee. So this is hip arthritis pain, difficulty walking again, sitting cross leg, मांडी घालून बसायला त्रास, गाडीत चढायला उतरायला त्रास, सॉक्स घालायला त्रास. So that is stiffness due to hip arthritis. आणि gradually shortening and then deformity and everything happens. Nowadays, in trend is the post-steroid avascular necrosis of femoral head due to use of steroids in COVID patients. म्हणजे every week I see now 1 or 2 patients who were treated with steroids for COVID, and they have avascular necrosis. Again, symptoms would be the same, like arthritis, groin pain, and if we diagnose them early with the MRI, the treatment modality would be different than diagnosing them late, where you have to do a hip replacement for these patients. So what can I do to avoid arthritis? Basically, it is a very difficult thing to do, because if it's going to happen, it will happen. There's nothing that you can do to avoid it. But if it happens, then something that you can do is regular exercises and control the weight. So basically, whatever weight you put on your body, it is going to go through your hip, it is going to go through your knee. So जेवढं जास्त weight, तेवढं जास्त गुडघ्यात त्रास, तेवढं जास्त hip मध्ये त्रास. So that's why lose weight or control your weight and keep doing exercises. Medication does have a limited role. So treatment for arthritis, again, I said regular exercises, physiotherapy, weight reduction is the first step. Then going for analgesic, anti-inflammatory medications. For rheumatoid and gout, you can start with DMARDs. Intra-articular injections, arthroscopies have a limited and a temporary role. And then ultimately, as I'm here for, is joint replacement. So when do I need joint replacement? So the only indication for joint replacement is pain. Pain because of arthritis, and X-ray shows significant bone-on-bone arthritis. So pain which is not controlled by analgesics, which is not, and have tried other modalities such as physiotherapy, injections, or pain relief. And if the patient is having difficulty in carrying out day-to-day activities, like walking, sitting down on the floor, climbing stairs, then yes, the patient do need joint replacement. So what exactly is joint replacement? Simple, we just cut the end of the bones and put a metal tibia, metal femur, and a plastic in between. Types of knee replacement. So usually what we have heard is total knee replacement, where we replace the tibia, femur, and sometimes the patella. And then there are this partial knee replacement, where, as I showed you the previous slide on the X-ray, that the medial compartment is only bone. Then why do you have to replace the whole knee? Then it comes to unicompartmental knee replacement. So either medial unicompartmental or lateral unicompartmental, and that is now even a patellofemoral replacements. So this is just a video of how we do a knee replacement. Basically, we just open the knee, use a tourniquet. I don't use it most of the times. Only for cementation I use. We open the knee. This is kind of an arthritic knee. And with special instruments and jigs, we make cuts at the end of the bone and then fix the metal. We have different kind of sizes of tibia, then different sizes of femur. Fix it with the bone cement. Similarly with the tibia, take the cut along the axis and we fix it with bone cement and then put a plastic plate in between. This is how primary knee replacement is done. So that's the plastic tray going on. And now the knee would be aligned straight and the movements would be pain-free. So knee replacement patients are usually quite happy. So this is a patient who had a bilateral varus deformity of the knee, difficulty walking, both sides on the X-ray. You can see she had bilateral osteoarthritis, and now she is a few weeks after the surgery, walking pain-free, walking with the straight knees, and the X-rays does show replaced knee. Now, what is partial knee? So basically, on this corner, you see a medial unicompartmental knee. On that is the lateral unicompartmental, and that's the patellofemoral replacement. So here the lateral component, lateral compartment is intact. The cartilage is not worn. So we only do a partial knee replacement where the ligaments are preserved, particularly the ACL, which is quite a proprioceptive function in the knee. So when the ACL is intact, the patient feels that the knee is more kinematic, more normal knee. So this is kind of an Oxford knee replacement. So not always knee replacements are successful. Like if you look at the literature, about 90-95% success rate, but sometimes they do fail. And when they fail, we need to do a revision knee replacement. So what are the causes of failure of a knee replacement? Firstly is infection. About 1% chances of infection, I tell my patients. Aseptic loosening. So that means over time, maybe about 10 years, 15 years, 20 years, the knee is going to worn out. It's going to become loose. So that's when you need a revision knee replacement. Fractures, if they fall, have a trauma or a fracture around the prosthesis, then you have to take out the prosthesis and do a complete revision, and gradually polyethylene wear or ligament instability, and sometimes because of stiffness, you have to revise the knee. So you can see the revision components on the left side. This is a primary knee replacement, and this is a revision knee replacement. So the components are much bigger, like you see on the bottom. They're much more expensive, and much more bone we need to take out and replace it with metal for a revision knee replacement. So this is a video of how we take out the metal. Then the end of the bone is again cleared with a saw, and this time we use more metal with metaphyseal sleeves or wedges to get fixation into the bone. So these are metaphyseal sleeves going in, and whenever doing a revision knee replacement, we have to use the stems so that it gets good fixation. In the primary knee, you only rely on the cement bone interface, but in the revision components, you have to take stems to fix into the isthmus of the bone so that we get good stability. So this is a revision knee replacement patient. So this patient had a knee replacement done 6 years ago, which eventually failed due to her weight. As I said earlier, weight is the most important factor. So she had a knee replacement done and it gradually loosened. There was no infection, and this was her walking before the operation. Couldn't even take 2 steps. And this was her X-ray, complete varus collapse of the tibial tray. And finally, we did a knee replacement in her, a revision knee replacement, using both stems in tibia and femur. And she's walking comfortable. This is on day 2. So I did see her at 2 weeks and she was more comfortable than this. So this is how they benefit from a revision surgery. Now again, hip replacement. The reason for doing a hip replacement is primary hip arthritis, which is quite rare in India. We used to get a lot of it in European population. And secondly, post-traumatic arthritis. And most common in India is avascular necrosis. And that might be due to various reasons, such as idiopathic, alcohol, or post-steroid. Then DDH, or developmental dysplasia of hip, or post-infectious arthritis. So types of hip replacements, there are numerous types of hip replacement that you can get into, either cemented versus uncemented. In cemented, as you saw in the knee, we use cement for sticking the implant to the bone. In uncemented, the stem is just wedged into the femur and into the acetabulum, and the bone kind of grows onto that and hold. So that is cemented versus uncemented. And bearing surfaces, that means what we use as bearing surfaces, like metal, polyethylene, ceramic. So there are numerous combinations of that what you can use. Dual mobility is another thing which is now coming up, which increases the stability. That means trying to use a bipolar kind of prosthesis in hip replacement, and then hip resurfacing. This is another surgical. So we again expose the hip, dislocate the hip. It is and then acetabulum is all worn out. So we ream the acetabulum with special instruments, make a bare surface of the bone for the shell or the acetabular socket to impact in, and sometimes we put in screws to fix it. So this is an uncemented kind of hip replacement, and then put a plastic liner inside, which is a polyethylene liner. And then next we move on to the femur. Take a cut with a saw, take the head out, and then impact a stem inside. Put a metal or ceramic head on top of it and reduce the hip. So that's your hip replacement done. So this is again a patient. He came to me last year. He was an ex-military person, 55 age, suffered bilateral AVN, and was not walking for the last 2 years. His son used to lift him up and move him from bed to chair. The reason nobody operated on him, that he was AKI, or acute kidney or chronic kidney disease with dialysis patient. And he came from Satara to me, and I performed, because unilateral hip replacement wouldn't help him. So I did a bilateral single stage hip replacement, both the hip replaced in the same sitting. And this is in 6 months walking. So they do take a long time to walk back, since he was not walking for the 2 years because of abductor weakness and everything. But still, there's a very good chance of them going back to normal life. Now, again, revision knee replacement, just like revision hip replacement, just like revision knee replacement, it can fail, and the causes of failure can be infection, aseptic loosening, which means it loosens over time, or fractures when you fall, or gradually the plastic or the polyethylene in between the hip wears out over time. And sometimes the hip dislocates because the artificial hip is not as stable as your native hip, because you might have seen on the video that the head we put on is quite small than the normal femoral head. So that means they are more unstable and prone to dislocation if not looked after for the first few months. So again, revision hip replacement, we use longer stem to hold on to the bone and isthmus. So this is again a revision hip replacement video. Take the previous implant out. We put in mesh or sometimes bone graft, and then again new cup. And there are again different types of things that we can use to augment the acetabulum or augment the femur to make it more stable and to last long. Sometimes you have to do an osteotomy of the femur to take the stem out. This is called an extended trochanteric osteotomy, and take the stem out. And again, whenever we do a revision procedure, we have to, as I said earlier, take more bone out and replace it with metal. So gradually over times, like I've seen in UK, that we have done total femur replacement after 2 or 3 or 4 failed revisions. Then you end up doing a total femur replacement where all of the femur is replaced with metal. So this is kind of a revision hip replacement. So this is a patient that came to me 6 weeks post bipolar hemiarthroplasty for a neck of femur fracture. I don't know what was the surgeon thinking, but he did place it wrong. I think even my non-orthopedic colleagues would see that the hip replacement is done other way around. So I had to revise her because of the fracture as well. So again, putting a long stem in, and with the plate, I did fix her fracture. Now she's moving comfortably. Another thing that we can do before doing a joint replacement, which I haven't spoken, is osteotomies, or change the mechanical axis of the limb. Now, joint replacement is at the end of the spectrum. This is somewhere in between where you have started arthritis. There is a reduced joint space, but the whole tibia, you can see it is in varus. So what you do to correct the alignment, you do an osteotomy. That means you make a cut in the bone, literally fracture the bone, straighten it up, and fix it with plates and screws. This is like a high tibial osteotomy. You can do it with various methods. And similarly for patellofemoral arthritis, you can do a tibial tuberosity slide osteotomy. It is all to gain your mechanical axis is proper. So if you're driving a car and wheel alignment is not proper, your tires are going to worn out. So similarly, we align the limb so that arthritis doesn't happen. So talking about recent. So what is the recent advances in replacement surgery? The first thing which we used to follow in Europe was a rapid recovery protocol. The rapid recovery protocol is something you start from the pre-op assessment to discharge everything. Like you screen the patient for any diseases pre-op, optimize his medical management, optimize his painkillers, because some patients are on long-standing pain relief. And then post-operatively, all the routine painkillers we give that don't work that well. So that's why optimization of pain relief beforehand is essential. Then during the procedure, using the tourniquet, I personally don't use a tourniquet, but people do use a tourniquet. They do get a lot of swelling in the knee post-operatively. So more the swelling, more the pain, more the inflammation. So basically, if you treat that, that would help. Then using periarticular anesthesia or adductor canal block, femoral block for post-operative pain relief, that does help. And then getting the patient early rehab and early discharge. In Ireland, we used to do day case hip replacement surgery. When the patient used to come in the morning, hard hip replacement, and then discharge in the evening. Now, frankly speaking, not possible in India, because unless you keep them for a few days, they don't understand the gravity and severity of the operation. They think it's a small operation and still doctor is charging so much. But then you have to keep them for 5 days in the hospital, caress them, and then discharge. But ideally, some young patients who can be candidates for day case joint replacement procedures. Secondly is robotic joint replacement. Now, if I say robotic, this is not what we do. This is the robot looks something like this. So as I showed you earlier, the cuts that we take along the bone ends, those are done by either there are 3 ways of doing it. First is manually, where I hold a saw, make a cut using the jigs and eyeballing it. That means looking at it, is it straight, is it not, and then cutting it. Secondly is navigation. So the navigation helps me to put the jig, but I am the one who takes the cut. And in a robotic, I put the jig, but the robot takes the cut. So that means a small amount of human error which is there. Like if I place my hand over here, you would see it is at straight, it is 90 degree. But it might be 89 or 91. But the robot exactly will tell me it is 90 degree. So that the human error is gone out when you are using a robotic saw in doing a robotic joint replacement. So what are the advantages of a robotic joint replacement? Basically, not much. Because if you see, it's more of a gimmick. It is more in US, where they are private hospitals and insurance are giving you more money to do a robotic joint replacement. In Europe, which is a very conservative countries, they don't do a robotic joint replacement because all the studies show there's no difference in the long-term outcome of a patient, either done by robotic or conventional joint replacement. Now, if you look at radiographic, yes, because you will see, because the robot has taken a cut, it is going to be straight radiographically. It might be 2 or 3 degrees off when you do it manually. But pain relief wise or clinical outcome wise, there is no significant differences in all the studies that have been there. Radiologically, yes, but clinically long term, no advantages with robot. Again, while using a robot, the robot itself, now this is a Stryker Mako robot. It cost about 10 CR to bring in a robot. And every time you use a robot, you have to use about 50 to 60,000 rupees disposables. So ideally, a patient would end up paying maybe 1 to 1.2 lakhs extra for getting a robotic knee replacement done without much benefit, which is not at all feasible in a country like India. If you have an option, yes, you can go for it, but I won't kind of be pushing for it. Next thing which is advanced is patient-specific implants. Now, we have a whole lot of trays in theater. If anyone has seen orthopedic theaters doing joint replacement, there are 5 or 6 trays, and they're all implant sizes from size 1 to size 8, femur size 1 to size 8 tibia, all thicknesses of poly going on. But there's something called as patient-specific implants, which we used to do on only specific patients where the anatomy is distorted, if previous fracture or any malformations, any dysplastic hip. So we used to do a CT scan of the patient, send it and get a 3D model reconstructed out of it. And they used to then 3D print an implant for the patient and 3D print a jig for the patient. So we just have to do is take the cuts, put the 3D printed implant already, which is suitable for the patient. And then that's it, surgery done, because then you don't have to then play between sizes intraoperatively. Next thing is uncemented implants. Now, hip replacement already have this option, but knee replacement, they don't have uncemented implant in India. I've used them in doing even partial knee replacements and total knee replacements in Europe. But India at present doesn't have uncemented knee replacements. It might be coming up in the future. Advantages, sometimes cement is kind of it causes cement bone reaction, which is sudden drop in blood pressure, hypertension, and even I had a few deaths on table with elderly while using bone cement. So that's why some people say avoid using cement in elderly, but knee replacement, we don't have an option and we have to do it sometimes. Then minimally invasive approaches coming up for knee replacement, people already using subvastus approach or doing it in a small incision. For hip, direct anterior approach, that is using a muscle splitting approach where we don't actually cut the muscle. Traditionally, we used to do it from a posterior approach. That means cut was over here and we go from the posterior direction and dislocate the hip posteriorly. But then you have to take off the external rotators to get to the hip. In direct anterior approach, you go through the muscles anteriorly, don't cut the muscle, just split the muscle. So that means quicker recovery and rehab, but again, no long-term benefits of it. And improve material and implants, thus survival of replacements. Now, I traditionally quote my patients to get about 15-20 years of life following their replacements, which I have longest seen is about 40 years. So I've seen a patient in Ireland who had a hip replacement done in 1970s, and he came to me 40 years later, which was still working. So we can say that even though we are improving materials, the age of the implant would still be better and better. These are some of the cases. This is just a avascular necrosis of the femoral head. Did a hip replacement. This is what I did in the last few months in India. Again, neck of femur fracture, always a question, either to do a bipolar hemi or a total hip replacement. Now, India doesn't have any guidelines for that, but nice guidelines, which we used to follow in UK, they suggest that if a patient is walking comfortably before the fall without any support, then hip replacement would certainly give a good results and better results than a bipolar hemiarthroplasty. So mostly if the patient is comfortably walking before the fall, I do a hip replacement in all of my patients rather than a bipolar. Because even bipolar won't last long and it can cause acetabular erosion and may need a hip replacement in the future. This again is a fracture patient who had a non-union for distal femur fracture with metal work put in, again removed for infection, and then the non-union didn't settle. It's still complaining of pain, and the joint was again starting to being arthritic. So in these patients, if you try to fix the bone, the joint won't work. If you try to fix the joint, the bone is already non-union. So what we do is a distal femur replacement, where we use just metal to replace the distal femur and use a stem into that. So basically you are replacing more and more bone with more and more metal. Life expectancy of these implants is less, but at least the patients do get about 5 to 10 years of their life out of it. Now this is another case of post-tuberculous arthritis with a quite huge wandering acetabulum. I did a hip replacement with augments and bone grafting beyond the acetabular cup and fixed it with screws. Okay, any questions? Ideal age, it is like, I have done it on a 41-year-old also, and I have done it on a 95-year-old also. So there's no ideal age as such. Pain is the indication, because if you do it even in 20s, nowadays the things have gone so advanced that I can do a revision at 35, 40 and another revision at maybe 60. But if you don't do a hip or knee replacement or hip replacement in early stages, you're compromising their lifestyle. Okay, so quality of life is the most important thing. Getting all, we have all the modalities to do a revision procedure. So if you do a knee replacement at 40 even, I don't mind.
What is cruciate retaining replacement?
So cruciate retaining, traditionally there used to be a posterior cruciate retaining and posterior cruciate sacrificing knee replacement. So that means we used to take the posterior cruciate off and then put a box and kind of post in between that acted as a posterior cruciate ligament. Nowadays they have a bicruciate retaining knee replacement, where you retain the anterior cruciate and posterior cruciate, and the tibial tray is kind of a horseshoe shape where it goes from posterior to anterior, and then the femur you just do a routine knee replacement like that. There's another thing which you can do a bicruciate replacement. You can do a bilateral, like lateral uni, medial uni, and sometimes patellofemoral. So this is a tri-compartmental replacement without replacing the total knee. So it's just preserving ligaments, because as I said, ligaments are responsible for proprioceptive functions of knee joint. So that means if the ligaments are intact, the patient feels it's more normal knee. But as such, again, not in India.
Thank you, Abhijit sir, for excellent talk in simple language. Anybody have questions on this topic? I think he have completely elaborated all things in his talk. So anybody? Thank you, sir.
Okay.
One more thing. Now it is expected from all faculties that Parbhani is having nice faculty for joint replacement. So you should not tell patients that it is not done in Parbhani.
Yeah, I've last time I visited Dr. Praful Patil Hospital, they have a state-of-art operation theater, and that is what I want as a joint replacement surgeon. Because when you are operating joints, you don't want any infection. And the types of OT and hospital setup he has, it is quite good to have a joint replacement. So it's not far that Parbhani would be having a joint replacement soon.
Thank you.
Thank you, sir.
Thank you so much, sir. Now, I would like to request all the chairpersons to felicitate Dr. Abhitej Maske, sir. कोणाला बोलू? सांग. Dr. Ajay Kundgir, sir, please come on dais to felicitate chairpersons. Forget. Thank you so much, sir. Now, for further anchoring, thank you so much.
All the delegates are requested to sign out the attendance register.
Now, for further anchoring, I would like to hand over the mic to Dr. Snehal Kade, ma'am.
A very good morning, ladies and gentlemen. I guess it's afternoon now. I'm truly delighted to be part of this awesome CME, having such renowned faculty and eminent audience. It gives me immense pleasure to welcome our next dynamic speaker, Dr. Ajengi Patil, to enlighten us on retrograde intra-renal surgeries for kidney stones. I request Dr. Kaushal Kondavar sir to chair this session. Let me introduce Dr. Ajinkya Patil. After completing his fellowship in laparoscopy and MS General Surgery from Bharati Vidyapit, he has done his MCH Urology from MGM Hospital. where he was able to train and operate a variety of endourology and general urology cases. He is currently practicing at Lifeline Hospital, Panvel. Over to you, sir. Sir, I request Dr. Eknath Gabay sir to chair this session.
Hello. Good afternoon, everybody. Me, Dr. Angiography. At the outset, I would like to thank Dr. Prafulla Patil, Multi-Speciality Super Speciality Hospital, for giving me this opportunity. And also Parbhani IMA President, Dr. Neil Kane sir, Dr. Vijay Bonde sir, and the panelists, as well as my colleagues, seniors, as well as juniors. As doctors, we persevere. As doctors, senior or junior, we all persevere की आपल्या पेशंटला सगळ्यात simplest आणि painless आणि best treatment भेटावं. So our all effort lies into that. I believe each and everyone would agree on that. So what is RIRS? RIRS in kidney stones. RIRS means retrograde intra-renal surgery. Kidney stones conventionally have always been operated by making a puncture into the kidney, dilating that tract, and getting the stone out by breaking it into multiple pieces. PCNL म्हणून surgery म्हटली जाते, which every one of us knows. Now, the era is of minimally invasive everywhere, all over the world, and India shouldn't stay behind. So what do we do when it comes to RIRS? RIRS needs a flexible scope, like OGD scope जसा असतो तसाच एक RIRS चा एक छोटा flexible scope असतो. It is hardly 7.5 French in diameter, and it has two types. Basically, it's technical, but just in short, fiber optic and digital. Fiber optic means it is all fiber optic fibers to which you can attach a camera and a light source like any other camera system. And digital means it has a small chip on its tip, chip on tip camera jala म्हणतो CMOS sensor. That's the digital URS. So FURS means flexible ureteroscope. That's all. So what is RIRS? Let's define it in simple terms. Surgery within the renal pelvic calyceal system and parenchyma performed using instruments introduced in retrograde fashion through the ureter and lower urinary tract. What is the advantage? More proximal ureter and intra-renal collecting system more easily accessible than conventional URS. Sounds all complicated, but it's this easy. Okay. So as you can see, this is the right kidney, and a small flexible scope has been passed via the urethra into the bladder into the right ureteric orifice through the ureter into the kidney. What is the advantage? You can access each and every nook and corner of the kidney. Advantage of accessing those corners is if you have multiple small stones located in the kidney, which are causing recurrent UTI or obstruction to the flow. We'll just see how the kidney looks on the inside. So here we are starting out. Yeah. So what I'm holding is the flexible scope, and there is a small lever on that which causes the tip of my scope to bend up and down. If I need to move it in a direction, I just need to rotate my wrist and it moves in the respective direction. What you can see is a beautiful kidney on the inside. These are the different calyces. This is the upper calyx where we have reached. This specific patient is a marine fellow. So these mariners have a very strict protocol as far as health is concerned. Even if they have a small stone like 2 mm stone, they are not allowed to board the ship and go ahead with their services. So it's an occupational problem for these people. They often come for removal of 2 mm stones. These 2 mm stones do not pass on multiple conservative managements of basically drugs, Ayurvedic treatments, homeopathic treatments. They have done every sort of treatment and they have wasted time and money into it. And also because of that, they cannot join their occupation. So as you can see here, we go ahead and pick up a small stone. This is a really tiny stone. It's hardly 1 mm. You would say, why would you want to remove a 1 mm stone, without which he cannot join his office, simply speaking, and he cannot work and he cannot put bread on his plate. So here we have basketed the stone and got it out. So is it really needed only for small stones? No, it is indicated in a stone of 1 mm up to, according to guidelines, 20 to 25 mm. But the upper limit that I have pushed is 35 mm in a patient, which is a huge stone. 35 mm even by PCNL, many people are scared to do these days. But with thulium laser is the world's most advanced laser, which we have got at our setup. So what do you use for RIRS? A flexible URS, means the scope that you just saw. A thulium laser, which you will see in further videos. It's a small 200 micron laser fiber, which we pass through the scope and go into the kidney and break the stone into really, really fine powder. So this is a flexible digital scope. This is the thulium fiber laser machine. And what we have got at our setup is a 60-watt machine, which can be used for both kidney stones and prostate as well. So why thulium laser? Thulium laser is unconventional in today's era. Why it is unconventional? Because all urologists have been trained on a holmium laser. Holmium laser has been there for the last 20 years or so. And it has been equally effective. But the problem with holmium laser is it's huge. It cannot be transported. It is expensive. Of course, thulium is equally expensive if you go ahead and buy it. But holmium cannot break a 25, 30 mm stone. You cannot even imagine breaking it because it will take hours together. And there is a time limit for any RIRS procedure, which is 90 minutes. We cannot operate into the system for more than 90 minutes because the patient can land up in sepsis. So here are a few points which say why thulium is better. Mainly, it breaks the stone 4 times, up to 4 times faster than a holmium laser. Multiple studies have shown that. So what are the indications of RIRS? If you just diagnostic purposes, hematuria, positive upper tract cytology, means basically if you're suspecting any upper tract cancer for the patient. Other indications like PUJ obstruction, there are small PUJ obstruction which you can do, anastomotic strictures. So this is a huge list of basically nothing but kidney stones. This whole list is indirectly mentioning kidney stones. So best treatment modality for kidney stones is what? ESWL, PCNL, or RRS. What should I suggest my patient? A patient comes to you, says, sir, I have a 10 mm stone. मग आता काय करायचं? PCNL नी होल पाडून काढायचं का ESWL करायचं का RRS करायचं? 3 different things, 3 different costs. India is a country where we have to consider cost, and it is very important factor as far as treatment modalities are concerned. ESWL has been around for so many years and it has really excellent results. But are you really willing to shell out 90 lakh rupees for a good ESWL machine? ESWL machines are available from 10 to 12 lakhs to 90 lakhs. A 12 lakh machine will give you 0 results, realistically speaking. You can have a machine and you can say, I have ESWL, I do ESWL, and your results will be really poor. As far as PCNL is concerned, you make a hole, go inside, get the stone out. All right. But you put the patient at risk. He can have a huge risk of bleeding through your puncture. He can lose a kidney because of that, which is a very, very, very rare complication of PCNL surgery, but it is a known complication of PCNL, wherein inadvertently people have ruptured the hilum of the kidney and the patient either has bled to death or emergency nephrectomy has been done for the patient. So why RIRS? RIRS is the most safest way to deal with a kidney stone without venturing into the kidney, making a puncture. You don't need to do any of that. Just pass a scope from below, go ahead and dust the stone. So here we are seeing on the left image, I have passed a wire into the kidney, and what you see down here is an access sheath, which is a simple tube through which the scope will pass. And on the right image, the scope has passed and I've started breaking the stone. What you see here, which is a hollow area, this part of the stone is broken. This part of the stone is still remaining. We'll see it in the video. So a 14 into 13 mm left kidney stone. This is a 3D CT image, what you're seeing right now. So again, we have gone into the system and here lies the stone, which we just saw on the CT, and we'll start dusting it into really fine powder. As all surgeons know, and of course non-surgeons also, that what we see here is a really magnified view in our TV screen. And that gives us better precision and better results and faster results rather. So I've started dusting the stone into really fine powder. This is a really hard stone. Its HU value on CT scan, which denotes the density or hardness of the stone, was roughly 1200 HU. So we'll get a better picture here. Sorry. Yes. So as you can see, I just paused the video to show you. This is the laser fiber that I'm talking about, which is passed through the scope. It's a 200 micron laser fiber. And this is your stone. This stone lies into the kidney, into the renal pelvis. And here we are dusting it into real fine powder. Sorry. Yes. So as you can see, it's been dusted. And what you see here, you can only see in the camera. If this same dust comes out through the urine, unless it is collected in large amounts, you cannot see it. It is not visible to the naked eye. It's that fine. So do you need to remove it? No, you don't need to remove it. We just place a stent for the patient and the dust comes out on its own in 10 days. So the procedure for this patient is he comes in the morning, gets admitted. I operate him in the afternoon. The next day morning or by 12 o'clock, he's going home. You can see fine dust here into the kidney. See, I've collected it all in the kidney tray, as you can see. It's really fine. You have to really look into it to even see if there is any dust. So this is a stent which was placed after the stone was cleared. As you can see on the C-arm image, it's completely cleared. And in just 40 minutes, this whole stone got cleared for the patient. This is an interesting case. She was operated somewhere outside 4 years back. A simple URS was done for upper ureteric stone. And unfortunately, inadvertently, none of us wish this, but this has happened for the patient, that a small fragment of a wire, a foreign body rather, was left into the renal pelvis, which formed a stone over the period of last 4 years. And she came to me with right flank pain and some tenderness. Fortunately, no sepsis for her. We passed a flexible scope, and here we dusted this stone into really fine powder and removed this foreign body for this patient. So you can see in the image, we dusted it into real fine powder, and what we realized is it is a zebra wire which we commonly use to pass access sheets or stents. And this is the foreign body with some amount of stone still intact, as I purposely kept that part of the stone to show. So does this mean, is PCNL obsolete? Means kidney stone आला तर PCNL करायचंच नाही का? PCNL बंद झालं का? No. PCNL is not obsolete. It is still prevalent, and it is the most cheapest option you can give to a patient. But it has its own set of complications and problems, and it is more indicated in a really large volume stone, say more than 35 mm, means 3.5 centimeter peksha motha stone aseल, then you suggest your patient that you undergo a PCNL. Yet still, I do give my patients the option of PCNL plus RIRS. So here is a case. This patient has these many stones in his kidney. He knew this since long. For 4 years, he knew that he had such a big stone, and the total stone load, as in if you measure all the stones together, was 7.5 centimeters. And that's a large stone. I did a PCNL for this patient, and this is the result. As you can see, multiple stones were removed. And this is one last fragment which is remaining, and it was in a end calyx, which was really difficult to negotiate. So in single puncture, I removed 90% of his stone. Now the 10% that is remaining, there are two options. One, you can take a puncture again and go ahead. But such patients have a tendency to land up in sepsis if you operate for a really long time. So we did a RRS after 21 days for this patient. The picture on RRS was something like this for that stone. It's a beautiful turtle-shaped stone, as you can see. And we dusted it into really fine powder. As it was a really difficult calyx to access, which often urologists find on table, and many times it might not be seen on IVP. We have to leave the stone behind or tell the patients that they can go ahead with ESWL, but that is not necessary. After 21 days, the patient is coming to you for DJ removal. At that same sitting, you can simply just dust the stone and get it out. So what are the advantages of RRS over PCNL? There's no incision, so no bleeding. There's no tract dilatation. So faster recovery. Patient comes to you in the morning, he can go back in the evening as well. But patients in India don't prefer that. It is best for high-risk patients like cardiac patients, especially people who are on blood thinners, for whom you can't do a tract dilatation. Problems with PCNL. Either you have to take one incision or maybe multiple incisions. There's a high morbidity and mortality rate. Patients might require multiple blood transfusion if there is a lot of intra bleeding. Complete stone clearance might be difficult in a really complex calyx. And patients take rather more time for recovery, wherein nowadays you have to be back on the job in a day's time or so. And of course, pain. which is one thing no doctor wants for his patients. So RRS, yes or no? 100% yes, without anything, without any doubt, RRS is the future. As time goes by, as patients become more aware, the size of the stones that come to you are gonna reduce and patients are gonna demand RRS from you. So if you look for perfection, you will never be content. So everything has its own small set of problems. Nothing is perfect. The equipment cost on RRS machine and its other accessories is really high as far as a doctor and a hospital is concerned. So that cost gets delivered to the patients indirectly, unfortunately. There is another problem with RRS. If the patient's urine is not sterile, there's a chance of sepsis in such patients. And of course, like I said previously, for large stone volume, like a 7 centimeter stone, you cannot do RRS because it is time consuming. Our proud moment, we bought a thulium fiber laser machine last year in the month of April. It's been 1 year and we've completed roughly 100 cases up until now. And it's the first machine in Navi Mumbai, Raigad, Panvel region. In Mumbai, there are only 3 machines and the 4th machine arrived with us now. Now Mumbai has started getting few machines. Thank you. So any questions about RRS, any doubts, if at all?
Thank you, Ajink Patil sir, for your wonderful lecture. One question from my side. Are you doing primary RRS anytime? Doing. Or most of the cases are stented?
No, 80% primary RRS, 20% you have to do secondary RRS. So
yes.
The difference between primary RRS and for others. Yes. So what we mean by primary and secondary RRS is these equipments that are being made, whatever flexible scopes and all of that we use, is being made for a European or American population, unfortunately. So many times the Indian ureters are really narrow. You cannot pass the flexible scope. And that lands up the patient as well as you in one trouble that you cannot pass the scope and you cannot end up injuring your ureter. So you have to place a stent for the patient for 10 to 15 days. The patient follows up after 15 days. You pass a scope, you get the stone out. But those 15 days are of course lost. The reason being the ureters are tight and you cannot force.
Is there any disadvantage of thulium laser? Have you seen thermal injuries?
No, I have not seen thermal injuries because primarily I do not use thulium laser in ureters. For a ureteric impacted stone, I will not use a thulium laser. I simply use our conventional litho. That's all.
Wonderful session. Truly speaking, it used to be pylolithotomy followed by PCNL.
Right.
PCNL was the considered minimally invasive surgery.
Right.
Now I think future is not so far. RIRS has taken a
Definitely,
step forward.
definitely.
So I will say the RIRS that you are doing is really wonderful. But I would like to know how many conversion rate you have found that RIRS, you have failed in RIRS and you have to convert the patient to
Right,
the PCNL.
exactly. That's a good question. The thing is that you generally don't need to convert unless it's a really large dilated system where your scope is not reaching in the lower calyx, say it's a medial placed calyx. Up until now, touchwood, I have just one case which I had to convert, which was a 12 mm pelvic stone. I passed a flexible scope. The stone unfortunately went into the lower calyx. I couldn't access it. I did a mini PCNL for him.
Okay. Second question, sir. What about are there any truly cut lines where you can decide whether I'll pose this patient for PCNL or whether for RIRS?
So as far as guidelines go, a 20 mm cutoff has been set clearly by American Neurology Association guidelines as well as EAU, means European Association. But in India, people push the limits. We all push the limits for our patients. As far as I go, I've pushed it till 35 mm. In a single sitting, I've cleared a 30 mm stone. Another patient of 4.5 centimeters I cleared, but I left 1.5 centimeters of his stone. I clearly told him that I cannot go beyond this because there is a very high risk of sepsis. And such patients land up in sepsis really fast than any other surgeries that you do. So you have to limit yourself. You have to know where you have to stop.
So
if you keep going, keep dusting, there is no end to it.
so you mean you can clear stones up to 30 mm by
Definitely,
RRS,
definitely.
and that will be better for
By
patient more
RRS
than
rather
PCNR.
by thulium laser.
Yeah, true. True.
Because with a holmium, I don't think it's really possible.
Wonderful work, sir. Wonderful.
I now request Dr. Eknath Gabare sir and Dr. Kaushal Kondawar sir to present our token of appreciation to Dr. Ajinki Patil. Can I please request Dr. Mukashi sir to felicitate our chairpersons? Let's welcome our next eminent scholar and honored guest, Dr. Ashish Agrawal sir, to deliver his talk on Introduction to Cardiac Surgery. To chair this session, I invite Dr. Amitabh Kartan sir and Dr. Daitankar sir. About Dr. Ashish Agrawal sir, after completing his MBBS and DNB General Surgery, Dr. Ashish Agrawal sir did his MCH in Cardiovascular and Thoracic Surgery from Lokmanya Tilak Memorial Medical College, Mumbai. Later, he also worked at Santosham Chest Hospital, Chennai, where he got further training in advanced thoracic surgery. To his credit, he has 4 paper presentations and 10 publications in national and international journals. Currently, he is working at Seth Nandanal Doodh Hospital, Kamal Nayan Bajaj Hospital, and Asian City Care Hospital, Aurangabad. Handing over the dais to you, sir.
Good afternoon, everybody. I thank organizers for inviting me for this session. Thank you, madam, for your introduction. This is the place where I worked for a long time, from 2008 to 17. Now I am practicing in Aurangabad at Doodh Hospital, Bajaj and Asian Hospital. I'm here to explain you some basic requirements of cardiac surgery department. These are the equipments which are required for heart surgery. We have world-class instruments at Doodh Hospital. We have Jostra, Mackey, lights, OT table, intra-aortic balloon pump, draggers, machines, and other ventilators. At Doodh Hospital and other hospital, we perform CABG, valve replacement surgeries like mitral valve replacement, aortic valve replacement, double valve, and tricuspid repair. We also deal with ASD, VSD, TOF, and permanent pacemaker implantations. Routinely, everybody is aware that any patient of cardiac have chest pain dyspnea, for which he undergoes angiography, after which if 1 or 2 vessel blocks are there, then they undergo plasty. But I would like to explain you what are the indications of CABG. Broadly, we can say left main disease, triple vessel disease, left main equivalent. If osteoproximal lesions are there, diabetic patients are there, impaired LV function, then we can benefit the patient by giving complete revascularization. Calcific vessels and arterectomies are required. Then if the lesions are at branching, means we need to deal both the branch, and if we do plasty of one branch, then the other branch if gets king, then in that cases our cardiologist colleagues request for CABG. If CTOs are there which are not negotiable, then we can go for CABG, and patient with post PTCA, they can also benefit from CABG. If broadly speaking, bypass can be done in two ways: off pump surgery and on pump surgery. In off pump surgery, we don't put the patient on heart lung machine, and patient is operated on beating heart. येत नाही का? Off pump surgery, in this patient is not on machine, that is heart lung machine, and surgery is performed with a beating heart. On the other way, on pump surgeries, the patient is put on a heart lung machine. It can be operated on beating or arrested heart. This is the heart lung machine where whole of the blood of patient is taken out of the body and put on pump, and then surgery is done. This is octopus, which is used for beating heart surgery, where heart is stabilized with the octopus arm and surgery is done on off pump. What are the advantages of beating heart? This reduces the incidence of stroke, then less kidney injury, inflammatory response is less, and lesser coagulopathy, as well as decreased length in stay of the hospital. What are the grafts which we use? The internal mammary artery, which is there in our body on both sides of the sternum. We can use both the internal mammary arteries. Then we can use radial artery, and vein graft from lower limb can also be used. I don't want to go into details of indications of stable and unstable angina, but broadly I have given you the criteria for going for CABG. That would be more theoretical by going into the details of all these indications which keep on changing as per AHA guidelines. This is the picture where before surgery you can see there are no graft, but when we use the lima, this is the lima which is grafted to LAD, and other graft is of vein graft. You can see the vein graft given to the other artery. Now going on to the other surgeries like mitral valve replacement and aortic valve replacement. The main indication of mitral valve replacements are patient in AF, patient with LA clot and calcific valve, and history of stroke. These are means you don't need to go into the details of theory. These four indications you can keep in mind, and patient can be sent for mitral valve replacement. Similarly, for mitral valve regurgitation, pH, dilating LV, and low if patient EF goes down, then that becomes an indication for mitral valve replacement. Similarly, in aortic stenosis, gradient more than 50, patient having history of syncopal attack, then patient with angina, then this becomes an indication for aortic valve replacement. And in aortic valve regurgitation, similarly, patient is having dilatation of LV, and worsening LV function becomes primary indication for aortic valve replacement. These are the type of valves which are used. These are older valves. These were ball and socket, then single tilting disc. Now new valve have come, they are bileaflet valves, and tissue walls have come. In young patient, male patient, we use mechanical valve, and in unmarried female and older patient, we use tissue wall, because tissue wall don't require anticoagulation, and metallic valve always require anticoagulation. This is again second photograph which shows new generation valve. These are percutaneous valve implantation, and these are the complications of valve when this valve has been crowded by pannus and some clot has come over there. These are the pericardial valves which have come recently. The life of pericardial valve is more. Okay. नहीं होता नला. This is the heart lung machine, and you can see the oxygenator. The patient blood is drained by the pipes in this oxygenator, where the blood is oxygenated and returned back to the patient. And in this way, we can do a valve replacement by placing the patient on pump. This is more important at the periphery like Parbhani, when most of the patient of valve replacement regularly follow up with our physician colleagues. We have to maintain the INR. I request all of my colleagues to ask the pathologist to at least keep the ISI value of the reagent 1 or 1.1, because there are a lot of variation in this factor. If the ISI reagent is more than 1.1, then the results will change, because the if reagent ISI value increases, it is cheaper. ISI value of 1 or 1.1 is costlier reagent. So request your pathologist colleague to keep the reagent value near 1. So you will get a better INR value. These are the overall worldwide international standards of complications, but at our hospital, we have been able to give better results than this. This is the operation theater of Dhut Hospital. It has laminar flow with 0.3 micron filters, world-class facility. We have 2 such theaters, so that in emergency, any standby emergency case from cath lab or any other place comes, we can take simultaneously. Thank you. Any questions?
Sir, this is just a family question which I could not ask to the cardiologist who operated, Dr. Agrawal from Kokilabin Ambani Hospital. My real sister was operated for critical mitral stenosis, and while putting the valve, they could not get the exact size because the mitral valve of the pericardium preparation was not available. So they kept the inverted aortic valve, and they said it's fine, it will not have any problem for as far as expectancy is concerned or acceptance of the valve is concerned. So I could not ask that question because she was my sister. So I'm asking you openly on this platform whether it's okay.
Yeah, it's okay. It's okay.
It makes
because,
no
because all pericardial or tissue valve, they are manufactured abroad, and the BMI of Indian patient is far less. So that size many times it becomes a problem. So you usually accept it, not an issue at all.
It's a-
Rather, I would say pericardial aortic wall has smaller struts, so that LV dysfunction will be less. The struts of mitral wall are bigger, which can sometimes cause injury to the LV. Aortic wall struts are smaller, so it's better, not too problem.
Fantastic. Thank you so much. Same was expressed by Dr. Agarwal. Yeah, thank you.
Ashish Agrawal sir. We thank him for his nice, lucid, elaborative, and informative talk.
Thank you,
sir.
Dr. Ashish, what is the incidence of, ratio of off pump and against on pump by CABG at your institution?
Last 1 year, if you ask, I have converted only 2 patients electively on pump, sir.
Nice to see. And do you ever, nowadays you using cardioplegia or not?
On all valve replacement, congenital, ASD, VSD top, we have to give cardioplegia.
For CABGs?
CABG, even if I did 2 cases on pump, they were beating heart surgery. We have not arrested the heart at all.
Nice listening. Thank you very much.
Yeah.
Thank you for the wonderful presentation, sir. I request Dr. Kartan sir and Daitankar sir to felicitate our speaker. I request Dr. Siddeshwar Bendekar to welcome our chairpersons.
Yes. Oh.
Can I show some videos of surgeries? See, this is the endarterectomy which has been done. The whole vessel was having calcification. I'll show you the other vessel. See. Nowadays, we get a lot of vessels with calcification inside it. So once we open, this is beating heart surgery with octopus applied. And this is the way we have to pull the calcification from the vessel out. You will be surprised. It will come as a whole tree root. The vessels are so calcific that just grafting them is not going to help the patient. We have to clean the media and intima of this patient. This big vessel was calcific. So we removed the complete vessel, which was diseased, and then grafted the LAD. Fortunately, everything was done on beating heart only. Patient did not require any on pump or balloon afterwards. Then this is how Lima to LAD is anastomosed. You can see beating heart and the graft has been done. And when we do a big endarterectomy, we have to put a vein patch, and on that we put a lima. This was the vein patch, and then lima was given. Thank you.
It's a great pleasure for me to now call upon the stage our next renowned speaker, Dr. Shailesh Zaide, sir. He is going to update us on basics of angiography and angioplasty. To chair this session, I invite Dr. Mahesh Soni, sir, and Dr. Govind Rasal, sir. About Dr. Shailesh Zaide, sir. After achieving MBBS, MD, and DNB medicine, Dr. Shailesh Zaide did his DNB cardiology. He has experience of working at interventional cardiologist in various institutes at Hyderabad, Jalgaon, and Aurangabad. Currently, he is practicing as consultant interventional radiologist at Axon Hospital, Amravati, and Sant Achyut Maharaj Heart Hospital, Amravati. In his experience of 7 years, he has done more than 8,000 cardiac procedures, including angiography, angioplasty, pacemaker, AICD implantation, and all. It's an honor to have you here, sir.
Good afternoon, all. I thank you, IMA Parbhani, to invite me here. Most of us, you are not familiar with me. I am from Amravati. I came all the way to give just a talk on request of Patil sir. So basically, this talk is regarding a very basic introduction to angiography and angioplasty. And so basically, the radiological examination of vessels after the injection of contrast medium is angiography. So it was started long back after discovery of X-rays by Roentgen. Two physicians, they thought, okay, we will just inject some mercury salt into amputated hand, and they created image of some arteries. So this was what they got. After that, the first attempt of cardiac catheterization and angiocardiography was done by Forsman in 1929. Later on in 1941, Conrad, he demonstrated that cardiac catheterization can be done safely in a human being. And in early 1960s, Masson Jones pioneered transbrachial. Later on, they also invented transfemoral angiography. So the basic principles what we need for angiography is the most important is the arterial axis. So this was done by using the routine technique called the Seldinger technique, which was like developed by Seldinger in 1953. So this is a percutaneous technique for arterial and venous access, and most of us, whoever is doing a central line catheterization, everyone is aware of this technique. So basically, radial artery is the most common artery which is used for this purpose. For angiography. Initially, it was all done through femoral route only, but nowadays most of the cardiologists, they are preferring radial route because of many benefits. Most important benefit being mobilization of patient immediately after angioplasty, and like a discharge of patient within 1 to 2 hours after angiography. So this becomes easy for patients, hospitals. Actually, it also saves bed. And this was the concept nowadays for all the major corporate hospital for radial launch introduction. Basically, it saves bed, it saves patients' time, it saves hospital infrastructure as well. So Seldinger, it is a very easy technique, and it requires a 18 or 20 gauge needle with which is usually with a stellate. It has a good hub and a wing handle. So this was the needle which we usually used to do either a radial or a femoral puncture. Later on, there was some change in the needles, and it came at a simple puncture needle as well. And nowadays, what we're using is this type of simple gel cores, which are basically a plastic, like just like our vein flows without wings. And whenever we do a femoral puncture, we use a needle because it requires a bit like stiff needle. So we usually use a metallic wire for femoral puncture. So Seldinger technique is very easy, and it requires introduction of a needle, then placement of a needle into the vessel lumen. And after insertion of a guide wire, we usually remove the needle and put a sheath over that wire. This sheath act as entry point for our all the catheters wires, which we usually use for angiography. So this is a basic sheath, and it is made up of a sheath, a dilator, and a wire. This is another sheath which is actually used for radial punctures. So another thing after sheath we require is a guide wire. Guide wire, these are easy and it allows safe introduction of catheter. These are usually made up of stainless steel, around 145 centimeters long, and they are tapered at the end to a soft flexible tip to avoid any injury to the vessel wall. Nowadays, they are covered with even a hydrophilic polymer and non-metallic materials, which are called glide wires, which are easy, give strength to the guide wire. And at the tip there, it can be a straight tip or a J tip. So basically these are multiple wires, and again, these are straight tip and J tip wires. So these are again wires. These are again the guide wires, which are packed like this. After the guide wire, what we require for angiogram is a catheter. Catheter, it can be of many shapes, and what we usually count it in diameter in French. So it can be a straight tip, it can be a curved tip, it can have a pre-shaped for particularly made for a particular arteries. So there can also be a circular tip like in pigtail, which is usually used for diagnostic purpose. So these are multiple catheter, and whatever shape you can imagine catheters, there are many catheters which are of a different shape, different like diameter, and it actually they are made up of depending upon origin of a particular vessel. So most commonly used catheter in cardiology, these are made by Judkins, and these are called Judkins catheter. right catheter which has a lesser curve for right coronary artery, left catheter with a greater curve for left coronary artery. There are other catheters as well, which are called amplards. These are the catheters which we usually use for angiography. The one in the with a smaller curve is for right coronary. The one with a larger curve is for left coronary, and there can be other shapes as well. So this is the man behind making this pre-curved, pre-shaped catheters, Judkins, and since many years, these catheters, the same catheters we are still using even in 2022. So this is a particular catheter like a Judkins right, which has a smaller curve. Judkins left, which has a larger curve. So right is for right coronary artery, left is for left coronary artery. This is a pigtail which is used for diagnostic purpose or for left ventricular angiogram, for aortogram. And this catheter, they have mentioned the length as well as the French, and it is like color coded according to the diameter. So the next thing which we require is a contrast media. Initially, they were using ionic iodine compounds. Nowadays, we're using non-ionic contrast media, which has a lesser adverse reactions and low physiological problems. So coming to the indications, so as everyone is aware of indications, it is basically a heart attack or a ischemic heart disease or unstable angina. After revascularization procedure to check for patency of stent, after bypass surgery to check for patency of grafts, then to look for congenital heart disease, congenital anomalies, we can do LV angiograms. It can be used for to see anomalies of great vessels, wall disease, myocardial disease, and ventricular function as well. Other things to look at is atheromas, aneurysms, AV malformations, arterial ischemia, sometimes in patients with trauma. Patient preparation is actually easy. Just to explain the risk to the patient: history, clinical examination, physical examination, lab test, consents, preoperative IV fluids if required, medication to relieve anxiety if required. Then pre and post procedure monitoring is easy nowadays because like after femoral procedure, they used to monitor the patient for 4 to 6 hours for hematoma formation, pulse, distal pulse and all. But now after like nowadays, because of radial punctures, it is again like chances of hematoma formation, bleeding after the procedure are very less. And still we immobilize patient for 4 to 6 hours if we use a femoral puncture. Then vital signs monitoring and puncture site inspection. So coming to contraindications, there are no absolute contraindications for angiograph. There are few related contraindications like contrast allergy, impaired renal function, blood clotting disorder, anticoagulant medication, and sometimes unstable cardiopulmonary status. Coming to risk involved. So again, bleeding from puncture site, which is the most common and most disastrous complication at some time, because sometimes there can be a retroperitoneal bleed. If we take a femoral puncture, it may get unnoticed and may lead to hemodynamic compromise, sometimes even death of the patient. Thrombus formation, which is very common after radial puncture, and many a times the radial artery, it may get closed after angiogram, routine angiogram or angioplasty, and because of multiple collaterals and ulnar artery around, it is usually asymptomatic. Sometimes there can be embolus whenever we use different wires, different catheter, and whenever there are catheter manipulation, multiple catheter exchange, there can be plaque dislodge from the vessel wall leading to stroke. Sometimes it may get dislodged to the distal limb, sometimes to the upper limb, sometimes to the lower limb, leading to limb ischemia. Again, dissection of vessel, because of if you do not use a guide wire properly, if you just use a guide catheter without a wire, there can be dissection. Sometimes even with the wire, then can be a dissection of the vessel leading to abrupt vessel closure and the distal limb ischemia. Puncture site infection, again, this is very, very uncommon and not seen nowadays with all the measures, precautions which we take. Contrast reaction. So this can be again a dreaded complication at some times. With a newer contrast, again, these reactions are very less, but many patients, almost 30% patients, they may get rigor, chills, and sometimes fever as well. Coming to cath lab room, so there is usually one procedure room, one console room. So procedure room can be anything between 400 to 500 square feet. It should be having a floor which can be easily cleaned. You need a oxygen and a suction. There should be at least 2 access, one main door for patient entry and one door to the console. Console size is not actually established by any terms. So you can have any like you can have a large console if you want. You can have a small console room if you want. There should be easy access and communication to the procedure room. Operating consoles, they have computers and monitors. Coming to equipment, so cath lab equipment, it has an X-ray generator, detector. There are multiple softwares, table, console, and it requires a UPS as well. So this is a typical cath lab machine. So if you see, there is a large C-arm, a table, there are multiple monitors. One is a live monitor, one is a reference monitor, and one is a hemodynamic monitor. So again, cath lab, it can be of multiple companies and all the companies, they are good. So coming to the stent, which is a basic requirement for any angioplasty. So it is basically a mesh-like device which is made up of metal. It acts as a scaffold and it keeps the vessel open. The stent helps, it also improves the blood flow. And 80% of the patient nowadays, whoever are undergoing angioplasty, they require a stent. Around 10 to 20% patients, they may get out without a stent as well, with just balloon dilatation. So coming to the type of stents, there are basically two types of stent: bare metal stent and a drug-eluting stent. Bare metal stent nowadays is absolute and nobody is using it, but it is still used for renal angioplasties, for peripheral angioplasties. Drug-eluting stent, these are most commonly used for coronary angioplasties, and it has a lesser side effects of restenosis. So again, in drug-eluting stents, there are multiple stents, imported stents. There are Indian stents. Almost all the stents available nowadays in the market, they are good. They made up of very good technology. There can be a drug coating of either a sirolimus or a everolimus or a zatololimus drug. So what we commonly use, we are using is a sirolimus eluting stents. So another stent nowadays available is a bioresorbable vascular scaffold, or a BVS. So this stent was introduced by USA in 2011 and it got a FDA approval that time. But after using for a few years, there were many complications with this stent. Chances of restenosis were high, chances of acute stent thrombosis, ACS after the stent placement were high, and so it was withdrawn after 5 years of using. And now again, an Indian company, Merrill, they have reintroduced these stents 1 year back into the market. Still, we don't know the long-term result, but because it has a bioabsorbable vascular scaffold, these are very good stents for a younger generation patients who do not have a calcified vessels. So we are still using, I'm using these stents only on demand from the patients. We are not giving options as of now because we are not sure about the long-term result yet. So coming to balloon angioplasty, this is a typical balloon which is usually used for balloon angioplasty. And what it does is the balloon is in deflated state over a delivery system, and when we inflate it with the help of an deflator, the plaque, it gets shifted and it gets compressed, leading to it gives artery is widened and the blood flow is improved. But as we all know, this arteries, these are elastic, and again there can be chances of restenosis with this procedure. So we usually put a stent after this procedure. So coming to a small history of angioplasty. So PTCA was done by Grutznik in 1977. So after that, Puel and Sigwart in 1986, he developed first coronary stent to act as a scaffold. Since 2001 in India, we're using a drug-eluting stent to minimize restenosis. So this is in short angiography. So as we can see, there are two arteries which are visible in this view. So the one coming down is a left circumflex. The one which is going up here is a LAD, which is a left anterior descending artery. So this is a catheter which is placed here at the left main coronary artery. So this is another view with this of the same patient with the same arteries. So the one coming down is in this view is a left anterior descending. The one going up is a circumflex artery. And there is one more artery which is on the right side in the aorta. So this is a right coronary artery. So coming in short to a procedure of angioplasty. So like this, we usually keep the catheter around the left main coronary artery. As you can see in the left anterior descending artery, there is a huge block of almost 95%. And what this is a guide wire, a coronary wire, which we usually put inside the coronaries. After putting the guide wire into the coronary, what we do is we take a balloon, we dilate that lesion with the help of balloon. And as you can see, after balloon dilatation, there is decrease in the size of the stenosis, and this makes a way for stent. So once we put a stent into the lesion, this is a particular stent, as you can see it here. After placement of the stent, we usually dilate it with the help of, again, the delivery system, which is equipped with a balloon. And once we deflate the balloon, we remove the delivery system, and the angioplasty is done. The block is usually, now there is no stenosis at the lesion site. So coming to the newer advances in cardiology, there are few things which are new in cardiology. The one is a fractional flow reserve, or FFR. So basically this is just to judge if the patient is having a borderline lesion, like someone says it is a 60%, someone says it is a 70% lesion, and you want to make sure that whether it is 60% or whether it is 70% or whether it is hemodynamically significant block, we usually do a fractional flow reserve for that patient. And the fractional flow reserve, it is like easily measured during routine coronary angiography by using a pressure wire. So this pressure wire, it calculates the ratio between the coronary pressure distal to the coronary artery stenosis and the aortic pressure. And when we take these pressures and when we calculate the ratio of that, FFR of 1 is normal. Anything below 0.75, it indicates that there is decreased pressure below, which indicates that probably the stenosis is significant, and so it requires either angioplasty or bypass surgery. Second new thing in cardiology is IVUS. IVUS is basically an intravascular ultrasound, and it is an invasive access technique that allows the dynamic acquisition of tomographic imaging in vivo of the vascular lumen. And you can see a very like whenever we were using just angioplasties, this was done without knowing the interior inside of the coronary artery. But with the IVUS, what we can see is inside of the coronary arteries as well. So yeah, it shows us multiple things. It shows us intima media, it shows us the plaque, it shows us the calcium, it shows us the lumen. It also, you can measure the lumen diameter directly. It even show you the side branches. So again, this is an IVUS image showing a calcified plaque, the lumen, the side branch, the vessel wall, the intima, and you can measure everything. The another advance is a OCT. It is again a bit above IVUS, and it is like used to examine the coronary arteries, and it has 10-fold higher resolution than IVUS. Based on the polarization properties, OCT can differentiate tissue characteristics as well. So it can tell us whether this is a fibrous plaque, whether this is a calcified, whether this is a lipid rich, and everything about thin cap fibroatheroma as well. So these are a very clear images which we can see in in OCT. So you can even see the calcification. You can see the calcification where it is 360-degree or located to a particular area. You can also see if the stent struts are there. You can even see the stent strut, whether the stent is expanded properly or no. Another thing which is new to the cardiology is the rotablation atherectomy. So this is basically used for a calcified lesion in which in which you are not able to pass the stents because of calcification. So in a heavily calcified vessel, because of the hardened arteries, you will not be able to pass a stent, because again the stent is not very flexible material, it is made up of metal. So what we do is we drill that thing with the help of a burr, which is a diamond burr at a very high speed, which rotates at a very high speed, and it drills the calcium around the arteries, and it makes some way for balloon as well as stent, which later on we can pass easily. So this is basically a diamond burr, and this is a calcium, and it bursts, and it decreases the calcium and makes way for our stents. This is a typical rotablator machine. This is a diamond burr, and this is a console. So this was all for today. I thank you for inviting me again. So I practice at Axon Hospital, and one other hospital we are practicing is Sant Achyut Maharaj Heart Hospital, which is basically a trust hospital. And I'm proud to say that here we do a maximum number of angioplasties throughout Maharashtra. So last month we did around 271 angioplasties here. We cater patients from almost 7 to 8 districts there, as well as from Madhya Pradesh, Chhattisgarh as well. Thank you, sir. Any questions?
Hello.
Nice presentation. Sir has thoroughly concluded all the points like indications, procedures, hardwares, complications, and everything. In cardiology, most important thing is golden period. You have to catch up by doing early procedures. So my advice will be everyone, you don't have to miss that golden period. Any questions from audience?
No questions, but just I want to pass some comment regarding the two chairpersons sitting and Dr. Jayade for your information. In the COVID times, Dr. Govind Rasal was attached to our cath lab, and Dr. Agrawal, Sunil Agrawal from Pune, and he has done a phenomenal work. That time his cath lab was not working. And really a substantial work was done in the COVID times, where all the people was fear for doing the non-COVID works because of that. And this appreciation was given by the Minister Rajesh Tope when he saw the abstract of non-COVID works done by the corporate hospital in Maharashtra. And he has conveyed a special appreciation to all our cath lab for Dr. Sunil Agrawal and Dr. Govind Rasal. That time they operated. I'm very happy, Dr. Jayade, today I think there are 5 cath labs working in Parbhani. So in last 2 years, the Parbhani has taken a shape for the cardiology, and very soon, in a year time, we will also have a cardiothoracic unit. And with these 5 people who are working in the city and a few visiting people, we will make a good cardiac center in coming next year also.
Definitely.
So Dr. Parbhani and Dr. Govind Rasal and other 2, all will make a group of like a family of cardiology, and we'll try to convert this in a whole cardiac unit. And you people also can come sometimes for the hands-on or when there is a big camp like procedures. So Amravati is not a far away from Parbhani. So thank you for coming here, and thanks Dr. Govind Rasal and Dr. Parbhani. And let us keep some big target for the next year.
Thank you, sir. That was a knowledgeable feast. I request the chairpersons, Dr. Mahesh Soni sir and Govindra sir, to felicitate our speaker. I request Dr. Manvatkar madam to come on stage to felicitate our chairpersons. Let's welcome on stage our next eloquent speaker, Dr. Prakash Devde sir, to update us on oral cancers. I invite Dr. Rahul Rathod sir and Dr. Tushar Dubey sir to chair this session. Dr. Prakash Devde sir has done his MBBS from GMC Aurangabad and MD Medicine and DM Oncology from BJ Medical College, Ahmedabad, Gujarat. Since 2013, he has been practicing as medical oncologist in Aurangabad, and currently he is working as a head of medical oncology in Seth Nandlal Dhuth Hospital, Aurangabad. He has successfully treated numerous cancer patients. He has been invited as a faculty for 41 national and 5 international conferences. And also he has been awarded as the best consultant oncologist in Maharashtra in National Healthcare Excellence Awards held in 2016. It is truly an honor to have you here, sir. I also request Dr. Mangala Mehta ma'am to chair this session.
She is Dean of our Saraswati Dhanvantari Dental College.
Thank you, madam, for a kind introduction. Thank you, IMA Parbhani. Thank you, Dr. Praful Patil Hospital for this for invitation. So I'll be talking on oral cancer updates in 2022. So few words about my specialty actually. I am a DM medical oncologist and privileged to be first DM medical oncologist in Marathwada region. So many don't know actually, I call it as medical literacy or cancer treatment literacy. So in general, in cancer treatment, there are 3 main pillars of treatment doctors, I call. It is like medical oncologist, surgical oncologist, and radiation oncologist. Radiation oncology is like after MBBS, they do MD radiation, radiotherapy. Surgical oncology, they are MS general surgery and followed by master in Shiari in surgical oncology. And medical oncology, that is, they are MD medicine followed by DM in medical oncology. So medical oncology, that is medicine related, we can call it as. So any medicine or anti-cancer therapies like chemotherapy is a one part, but other are, I call it as systemic therapy. So any therapy which is going into whole system, anti-cancer therapy, these are chemotherapy, targeted therapy, immunotherapy, hormonal therapy, either in oral form, IV form, subcutaneous form, intramuscular, there are, and intrathecal. There are many systemic therapy forms. So I will cover basics like what is cancer, its causes, why there is a rise in cancer incidence in India, and my topic, that is oral cancer, what are the causes, sites, how to there is a awareness need for screening and early detection, and some 2-3 slides about the before starting or head neck cancer therapy, mainly radiation and chemotherapy. Some prerequisites are there, some oral hygiene and dental treatments are there. We need to be clear in that. And lastly, what is the role of systemic therapy in head neck cancer? So cancer, it is a loss of normal growth control. So uncontrolled growth, cancer, it is genetic disease. Don't confuse with hereditary. Genetic disease, gene related, there is a gene mutations that can be hereditary or sporadic. So hereditary gene mutations, then call it as hereditary cancers. But there are mutations, there are carcinogens which cause mutations, and when these mutations are not there is a problem in balancing cell repair and cell death and cell replication, there is uncontrolled growth, and it's called cancer. So this is a basic slide where why there is a cancer. It is a preventable disease because there are 90% cases, there are environmental factors, and these are chemicals like pesticides, smoking, tobacco, alcohol. There are around 25% cases caused by viruses, bacteria, that is infections as a cause of cancer. And radiation, it may be like UV radiation or electromagnetic radiation and other environmental radiation, and they cause gene mutations and they cause cancer. So there is a rise of cancers in India, and we don't believe that India ranks third among all nations in terms of highest number of cancers. And obvious reasons are environmental factors that are, it is a like in other non-communicable diseases like diabetes, hypertension, the risk factors are same, like sedentary lifestyle, urbanization, rise in obesity, and tobacco, alcohol. There are the deadliest carcinogens, and its increase causes increase in incidence of cancer. So ICMR in 2021 estimated that there will be 12% rise in cancer cases in India by the next 5 years. And most common, as you know, there are breast cancer, cervical cancer, lung cancer, and today's topic, that is oral cancer. So more than 90% head neck cancer are squamous cell. Other are other sarcomas, lymphomas. We are not talking about that. And etiology is 90% cases, it is tobacco, alcohol, and in 10% cases, it is a human papilloma virus infections. So these are the picture of why, what are the risk factors associated with head neck cancer. These are tobacco, alcohol in many forms, chewing tobacco, smoking, and with tobacco and alcohol together, HPV 16, 18, betel nut, and other factors are radiation exposure, UV light radiation. So these are the sites of oral cancer. Oral cavity, so it is a buccal mucosa, oral tongue, hard palate, retromolar tygon, that is oral cavity. Some are as oropharynx. These are bilateral tonsil, soft palate, base of tongue, and other are hypopharynx, supraglottic larynx, nasopharynx, and why there are change in like sites. We have to differentiate because the therapy also differs as per the site. Mainly supraglottic larynx, and nasopharynx. Because even etiology, in etiology also, oral cavity, oropharynx, there are more of HPV related, but not in oral cavity. And nasopharynx, usually it is EBV, Epstein-Barr virus related. So there is a even change in biology of these cancers. So in India, it is called head neck cancer capital of the world, because there are 86,000 head neck cancer cases diagnosed each year, with 144 deaths a day due to head neck cancer. And there is a higher death rate than many other cancers. It is even if it is a very locally advanced head neck cancer, around 15 to 20% cure rate is there. So deadly it is. So we need to detect early, and that's why there are the more death rate is due to late detection, late referral, lack of awareness, and metastasis. So just for awareness, if you see this non-healing right buccal ulcer more than 3 weeks, so we have to have a high index of suspicion of cancer and need to be biopsied. If there is a lymph node, so it is not only tuberculosis, it could be metastasis from head neck cancer. So need to have suspicion, index suspicion high. So look out for this warning signs: oral sores more than 2 to 3 weeks, and pre-malignant lesions. These are leukoplakia, erythroplakia, dysplasia, submucous fibrosis. There may be lump in the neck, difficulty in swallowing, chewing, hoarseness can be due to hypopharyngeal cancers. So oral leukoplakia, it is a white patch, and it is a pre-malignant lesion, and it is due to tobacco chewing. Erythroplakia, it is more pre-malignant, or chances of malignancy are higher in erythroplakia. There is oral submucous fibrosis. We see day in, day out these population patients who are chewing tobacco. So this is the high risk population where we need to we need to screen for any early development of head neck cancer. So it is the problem in other cancers like lung cancer or ovarian cancer. So these are like if cancer is early, there is a growth started, but symptoms will be developed later. But in head neck cancer, it is easily visible lumps or ulcers are there. They are easily felt, has easy access. So we need not, we should not miss out this. And there was data, Indian data, that due to this effect of screening, there is a much oral cancer mortality was very much decreased, and it was published in Lancet 2005. So in general, these are concept of oral cancer management. There are local therapies, systemic therapy. Local therapy, this is surgery. That is the only chance of cure in mainly buccal mucosa cancer, and in hypopharynx or larynx cancer, radiation with chemotherapy is curable. So local therapies are must. Without any local therapy, chance of cure is not there. So many times I see patients who are, there is a early cancer, but they took alternative therapies and miss out the local therapy part, and they come in locally advanced case, and it becomes non-curable case. So in nasopharynx, oropharynx, radiation chemo is the treatment, and if it is a recurrent or along with radiation, there is a role of targeted therapy, chemotherapy. I will talk in next slides. So when patient is diagnosed with head neck cancer, there are some prerequisites or cancer oral health examination need to be there. If cancer is diagnosed, for example, larynx, and we need to give chemotherapy and radiation, if there is anything in the mouth problems, because there is a stomatitis, which is a problem, if oral hygiene is there, then these problems will be lesser. So any dental problems, we have to complete any invasive procedure at least 14 days before head neck radiation, and before 7 days at least before starting chemotherapy. And if there are elective oral surgical procedures, they should be postponed until cancer treatment is completed. So even if there is any sites of infections that to be identified and treated, like caries, periodontal disease, endodontic disease, mucosal lesions. So this any other oral trauma, irritating like ill-fitting dentures, orthodontic bands, this should be identified and eliminated. And many times, even in villagers, there is a scaling. So we have to do scaling also before any starting radiation and chemotherapy. And of course, oral hygiene is main to minimize the complications of radiation and chemotherapy. So during chemotherapy, many times call is from dental surgeon that whether to do surgery or any dental extraction or not. So we have to see whether there is a CBC is normal. So platelet count, WBC count should be normal before doing any surgery. So even after chemoradiation, there should be dental hygiene should be maintained to minimize the long-term complications. So just to tell that there is a more guidelines are there for oral dental evaluation and management, and that should not be missed out. So coming to my part, that is a chemotherapy. So as I said, there are surgical resection, radiation, chemotherapy, and depending on the stage, if it is a buccal mucosa, very size is very small, like T1 lesion, then only surgery will be suffice. There is no role of any radiation or chemotherapy. But as the stage goes up, then needs radiation, then added chemotherapy. So as per the stage, there are therapy, and the chemotherapy part, actually it addresses the issue of distant metastasis, because micrometastasis, if they are there, they're taken care by chemotherapy. So chemotherapy in general usually in the after surgery with adjuvant RT, that is post-op CT-RT, in where surgery is not don't have a role like base of tongue or hypopharynx or larynx, then with definitive radiotherapy, chemotherapy has a role. In some cancer, like locally advanced oral cancer, mainly in larynx and nasopharynx, there is a role of induction chemotherapy. In as an adjuvant chemo, that is when any definitive therapy has been done, there is no evidence of any disease, but we give chemo to prevent recurrence, that is called adjuvant chemotherapy. And in nasopharynx, there is a role of adjuvant chemotherapy. Many times I have seen that chemotherapy sometimes taken care by only radiation, and they give chemotherapy, radiation, and patient is sent back home, and that's how adjuvant chemotherapy is missed out, and then recurrence comes. So there is a role of adjuvant chemotherapy. Everyone should know that in carcinoma nasopharynx, mainly in stage 2, stage 3, as local advanced in very low, like low stage nasopharynx, there may not have adjuvant chemo role. And lastly, in recurrent setting, in palliative setting, there is a chemotherapy, targeted therapy, immunotherapy has a role, and everyone should be knowing that there are many long-term survivors, like 2 year, 3 year with these immunotherapies. So first is post-op CT-RT. So wherever indicated, there is a role for adding chemotherapy to the radiation, and to know that there are only 2 absolute indications where you have to add chemotherapy. that are extranodal extension and positive surgical margin. In other cases, there are some relative factors are there. So in those, there is, in some trials, there is a benefit, and some trials there is a no benefit of adding chemotherapy. So I call it as relative indications. So they are multiple positive nodes without ENE, perineural invasion, lymphovascular invasion, T3, T4 tumor, N2, N3, or positive level 4-5 nodes. So there is a doubtful role of chemotherapy, I can say. So in those cases, practically what I do, if it is a young patient, fit patient, and there are relative indications, I will add a chemotherapy. Many times 3-weekly chemotherapy is actually a standard, and level 1 evidence have 3 weekly. So in these cases, weekly chemotherapy will suffice, lower doses chemotherapy. But if patient is like old age and there are no absolute indications, then I may remove chemotherapy and only proceed with only radiation. So there are guidelines. There are actually, in general, in cancer treatment, there is a evidence and evidence-based practice we follow. And there are many guidelines like American guidelines, European guidelines, Indian guidelines. So they are based on the robust data. So we have to follow it. So we have to follow any one of the guidelines. So as per the recommendations, there is a role of cisplatin chemotherapy in after the surgery has been done, and that is a 3-weekly chemotherapy. That is a standard. But if patient is performance status poor, in those cases, weekly cisplatin also suffice. So in definitive RT, there is a wide options are there to add systemic therapy with definitive RT. And just to know that it is not only weekly chemotherapy in each and every case, there are other options which will individualize as per the patient's disease risk factors, age, performance status, his kidney status, and other like cardiac status and any other comorbidities. So cisplatin is the platinum, that is a chemotherapy 3-weekly. It is a standard. In other cases where we cannot give due to CKD or nephrotoxicity, then carboplatin 5-FU, that is injection, which we will give every 3 weeks, 2 to 3 doses in along with the radiation. So there are other also. There is a targeted therapy called cetuximab, that is a anti-EGFR antibody, which we can give with radiation, where chemotherapy is not cannot be given due to risk factors or comorbidities. And it is also, as per the histology, some treatment changes. So in in non-nasopharynx, there are different guidelines. In nasopharynx, only cisplatin has a role as per the data and clinical trials. And in non-nasopharynx, there is a data for other chemotherapies. But in nasopharynx, there is only cisplatin 3-weekly or weekly chemotherapy has a role. So coming to the induction chemotherapy, that is neoadjuvant chemotherapy. Before any definitive therapy like surgery, RT, we give chemotherapy to downsize the tumor. That is called induction chemotherapy. And it is mainly used in where surgery is not an option, and we have to facilitate organ preservation, mainly in nasopharynx, larynx. And in induction chemotherapy, there is a TPF docetaxel protocol or TPF paclitaxel protocol. That is the best. If patient is performance status is poor, then double agent is given. So this is the standard, just to know that TPF is a standard induction chemotherapy. And there is no data of induction chemotherapy in oropharynx. So if it is a like base of tongue or tonsil or soft palate, there we should not give induction chemo because there is no data. And it has seen that in RTOG 9111 trial, there is a role for induction chemotherapy. And after induction chemotherapy, same chemotherapy, some majority of time cannot be given, and we have to shift on either carboplatin or weekly targeted therapy after NSCT definitive therapy. And the other point is, if there is a radiological CR in post-induction, we can avoid also chemotherapy in those cases, mainly in old patients, larynx case and nasopharyngeal. So nasopharynx, there is of course there is no role of any surgery, only radiation and chemotherapy. So in adjuvant chemo, as I said earlier, that in nasopharynx it has a role, mainly in stage 2, 4A. There is, as per the guidelines also, we have to give, if there is a neoadjuvant chemotherapy not received, then adjuvant is must in stage 2, stage 4A CA nasopharynx. In non-nasopharynx, and we are coming to the recurrent setting, that is metastatic setting after surgery, chemotherapy, there is a recurrence and there is no curative option, then there is a role of immunotherapy. So many times patients ask if there is a immunotherapy in early stages or with definitive therapy. So there is no role of any immunotherapy in general. In cancer also, immunotherapy has a role only in recurrent setting and stage 4 setting. So now it is first level 1 evidence for immunotherapy along with chemotherapy. That is so it is a number 1 option. So if you want to get best therapy in recurrent setting or head neck cancer, then we have to give immunotherapy with chemotherapy. So in general, we check PD-L1 status in all recurrent setting. If it is a more than 20, then only single agent also can be given. But if patient progresses after, say, chemotherapy, then immunotherapy, we need not check that marker for whether immunotherapy will be useful or not, that is PD-L1. So other is a targeted therapy with chemotherapy, that is anti-EGFR, that is cetuximab, and it is also to be combined with chemotherapy. So these both are options. So sometimes immunotherapy cannot be given, so we combined chemotherapy, targeted therapy. So these are the number 1, level 1, there is a high chance of response with this type of therapies. Other are many palliative therapies, different chemotherapies, methotrexate, oral metronomic chemotherapies, and there is one tablet which is called afatinib. That is also has a role in recurrent setting. And in nasopharynx, as I said, there is a biology is different. So there is a role of a different chemotherapy in nasopharynx, that is a cisplatin gemcitabine. So we will not give cisplatin 5FU in those cases. Of course, it is an option, but we'll prefer cisplatin and gemcitabine chemotherapy in those cases. Thank you. If any questions, please ask. And you can ask anything about cancer. It's not about only head neck.
Thank you, sir, for your excellent talk. Sir has highlighted in 3-4 slides that early detection is the rule, because all head neck swellings, thorough oral examination is required, because it is very surprising. I'll tell you one case. Last month, I have seen one parotid swelling. Patient had for 3-4 months parotid swelling, and she had a multiple FNAC done, which showed a infective. So when I did an oral examination, I found an ulcer in upper GB sulcus, which was blocking the parotid duct, and which came as a squamous cell carcinoma. So 4-5 months, no one had done an oral examination. So it would have really saved the time, and we would have started a treatment earlier. So last week, the patient has already received a chemotherapy.
Nice. Interesting.
Yeah, thank you, doctor, for an enlightening lecture. So many things we did not know really. We were just, we used to be really day in and day out, we deal with precancerous lesions, in our department. So that was really nice. You talked about immunotherapy. That was really new for me. So very nice. And just can I know the role of PDT, photodynamic therapy in squamous cell?
Yeah, actually, it's not my topic actually. We don't deal with photodynamic therapies, and maybe radiation oncologists can tell that But in at least in head neck cancer, okay, not for pre-malignant lesions, but in proper head neck malignancy, there is no role of any photodynamic therapy. And usually pre-malignant lesions, they are usually seen by surgeons. So mainly medical oncologists, as a medical oncologist, I don't know anything about photodynamic therapy. So there is a one question. What is benefit of immunotherapy in known case of HIV positive suffering from cancer? So in general, there is a separate guidelines for HIV patient, any cancer. So first and foremost is, if it is a HIV, irrespective of CD4 count, we need to give antiretroviral therapy. Second thing is this viral load must be controlled before starting any therapy, not about only immunotherapy. Actually, if it is a like CD4 is like not low and it is more than 50, so I think immunotherapy can be given. There may be chance of more reactions like we see with ART. So if patient is newly HIV positive, if we give ART, there are reactions. So there is chance of toxicity or more, because there is like what actually immunotherapy does, we give some injections which will increase the anti-tumor specific immunity by increasing the T cell regulatory cells. So there may be chance of reaction with immunotherapy in HIV positive cancer patients.
I think the questions are over. Can I please request the chairpersons to present our token of appreciation to Dr. Devdi, sir? I invite Dr. Bakul Kulkarni ma'am on stage to welcome our chairpersons. After so many brain whacking sessions, I guess now it's time to regenerate. Okay. Welcome, Dr. Kalani sir, our MMC observer. Please come on stage. I request Dr. Kane sir to felicitate Dr. Kalani sir. As I know, they are best of friends. After so many brain whacking sessions, I guess now it's time to regenerate our neurons and to cater our hunger cramps. Let's meet after the lunch break.
येतोय का सर? मिले सुर मेरा तुम्हारा तो सुर बने हमारा सुर की नदियाँ हर दिशा से बह के सागर में बादलों का रूप लेकर बरसे हल्के हल्के सुर में था तुम्हारा तो सुर हमारा सुर में था तुम्हारा Join entertainment.
भक्त पुकारे दूर करो प्रभु दुख हमारे दशरथ के घर जन्म पतित पावन सीताराम
Please have a round of applause for the anchors, without whom the session will not be able to complete it, right? Dr. Pallavi Dodke. Now I will hand over the mic to Kade ma'am.
Once again, going ahead with our series of interesting sessions, I accord a warm welcome to Dr. Virendra Vadgaonkar, sir. He will enlighten us on the role of diagnostic bronchoscopy and medical thoracoscopy in current practice. Can we please have up on stage Dr. Rahul Ambegaonkar, sir, and Dr. Sudhanshu Deshmukh, sir, to chair this session? Dr. Virendra Vadgaonkar, sir, has done his MBBS and DTCD. He is currently working as chest physician at Orient City Care Hospital, Aurangabad. He has specialized in interventions like thoracoscopy and bronchoscopy. Handing over the mic to you, sir.
Thank you, ma'am. Good afternoon, everyone. Thank you for inviting me to Parbhani for this session. So my topic is role of medical thoracoscopy in current practice. It was originally actually bronchoscopy plus thoracoscopy. It was too long, so we selected as a medical thoracoscopy in current practice. This is a challenging session. We are in a post-lunch session, so I will make it short and seem more practical. So medical thoracoscopy, or it is also called as pleuroscopy, is a minimally invasive procedure that allows access to the pleural space using combination of viewing and working the instrument. So originally it was done by for many years by CVTS surgeons, cardiac surgeons, because it requires many times thoracotomy or VAT surgery. But since last 8 to 10 years, due to arrival of new scopes by Olympus, so it is a very less invasive or minimally invasive surgery now. It allows us the basic diagnostic, undiagnosed pleural fluid and pleural thickening, and therapeutic procedure like pleurodesis to be performed safely. So as I said, it is earlier it was VATS like performed by thoracic surgeon in OT under GA with double lumen endotracheal intubation with single lung ventilation with multiple ports, and many times requires thoracotomy during surgery only. But nowadays, almost 90% of the cases we do by medical thoracoscopy. It is done by, of course, interventional pulmonologist. It is done in endoscopic suite under conscious sedation and local anesthesia. Patient takes spontaneous breaths, no requirement of any endotracheal intubation or lung ventilation or mechanical ventilation. Port is normally single. Sometimes we require double port, but it is normally single port. So we do diagnostic and therapeutic procedures with medical, minimally invasive medical thoracoscopy like pleural biopsy, chest tube insertion, TAC pleurodesis, and deloculation. So many of the cases like pleural effusion or multiloculated pleural effusion earlier used to be done with ICD, or in advanced stages it is done by with VATS by CVTS surgeons. But nowadays many cases, many physicians are very aware of these cases and they refer it very early so that patient undergo very on a procedure under conscious sedation and ELA. So indications for medical thoracoscopy, these are diagnostic and therapeutic indications. Pleural effusions of unknown origin. Diagnostic yield in these cases is 93 to 100% with medical thoracoscopy, but only with fluid cytology we diagnose 62% of the cases suspected tuberculous effusion. and suspected malignancy with inconclusive cytology and evaluating the chest trauma. In many of the chest trauma cases, we do the medical thoracoscopy. Oh yeah, these are the diagnostic indications. In therapeutic indications, main is pleural disease, tal pleural disease in malignant or recurrent pleural effusion, benign pleural effusions, and recurrent pneumothorax. This is the main therapeutic indication in these cases. And other side, deloculations, dividing the adhesions in recurrent or persistent spontaneous pneumothorax, or in empyema, pleural dilating in fibropurulent empyema. So these are the therapeutic indications. So, but main is pleural disease and deloculation. So what is flexi-rigid thoracoscope, or what is medical thoracoscope? It is a semi-rigid pleuroscope. It is a pleura videoscope model LTF by Olympus. As I said, in last 10 years, it is in the market. And since then, this procedure is very easy now. Consists of handle that is similar to standard flexible bronchoscope. It has a measurement of 7 mm outer diameter and 27 centimeter of length. The shaft is made of two sections. Just I am giving a small introduction of the scope. So it is a 27 proximal. It is a rigid portion, and 5 centimeter distal end. It is a flexible scope. The flexible tip is movable by lever on the handle, which allows two-way angulation. It is up 160 degrees, and whenever lever is down, and if we put lever up, then it goes down by 130 degrees. So we get an excellent visualization of the pleural space. It also has 2.8 millimeter of working channel. Through this working channel, we put bicep, forceps, needles, cauteries, lasers, everything we can do this with this scope. Of course, it is a little bit costly scope. So this is the one is the rigid scope and other is the flexi rigid scope. This is actually flexi rigid scope. So you can see the shaft. This is the shaft of 27 centimeter. First 22 centimeter it is rigid, and last 5 centimeter is very flexible. You can see angulations over here. Upper angulation is almost 160 degree and lower is 130 degree. So you can visualize the pleural space excellently. With VATS or other procedure, we cannot visualize the pleural space. We have to make them 2-3 ports for visualization of the pleural space. So this is the rigid trocar and cannula. With this, after taking incision, I will just say this. This is the local anesthesia part. Local anesthesia with local infiltration of the lidocaine, midazolam. Of course, it is done by anesthetist. Standby anesthetist is always there. They use propofol and they are ready for many times intubation, but many times it is not required. In some cases with COPD, we may require. So this is the actual position. It is lateral thoracic region between the mid axillary and anterior axillary line. In 4 to 7 intercostal space, we take the incision. But normally it is taken in 3rd to 4th space, because many times diaphragm is very upwards and we can traumatize the diaphragm. So generally it is in 4th space. And there are vessels in the intercostal space. We can see this is the external intercostal muscle, internal intercostal muscles, and in between transverse group of muscles, there is a neurovascular bundle. We can see the nerve, intercostal artery, and the vein. So always the incision is taken at the upper margin of the lower rib, not at the lower margin of the upper rib. So because this intercostal artery is very tortuous sometimes and it bleeds like anything. So incision is very important. There are 3 muscles, as I said, lies in the, and the neurovascular bundle lies in the groove of the inferior aspect of the lower upper rib. Posteriorly, the bundle lies in the middle of the intercostal space between 5 to 8 centimeter lateral to the spine. Intercostal vessels may sag in geriatric. In old patient, these vessels may sag sometimes. So we have to be very cautious during the incision. So this is the actual procedure. After taking the incision, we insert the trocar like this. After taking a small incision normally 1 to 1.5 centimeters. So even after removal of the ICD, we need not to take any sutures for this incision. So it is hardly 1 to 1.5 centimeter of the incision. Patient in the lateral decubitus position, the arms placed over the head in order to increase the size of the intercostal space. So whenever we do this type of position, this intercostal space increases and we take easily we can take the incision. Local anesthesia with 2% xylocaine we take and sedation with the midazolam. A small caliber trocar of 14 mm, what I have shown you, is introduced in the intercostal space after incising the chest, and we induce a small pneumothorax so that the lung collapses and we get a visualization of the pleural space. So increase the pneumothorax by insufflating air with the 60 ml of syringe. So hardly 60 ml air is required, but many times it is filled with pleural fluid, what are whichever we indicate like a pleural effusion or pneumothorax. So we need not to insufflate the air in the pleural space, but if sometimes required, hardly 60 ml air is required. So these are the pleural biopsies. Most of the pleural biopsies are taken in the posterior costal pleura because anteriorly we got mammary artery, internal mammary artery, and intercostal arteries also. So generally it is in posterior costal pleura we take the biopsy. Biopsy specimens from the parietal pleura over the rib. It is to be taken over the rib. I will show you the video. Because in between intercostal space, many times you take the biopsy of muscle only, not the pleura. Ideally, specimen should not be taken from the apex or anterior parietal pleura, as I said. So pleural pathology, like tuberculous pathology, like we can see the diagnostic yield with pleural biopsy by medical thoracoscopy is 70 to 90%. Needs 6 or more biopsies for this. Thoracoscopy may offer higher tissue culture with positive rates of the culture. So in tuberculous pleural effusion, we see the visualize the grayish white nodules or granulomas over parietal or anterior or diaphragmatic pleura, anterior or posterior. Multiple biopsies are taken for this. And TB culture is always positive if we take by medical thoracoscopy with culture with histopathology. It is almost 100% of the diagnosis. Nowadays, we can see many cases of MDR tuberculosis or XDR tuberculosis. So culture is very important. So this we see the in tuberculous pleural effusion. In thoracoscopy, in pleural malignancy, pleural fluid cytology hardly shows any time, many time atypical cells or it positivity rate hardly goes up to 60%. We may miss the case. It patchy involvement of the pleural cavity, involvement of the visceral pleura, lower hemithorax, diaphragm involvement is always there in malignancy. So we take multiple biopsies of the parietal pleura. Thoracoscopy in pleural malignancy. Thoracoscopy is a recommended procedure in patients with undiagnosed effusion and negative pleural fluid for cytology or who are suspected of having malignancy. We can see elderly patient over after history taking, we many times suspect malignancy. So in this patient, it is very much indicated. Diagnostic yield with thoracoscopy is over 90% in the malignant effusion. Pleurodesis also can be performed during the same setting if the biopsy is positive on site cytology during thoracoscopy, or if the macroscopic view, in general view of the pleural space, we see the malignancy like nodules or big masses in the pleural space. We can, in the same setting, we can do the pleurodesis by study talc. So this is one of the video. So in this field also you can book load of that. In this photo also you can see the pleural space, whatever fat is seen, that is exactly over the ribs, and in between there are the muscles, intercostal muscles. नहीं होते क्या? Okay, we'll see afterwards. So in malignant mesothelioma also, thoracoscopy is important. Routine cytology examination of the pleural fluid has sensitivity of hardly 32%. So blind percutaneous needle biopsy, hardly there is sensitivity of 50% of the diagnosis. Thoracoscopy allows complete visualization of the pleural cavity and multiple biopsy samples we can take. It helps in the early diagnosis of the lesion or any malignancy. A concern of tumor spread along the chest drain is always there. So we do many times we advise irradiation with the 7-gray or 3 days within 15 days of the procedure. Recurrence of the prevention of the malignant effusion. So many of the malignancies like lung malignancy, breast malignancy, lymphomas, ovarian primary, other primary malignancies, always there is pleural, many of the times, not always, many of the time there is pleural effusion, it is malignant pleural effusion, and it is always recurrent malignant pleural effusion. So to palliate the symptoms, we do with medical thoracoscopy, you can completely evacuate the pleural fluid with maximization of the lung expandability by removing the adhesions. So it palliates the symptom of the patient. Prevention of fluid reaccumulation by obliterating the space by pleurodesis, long-term success rate is more than 90%. With Steritalc, it is almost 99 to 100%. That I will show you afterwards. So chemical pleurodesis is done by most of the time talc, that is Steritalc, but in some institution they do with the tetracycline, doxycycline, bleomycin. Many of the chemical agents are there. In iodine also one of the agent. So in talc pleurodesis, it is a specific form of chemical pleurodesis. Talc is the most effective sclerosant available pleurodesis in the malignant pleural effusion as compared to indwelling pleural catheter placement. Talc pleurodesis has been shown to be equally effective in relieving the dyspnea. Talc is a predominantly hydrated magnesium silicate. It also has varying amounts of calcium, aluminum, iron, and lead. But definitely talc, it is always asbestos free in, because in many of the lung cases, asbestos is very common. So it is always asbestos free. It contains several mineral contaminants also, but without asbestos. Particle size is mostly more than 15 micron to avoid the systemic side effect and pleural outcome. Average size is 25 micron of this talc. Lower size of the particle like 5 to 10, it may cause intense systemic inflammation also by absorption in the systemic circulation. So it always above the 15 micron up to 25 micron size of the talc particle. So again, one video is there. These are excellent videos, but I can't play it. Recurrent pleural effusion of the benign etiology and thoracoscopy. In many of the, we do the pleurodesis in malignant pleural effusion.
सगळं प्ले होतात पण
हा नाही तिथे झालं होतं प्ले नाही बघितलं
आजचे पण पीपीटी झाले ना प्ले
हो ना
स्लाइड नंबर
पुढे पुढे जाऊन
first video.
नाही ठीक so we can't play the video. So in many of the other non-malignant cases, we do pleurodesis also. Some of the heart failure cases, recurrent effusion in heart failure cases, cardiac surgery, nephrotic syndrome, connective tissue disorder, other any inflammatory disease. But sometimes there are chances of failure of the pleurodesis in these cases. Occur. Sorry for the disturbance. नाही आता फक्त मला दाखवत होते व्हिडिओ प्ले होणं अवघड दिसत. हा ठीक. So thoracoscopic pleurodesis is indicated when the recurrent effusions causes symptoms in this patient in non-malignant cases also, and it is not controlled by repeated large volume thoracocentesis. In these cases also pleurodesis is indicated. अरे हे पुढे पण नाही जात नाही. Spontaneous pneumothorax, it is also one of the indications for the pleurodesis. Persistent or recurrent pneumothorax, recurrence rate of the pneumothorax always increases. We know after first pneumothorax or primary spontaneous pneumothorax, chances of second pneumothorax is always high, like 20%. And third time chances of pneumothorax are almost 40%. So in these cases, primary spontaneous pneumothorax, pleurodesis is very much indicated, and it is attributed with these cases with talc insufflation. Of course, quantity of talc is required is very less in pneumothorax cases. And other excellent alternative is repeated chest tube drainage, but with drainage also there are chances of recurrent pneumothorax. So talc pleurodesis is an excellent therapeutic procedure for this primary spontaneous pneumothorax. Empyema in complicated parapneumonic effusion after failure of the chest tube drainage and fibrinolytic therapy, fibropleurant stage with pleural pills entrapping the lung in these cases, and for deloculation, fibrinolysis, chest tube insertion in the exact area of the pleura under direct visualization, and mechanical removal of the infected material. This thoracoscopy is very much indicated, and it gives excellent result. Empyema in thoracoscopic drainage, especially in the frail patients with high surgical risk, entry site is confirmed by, of course, sonography. Aspiration of the liquid is done, and after that exploration of the thoracic cavity, and we identify the loculations and we break the loculations, and we rarely see foreign bodies in this. Opening the loculation is very important in these cases. So this was also excellent video, but we can't play video right now. Removal of the fibropurulent membranes from the cavity and from the parietal and visceral surfaces, cleansing the pleural space with the saline solution. When the thoracic cavity has been emptied, a careful exploration of the pleural surface is carried out, and if necessary, biopsies are always performed. But generally, whenever we enter the pleural space, we generally take pleural biopsies, whether it is a malignant, non-malignant, or for empyema, for the culture and all these things. Finally, a large bore chest tube is introduced. In empyema cases, we put a 28 size ICD, and in general malignant or pleurodesis cases, we put 20 F ICD in these cases. So complications of the thoracoscopy, generally it is a very safe procedure, but desaturation during the procedure, persistent air leak in some cases, subcutaneous emphysema, postoperative fever due to infection and empyema, and hardly death is very less, but we have not seen any death, and negligible are benign cardiac arrhythmias and transient hypotension. These are general complication, but generally it is a very safe procedure. Prevention of the complication, of course, postpone the thoracoscopy for several days if patient is coughing or having fever, high-grade fever, measure blood gases and monitor the cardiac status by ECG and 2D echo. Oxygenate the patient during thoracoscopy. Avoid taking biopsy samples from the internal parts of the fissure or mediastinum, and coagulate and ensure the hemostasis. So what are the contraindication? Only one absolute contraindication is there, that is the absence of the potential pleural space. Many of the cases like chronic pleural effusion cases or empyema cases, we don't get the pleural space to insert a trocar and pleuroscope. In these cases, it is the absolute contraindication. If we get a space more than 6 to 10 centimeter, generally then only we take a incision. That is done by USG. We can see in USG or CT chest. Relative contraindications are, of course, uncorrectable coagulopathy, multiple pleural adhesions, unstable cardiorespiratory status, uncontrollable cough, inability to lie flat for an hour, and severe chest wall deformity. Conclusion: pleuroscopy allows the pleural cavity to be visualized under local anesthesia with sedation and intravenous anesthesia. It is a procedure of choice in the diagnostic workup and, of course, therapeutic in for pleurodesis in malignant pleural effusion and pneumothorax. It allows the pleurodesis in the same setting in malignant effusions. Thank you. And sorry, videos were excellent. Actually, our own cases were there.
Hello. You can directly open the videos, no? Instead of this slideshow. Sagar, direct folder मधूनच open कर.
त्याच्यात हेच व्हिडिओ
हा.
होते.
Yes, yes, please those videos.
इनकॉर्पोरेट केले की ते प्ले व्हायला थोडंसं
अच्छा हे होईल का?
हे ऍप्लिकेशन सेपरेट
थोडंसं पुढे करता येईल ना याला? हा. So this is, I think, this is a case of pleurodesis. We have taken biopsy in these cases. We can see the nodules. This is a case of malignancy. We can directly see the nodules or pleura. So this biopsy we are taking with the forceps. So this was the nodule. This was a adenocarcinoma of the lung with deposits in the pleura. थोडंसं पुढे जाता येईल का? ठीक आहे ना, काय हरकत नाही. So after visualizing the whole of the pleura, and these are the nodules, these are malignant nodules, we can see. These are the malignant nodules, adenocarcinoma of the lung with secondary is in pleural space. After taking multiple biopsies of the nodules, we have done pleurodesis in this patient. So this is also biopsy forceps. We can see the nodules and the biopsy. So I will show you the pleurodesis part. So black part we can see this is a lung, collapsed lung, and this red part is pleura, parietal pleura, anterior and posterior parietal pleura. So these are the malignant nodules. We've taken multiple biopsies. So this is the talc pleurodesis. We can see the talc after inserting a wire into this. We do the talc pleurodesis. This is the talc. We are insufflating the talc through this wire through the thoracoscope. This is called as classical snowstorm view of the pleurodesis. You can see the talc. It is going all over the pleura. So this is equal distribution in the anterior, parietal, and mediastinal pleura. So it has got excellent result with pleurodesis. There are no recurrences of the effusion. We can see the talc over here. This is talc pleurodesis. So all over pleura, anterior pleura and posterior pleura, we insufflate the talc. Only before doing the pleurodesis, one thing we have to always think is lung will always expand after the procedure, because many of the cases in malignancies, if endobronchial mass is there, huge endobronchial mass is there, so lung will always be collapsed. In these cases, we first do the bronchoscopy. We see the lung can be expanded after the procedure, then only we do the pleurodesis, because otherwise it will be a failed pleurodesis if lung doesn't expand. So this was one of the case malignancy with pleurodesis. We'll just show within 2 minutes another video. This is also, you can see the lung. This is a lung, and after that we can see the pleura over here. This is a posterior parietal pleura. So this was a case. This patient has visited the orthopedician multiple times in last 6 months for backache. Multiple investigations were done, but after some time, one of the physician has seen some pleural fluid is there. So the patient was referred here. So after doing the thoracoscopy in this patient, we can see the only a small mass is there in the posterior parietal pleura, gutter of the posterior parietal pleura. So this case was undiagnosed for almost 6 months due to a patient was having only complaint of backache. So she was always seen by orthopedicians and or 1 or 2 physicians, but after referral, small pleural effusion, patient was referred, and this was a small mass in the pleural space. So we have taken biopsy, and after that we done pleurodesis in this patient also, because it was obviously a malignant mass. Third video. One of the last video I will show you. This patient is from Parbhani only. My dear friend has referred this. So this patient was having loculated pleural effusion. What locules I was saying, you can see over here. These are the multiple locules we can see. So we have broken these locules, and patient almost was very much symptomatic and hardly any these locules we can see. So we have broken these locules, and all the adhesions we have broken, and patient was almost asymptomatic and relieved and afebrile after this procedure. So this is one of the case, very interesting case. Patient was tapped once or twice for 1 liter also. After some delay, patient may have gone for VATS or thoracotomy or decortication. Still, this patient is under vigilance because 1 month is there. Some patient after that also we develop thick pleural thickening, so they may go also many times go for the decortication. But we have done excellent work in this patient. So almost it has taken 2 hours for us to deloculate this patient. These are extensive loculations you can see everywhere over there. So we have to deloculate these adhesions, and we have to break the adhesions between pleura and lung so that the lung will expand normally. So these are the locules you can see. And after UAG guidance, multiple septae were there. After UAG guidance also, if you do pleurocentesis, hardly we can tap 100 ml or 200 ml of fluid in these patients. So this was a case of multiple loculations. We have broken almost all the locules and put a 28 gauge ICD in this patient. The patient is excellent after 1 month. Still, it is under vigilance. So these were the cases, basic cases. Thank you.
Thank you, Dr. Vadgavkar, for your excellent talk. If somebody has any questions, the case number 3, she was came to us for hydropneumothorax. Initially, she was reluctant for admission.
There were multiple fluid levels were there.
That's why we convinced her to and referred her, and she came very excellent results. She is asymptomatic now.
Almost asymptomatic. Still, we'll see her after 2 months. Many patients sometimes develop decortication may be required, but we'll see. But right now, she is excellent, febrile, asymptomatic. And we have done almost 2 hours procedure in this patient. Thanks.
Sir, difference between pleuroscopy and thoracoscopy, is it same or?
It is same. It is a medical thoracoscopy and pleuroscopy. Only wording is different, other it is same. Only VATS is different. It required 2 ports. It is done under general anesthesia. And this is medical thoracoscopy is same as pleuroscopy. One rigid pleuroscopy is there also there. It is normal. It is nowadays it is not done generally.
Decortication possible through medical?
No,
or
no,
VATS
no,
only?
it is only VATS or open thoracotomy.
Open, yeah, that's all. Sir, please.
Yes, sir.
Nice presentation.
Thank you, sir.
This sometimes this pleurodosis is required recurrently. Sometimes 2 or 3 cities.
Almost in my cases, almost it was successful. Selection of the cases is very important, sir. Whether lung will expand, and only doing the pleurodosis is not important, but whether lung will expand after the procedure, it is the main question. So we have to many times apply negative suction for 12 to 24 hours, so the lung will expand. Or we have to do a bronchoscopy. If malignancy is there, we have to rule out any major mass is there in the main bronchus, right main bronchus or left main. In that cases, lung will never expand. So we cannot do pleurodosis in these cases.
TAL, as you have said, TALC is most commonly used.
It is most commonly, not commonly, it is actually, it should be used because particle size is excellent and it has got excellent inflammatory properties. It does intense inflammation of the pleura. So the pleurodosis,
good results.
and but it is very costly. One bottle of 4 gram is almost 7,000 to 8,000. So many times powder is required, many times 4 to 8 gram. It is little costly. Otherwise, doxycycline or oxytetracycline, it is hardly 100 rupees bottle. It is very cheap, but success rate is very high in talc pleurodosis.
Talc sometimes causes some severe allergic reaction.
No, sir.
No.
Generally.
Tetracycline, I think.
Tetracycline sometimes. Tetracycline almost no one does right now with tetracycline. It is almost used right now is Steritalc only.
Okay. You have shown some indications in some medical conditions like heart failure.
In a recurrent,
what exact role?
Role
like
of only
pleural effusion.
Pleural effusion, because these patients are symptomatic. बऱ्याचशे patient बऱ्याच वेळा multiple times they tap होतात with diet or diuretic, effusion is not resolved. In these cases, hardly we have done hardly 10 cases. It is successful, but 2 cases it was not successful. But it is one of the indication, relative indication, not absolute indication.
No, this effusion is a part of failure. Okay.
Failure, yes. Unilateral effusion, if it is recurrent effusion after tapping also, after dialysis also, after giving a high dose of diuretic, in these cases, sometimes we do, but is it not an absolute indication?
Yeah, it's type of resistant cases.
Yes.
Yeah, thank you.
Thank you, sir.
Thank you.
Thank you so much, sir, for the informative session. We all enjoyed it. Now, I request chairpersons to felicitate Dr. Virendra Vadgaonkar, sir. And I would like to call Dr. Karle, sir, on the dais for the felicitation of chairpersons. Dr. Karle, sir. चंडक सरांना घेते आणि परताना सरांना आणि मग पुढच्या सेशनला जांभरे सर. Thank you so much, Dr. Sudhanshu Deshmukh sir, Dr. Rahul Ambegaonkar sir, for now our next speaker, Dr. Rajkumar Gumre sir. He is a renowned cardiologist from the Aurangabad. He is practicing since last 10 years. He has completed his DNB cardiology from the Fortis. He is skilled in temporary and permanent pacing, ICD, CRTP, CRD, and coronary angiography, and many more skills. Now, for the session of Dr. Gumre sir, I would like to invite Dr. Chandak sir, GM Chandak sir, physician GM Chandak sir, and Dr. Cardiologist Kaustubh Partani sir as a chairperson. Next. Okay. Also with us today, we are having the senior most anesthetist and our guru, Dr. Zambre sir. So he is also invited on the dais for as a chairperson. So we have 3 chairpersons. Dr. Kaustubh Partani sir is cardiologist, Dr. Chandak sir, and Dr. Zambre sir. Thank you very much. Over to you, sir.
Good afternoon, everyone. It's a pleasure being here on this Sunday afternoon. Thank you. At the outset, I would like to thank Dr. Praful Patil, Dr. Vidya Patil, and the whole organizing team of this conference. I would like to also thank the IMA and all the chairpersons for inviting us and giving us an opportunity to be part of this academic feast. So without wasting too much time, I will start my topic, approach to diagnosis and management of supraventricular tachycardia. As a student, I always remember how scared I was of ECG. During my medicine exams, I was scared that somehow I could escape that ECG part during my exam. But later on, this turned out to be the bread and butter for me. So yeah, we'll start off with a case because this is how the patients present to us. This was a lady in her 40s who presented. She had no comorbidities, non-diabetic, non-hypertensive. She had recurrent episodes of palpitations. During the palpitations, she used to also complain of feeling of pulsating in her neck, sometimes occasional sweating, mild giddiness. On examination, her heart rate was in the range of 180, 190. BP, she was holding on 110/80. Otherwise, examination was unremarkable. 2D echo showed a normal study, which was done later, of course. This was her ECG when she presented to us. So as we all have seen such kind of ECGs during our emergencies. Basically, patients presenting with palpitations and having such kind of ECG. As we can see, this looks like a narrow complex tachycardia. By narrow complex, we mean a QRS duration of less than 120 milliseconds. That's less than 3 small squares ECGs presenting. We call them as narrow QRS tachycardia. So this is a narrow QRS tachycardia. Just the look of it looks pretty regular. And we have been trained in our UGs and PGs that this is a SVT or a supraventricular tachycardia. Because it presents in episodes, we also call it as a PSVT or paroxysmal supraventricular tachycardia. So basically, what is supraventricular tachycardia? It is a tachycardia which has origin, the circuit of the tachycardia or the arrhythmia lies either partially or completely in the atria, supraventricular, above the ventricles. There is only one supraventricular tachycardia which the circuit involves part of ventricles. That is the pathway related WPW syndrome tachycardias. The circuit involves the atrium as well as the ventricle. Otherwise, the rest of the supraventricular tachycardias, the circuit of the arrhythmia is totally in the above the ventricle, that is the atria. We all are aware that the conducting system of heart is like the electric supply of our heart. So any abnormality in this circuit can give rise to various arrhythmias. So supraventricular tachycardia is as such is a very broad term. It includes sinus tachycardia. SNRT is a rare diagnosis, but commonest one are atrial fibrillation, atrial flutter, junctional tachycardias. But those ones which present as SVTs or paroxysmal episodes are the 3. That is AVNRT, AVRT, and atrial tachycardias. We'll have a brief introduction to all these 3 in our talk. So how do we approach a diagnosis in cases of SVT? Can we differentiate these different tachycardias on the basis of some ECG clues? I'll try to keep it simple. I'm aware
that all are not physicians. So basically, a very simple thing. First of all, when we come across a ECG of tachycardia or an arrhythmia, look for regularity. We all have been taught, take a piece of paper, use a pen and draw 2 or 3 lines at the QRS complex and just see whether it matches everywhere. So that way we assess the regularity of any tachycardia. So that holds true. We should keep on doing that. Look for presence or absence of P waves. Can we see a P wave in that ECG? Next is after regularity, look for P wave. Next is look for RP interval. If you can see a P wave, try to judge what is RP interval. I'll be telling about RP interval. And lastly, if we cannot make out anything, just like our last patient, we just see a regular narrow complex tachycardia, try to do a vagal maneuver or try to give an adenosine, because it may not be just therapeutic. Sometimes it also aids in the diagnosis of the tachycardia. So any narrow QRS tachycardia, the first step, whether it is regular or not. So let us say that the ECG presented to us was not regular. We have done the 3-line thing, and so the ECG shows that the tachycardia is not regular. So the commonest 2-3 diagnoses which come in the narrow complex and irregular tachycardia, commonest one which we all have seen time and again is atrial fibrillation. Next, after that is atrial flutter, and rarely in patients, especially of Vadgavkar specialty patients of COPD, they may come with multifocal atrial tachycardia. It's not a common diagnosis again, but atrial flutter and fibrillation, I am sure you all have seen. So just an ECG example. As we can see, this is again a narrow QRS tachycardia, and clearly we can see that it is irregularly irregular. There is no P wave seen and it is irregularly irregular. Only the central part of ECG, you may think that it is slightly irregular. Yes, it is atrial fibrillation. We have been taught irregularly irregular, P waves absent, and F waves or fibrillary waves may be seen in some ECGs. So these 3 things help us in diagnosis of an atrial fibrillation. Rarely, when the rate is very fast, it may appear to be a regular tachycardia. When the rates are fast, look at the central part of the ECG. If the rate had been very fast, we may not have been able to diagnose. So sometimes do a simple trick, increase the speed of the ECG machine from 25 to 50, and it may help you by bringing out the minor irregularity in the QRS complexes. Next is again a classical teaching, sawtooth appearance of the P waves and the long lead, lead 2 and lead V1. These are the leads which we should look for P waves. So if we look at the long lead 2 at the base, we can see that sawtooth appearance of the P waves. Sawtooth appearance and the conduction of the sawtooth P waves to the QRS complex is not regular. In flutter, it can be regular, like 2:1, or it can be irregular. Here it is varying block. Sometimes after 3 flutter waves, there is 1 QRS complex, sometimes after 2. So this is a case of atrial flutter with variable conduction. So atrial fibrillation and flutter are the tachycardias which will have irregularly irregular rate on the examination and ECG. The third diagnosis again was referred by chest physician, call was given. In this tachycardia, it is irregularly irregular, but next thing what we have learned is look for P waves. So we can see the P waves in this ECG on the long lead 2, and we see different morphologies of P wave. To diagnose it as multifocal, we should have at least 3 morphologies, 3 or more morphologies. So I have pointed it for you. There are multiple various morphologies of P wave in this. So this is a case of multifocal atrial tachycardia. Management of such patients usually require us to tone down the treatment of COPD. Like they are on beta-2 agonists, they are on derifylin, all such drugs which increase the heart rate, increase the automaticity of atria. So we just need to reduce it a bit and sometimes maybe give some calcium channel blockers. So this is a multifocal atrial tachycardia. So we have seen the narrow QRS tachycardia, irregular part. So what if it is regular? So what should we do next? Look for P wave. So whether P wave is seen or not. So if P wave is seen, there can be 2 things. Are the number of P waves equal to QRS complex, or if it is more? So number of P waves, if it is more than QRS complex, for example, say 2 flutter waves and 1 QRS complex, or 2 P waves and 1 QRS complex. So there are 2 simple diagnoses. One is flutter, which we have already seen here. Last flutter, the wave conduction was variable. In this atrial flutter, again sawtooth appearance, and after every 2 flutter wave, there is 1 QRS complex. So it's an atrial flutter with 2:1 conduction will again be regular, and P waves will be more than QRS complexes. And second one is atrial tachycardia. Here again, there are 2 P waves and 1 QRS complex. This is again rare tachycardia, not very common. We'll just focus more on the common ones. So if number of P waves is equal to QRS complexes, if it is not more, look at the RP interval. This is the third step. So RP interval, what is RP interval? We'll see that. So if RP interval is more than PR interval, what are the possible diagnoses? Commonest diagnosis is atrial tachycardia followed by sinus tachya. Leave the other 2 ones. So basically RP interval, we all know the PR interval which has been taught to us in ECG, that is from beginning of P wave to beginning of QRS complex, that is PR interval. So RP interval is from beginning of R wave, that is beginning of QRS complex to the beginning of P. So this is RP interval. We have to see the length of RP interval in comparison to PR interval. So depending on that, long RP interval either can be 2 diagnoses. One is atrial tachycardia, and second, so this was a case of atrial tachycardia originating from the right atrium, lower part of right atrium. See the P wave in inferior leads, that is 2-3 AVF. The P wave is inverted. The origin is from down below, it is going up. So this was a case of atrial tachycardia originating from, sorry, I skipped probably. Yeah. Atrial tachycardia. Next is if the RP interval is shorter than PR interval. The diagnosis, common diagnosis for a very short interval is the AV and RT. This is the commonest type of SVT, that is AV nodal reentry tachycardia. This, if we see 100 patients of SVT, almost 60 to 70% are these subset, that is AV and RT. And sometimes P wave may not be seen at all. Like in this short RP wave, RP interval, the P wave is just seen here. I have shown the arrow. P wave is just coming out of the QRS complex. It's also called as pseudo R dash. Pseudo R dash is seen here. It is classical of AV and RT, the commonest SVT. And if it is a short RP interval, but it is slightly longer, more than 90 milliseconds, this is the case of AVRT. AVRT means those tachycardia presenting to us with an accessory pathway, or the all of us which you have heard the term WPW syndrome. These are the patients who have RP interval is shorter than PR, but the RP duration is more than 90 milliseconds. This is a AVRT, and sometimes the P wave is not seen. So it is again AV and RT. So our patient who presented to us in our emergency was regular narrow complex, and P wave is not seen at all. Even there is no convincing pseudo R dash or P wave peeping out of QRS complex. So our diagnosis, the last step of our algorithm was AV and RT. I hope this is not the situation. We'll try to go again with some basic facts of PSVT. As we all know, the incidence of SVT is somewhere in the range of 1 to 3 per 1,000 population. And it usually is not life-threatening, but it is a cause of frequent emergency visits. I have done electrophysiological studies for patients who come to me with a bunch of files, 8 to 10 emergency admissions, 2 days stay in ICU, 2 days in the wards. So basically it is a reason of frequent hospital admissions. So as I have told you, 50 to 60% commonest SVT is AV nodal reentry tachycardia, followed by the WPW syndrome, that is 30-40%, and rare is atrial tachycardia, less than 10%. So many times I get a call from ICUs that there is a patient of SVT, please come and see. But if we go according to our steps in the algorithm, you can see this is a narrow QRS complex, looks fairly regular. Is P wave seen? Yes, P wave is seen. Look at the long lead 2. P wave is clearly seen just before QRS complex, and RP interval is longer. PR interval is very short, RP interval is longer. So 2 common diagnoses which present with this is either atrial tachycardia, and not to forget our common friend is sinus tachycardia. So this was a case of sinus tachycardia. This was a lady admitted in sepsis in ICU. So commonest tachycardia in young patients with sepsis or systemic diseases is sinus tachycardia. Sometimes the rate is so fast that we may not see a P wave clearly. Just we have to search for it or do a slight vagal maneuver and P wave will come out. So in cases of sinus tachycardia, we do not treat the tachycardia. So we treat the underlying cause. This is the long list of causes which we need to look for and treat according to the cause. So some patients, when we have ruled out this long list of thyrotoxicosis, anemia, and so on and so forth, we haven't found a diagnosis. Such patients are labeled as inappropriate sinus tachycardia, commonly seen in young females. They have tachycardia, but there is no underlying cause. These are cases which need to be either treated with the ivabradine, the newer drug, which selectively inhibits the sinus node, does not cause systemic side effects like beta blockers. And the second line is beta blockers. Earlier, they were treated with beta blocker. Now we prefer to give them ivabradine. So basically, PSVT patients will present to us. Apart from palpitations, they may have shortness of breath due to recurrent episodes. Sometimes they may have decrease in ejection fraction, which we called as tachycardiomyopathy. They may present to us with syncope, loss of asthenia, that is fatigue, headache. So many elderly patients, sometimes they will never complain of palpitation. They'll just complain of weakness. This is commonly seen with atrial fibrillation and with underlying thyrotoxicosis. They may not complain of palpitation. So how do we acutely manage a patient of, now that our patient has presented to us in emergency, how do we manage? So we have seen her BP is okay. So she does not need emergency cardioversion. Like suppose a case of VT has come to us and patient is hemodynamically unstable, we'll directly go for a DC cardioversion. But here we should first try, first line treatment is a vagal maneuver. If vagal maneuvers do not terminate the tachycardia, the second drug of choice, or the first drug of choice, I should say, is adenosine. Adenosine usually does not cause hypotension. The other in line are beta blockers and calcium channel blockers. Both the drugs can cause hypotension, and sometimes these patients have borderline BP. So I would always recommend try adenosine first and then only go for other line. And rarely, sometimes these patients may be unstable. That time they will require synchronized DC cardioversion. Don't forget to switch on the sync button on your defibrillator, because you may convert the SVT into VT or VF. So always, whenever we are terminating a SVT or atrial fibrillation, the sync button has to be switched on. These are the various vagal maneuvers which we should try before going on for drugs. The commonest is carotid sinus massage done at the angle of mandible, firm pressure for at least 20 to 30 seconds. Elderlies try to skip this because sometimes we may dislodge a carotid atherosclerotic plaque and cause a small stroke. So preferably avoid that in elderlies. Just splashing of ice cold water on face is enough. Or Valsalva maneuver. Valsalva maneuver, sometimes the patients are not able to do. Illiterate patients, just press their abdomen firmly and tell them to push it out. Even that can terminate an episode of SVT. Adenosine is a very short acting drug. While giving adenosine, be very careful. Try to get an IV access as near to the heart as possible. So preferably what we do is take an IV access in the cubital fossa, load your adenosine, and at the same time take a 20 cc saline flush. Immediately after giving adenosine, flush it with 20 cc saline and elevate the hand. Because the half-life of adenosine is in hardly few seconds, 6 to 9 seconds is the half-life of adenosine. So it has to reach the heart and terminate the tachycardia within that half-life. It can sometimes cause flushing. Try to avoid in severe asthmatics. Mild COPD patients do tolerate it, but severe asthmatics, try to avoid it because it can precipitate bronchospasm. And very rarely it can cause prolonged asystole. Don't panic. Usually I must have used it at least 100 to 100 times. It has rarely caused any prolonged asystole. Sometimes it does help in differentiating types of SVT, as I have just told. If you give adenosine, sometimes which the tachycardia which was looking like a AVNRT, there was no P waves in, just give adenosine and flutter waves come out, and we diagnose it as atrial flutter. Later on you do a echo and find a rheumatic heart. So adenosine not just therapeutic, sometimes also helps in the diagnosis. This is just what I have told. It helps in termination, also helps in diagnosis. Further management, now that we have converted, you have given adenosine, you have terminated the tachycardia, what next? So if a patient who has come to us recurrent episodes of symptomatic SVT, the first line therapy nowadays is a diagnostic EP study followed by a radiofrequency ablation. This therapeutic modality is like a cure. It is like a boon for these patients because later on they do not have to attend the emergencies again and again with the symptoms, do not have to take any medical management like after an angioplasty patient have to take lifelong antiplatelets. But once you ablate a patient of SVT, it does not need to be on any drugs, maybe after 4 to 6 weeks of aspirin or a novel oral anticoagulant. So first line therapy is EP study and radiofrequency ablation. If patient is unwilling or due to some reason does not want, then the drugs which we give for prophylaxis are either beta blockers, calcium channel blockers, and if a patient has pre-excitation, the delta wave is present on ECG, in that case, we should add some drugs which inhibit the pathway, not just AV nodal blocking drug, beta blocker, calcium channel blocker, and adenosine. All these drugs are AV node blockers. So drugs which can block the pathway, accessory pathway, are like flecainide, propafenone, and amiodarone. Nowadays, flecainide and propafenone is also available, but not so easily widely available. Amiodarone is the drug which is widely available. So in that case, we should use this. We have already discussed acute therapy. Beta blockers and calcium channel blockers can be used for both acute therapy as well as chronic therapy. Patients who are presented with, rarely they may present with heart failure. Someone with a low ejection fraction, if he develops SVT, he may land up in failure. In that case, try to avoid drugs like beta blockers and calcium channel blockers. Same with the calcium channel blockers. Amiodarone, as I have said, it should not be used for SVTs as a rule. Only if you are dealing with atrial flutters, fibrillation, this is the drug which we should use. Otherwise, try to use adenosine. If not available or doesn't terminate, use beta blockers and calcium channel blockers. Flecainide and propafenone are class 1C antiarrhythmics, nowadays available with us. These drugs are very good for prophylaxis of WPW syndrome and also for patients of paroxysmal AF and flutter. If they on and structurally normal heart, these should not be used in patients with valvular heart diseases, should not be used in patients with low ejection fraction. They can precipitate or worsen the heart failure. So this should not be used in those, but patients with structurally normal heart, these are the drugs which you should use, because long-term adverse effects like amiodarone can cause liver dysfunction, can cause lung fibrosis, can cause corneal opacity, thyroid problems. So these drugs do not have such long-term accumulation and side effects. So these are safer, relatively safer drugs. Only thing is you have to occasionally monitor the QT interval, because they have tendency to prolong the QT interval and sometimes called torsade de pointes or polymorphic VT. AVNRT, as I've seen, told commonest tachyc SVT, more common in women. Usually the onset and termination is very abrupt. Basically, in this tachycardia, the pathway is near the AV node, AV nodal re-entry. There is something called as fast pathway. This is the AV node, this is bundle of His, and this is the slow AV nodal pathway. So basically here, there is a re-entry circuit, because of which there is a formation of an abnormal re-entry circuit, which leads to clinical manifest tachycardia. This is the re-entry circuit. So basically what we do during EP studies, find out the slow pathway and give radio frequency burns. In short, we just burn the abnormal wires and keep the normal ones going. So the radio frequency ablation, we burn that circuit. This is EP lab. This is how we work. Basically, there are on ECG, we take the currents from the surface. During EP study, what we do is, these are multiple catheters which we insert via the femoral vein into the heart, and we take the intracardiac electrograms. This is ECG directly from your heart. So it shows various types of signal. These are various catheters which I have the patient which we saw the ECG. This is the same patient. We did her EP study. So we have placed catheters in various locations of the heart. One is bundle of His. Second is one in the coronary sinus, which goes from right side of the heart to the left, and one is in the right ventricle. We use various pacing protocols or give some isoprenaline injections to clinically manifest the tachycardia again, which the patient had. Now, after patient develops the tachycardia, on the left side, we see the tachycardia. After various pacing protocols, the clinical tachycardia was reproduced in the EP lab. We do some diagnostic manuals and try to diagnose whether it is AVNRT, whether this is WPW syndrome, try to locate the pathway. Now this on the right side is the junctional rhythm. We have come to a diagnosis of AV nodal re-entry tachycardia. The circuit is near the AV node, the slow pathway we have localized, and now we have given the radio frequency burn. Once we give the correct burn, we see the junctional rhythm. So this is the junctional rhythm seen on the monitor. So SVT ablation, I have already told you, this is a very safe procedure. It is a curative treatment modality, has very low risk of complications and very low risk of recurrence, especially in AVNRT and WPW syndromes. So it should be offered as first line of therapy in such patients. AVRT, this is basically accessory pathway connecting the atria to ventricle. Normally there is only the AV node and bundle of his which connects atrium to ventricle. But in these patients, there is one more accessory pathway. So basically there is a this is an ECG of a WPW syndrome patient. We can see the delta wave. After P wave, there is a slurring of the upstroke of the QRS complex. That is called a delta wave, or we call it as pre-excitation. So this patient presented with this clinical tachycardia. She had the AVRT, atrioventricular reciprocating tachycardia. The circuit is something like that. From the AV node to the ventricle, from the ventricle to the accessory pathway, back into the atrium. So this is how the circuit is completed, and such patients present with the tachycardia. Rarely, sometimes these patients, they may have very fast atrial fibrillation. Instead of going through the AV node, the AF may conduct through the pathway, and they can have such kind of presentation. Very fast rates, because our AV node has some property of causing delay. We call it as AV nodal delay, but the accessory pathway doesn't have any such property. So patients can have very fast rates, and rarely this can be life-threatening. So this is called AF with pre-excitation, which will be irregular with delta wave is seen in some of the complexes. Sometimes it may not be seen because some waves go through the AV node, some go through the pathway. These patients will require, if unstable, early cardioversion, DC cardioversion. So chronic therapy, basically, again, this patient should be offered EP study and ablation, especially those who have delta wave on ECG. They should undergo EP study and ablation at the earliest. This was one lady who presented with that AVRT. She had a posterior septal pathway. This was her EP. During her EP study, she developed the tachycardia. So we localized the accessory pathway in the posterior part of the septum. These are the various catheters. This catheter is in the posterior part of the septum. This is bundle of his. This is bundle of his is anterior. So this was the tachycardia. It was posterior part of the heart, and this is her ECG after the ablation. Can you appreciate the delta wave? This is before the EP study, and this is after the ablation. There is no delta wave seen on the ECG. So few take-home messages at the end of my talk. Careful analysis of a 12-lead ECG is key to the differential diagnosis of various tachycardias. Try not to get scared of the ECGs, as I used to do. If hemodynamically unstable, in all cases, be it VT and rarely in SVT, do a synchronized cardioversion. Only for VF and polymorphic VT, you need an asynchronous cardioversion. If hemodynamically stable patient of SVT, try to use a AV nodal agent. In that order, first adenosine, and if not available, then go for a beta blocker or a calcium channel blocker. And long-term therapy depends on the mechanism, what kind of tachycardia it is, either pharmacological therapy or invasive therapy. And EP study is often needed for definitive diagnosis and as a curative therapeutic modality for such patients with a very high success rate and low risk of complications. Thank you. If there are any questions, I would be happy to answer.
Very nice presentation, Dr. Ghumre.
Thank you.
Yeah, it's a very complicated topic. Still, whenever a patient of arrhythmia comes to our clinic, it makes us panicky, and we are uncertain whether that the arrhythmia will be terminated or not. Or a question comes, which drug we should use properly. Initially, there were no EP study and ablation in our area. I think it's a good thing that Dr. Ghumre has came to our area. I still remember your lecture long ago you had taken, still remember. It was also nice. So it's a good thing that our patients have got facility of this EP study and ablation in our area. Otherwise, our patient has to go to Mumbai or Pune initially.
Yes.
Just one simple question. As a physician, we have got a very wide experience of using verapamil. Means nowadays that drug we are not getting very easily.
It's not easily available.
Yeah,
now.
but many of physicians have used it so widely.
Yes, sir.
So you told that, I don't know, sin is the first preference. So can still verapamil be used as a first? What is the?
Sir,
I think whenever blood pressure is low, that time
That time we should
definitely
avoid.
verapamil we have to avoid. So what do you say?
Sir.
Adenosine we have used on few occasions, but that asystole makes sometimes us panicky that
We skip a bit for few seconds when we
Yeah.
see that slightly prolonged asystole, but usually it doesn't last for more than 1 or 2 seconds.
Okay.
And verapamil, I think nowadays there is slight problem with the availability, but young patient presenting with SVT, if adenosine is not available, second thing is sometimes even the affordability. Adenosine, the cost is significantly higher as compared to verapamil. So you can use verapamil. This is the order suggested because it does not cause any hypotension. So very rarely, even with small doses of verapamil, it won't cause hypotension in patients who have structurally normal heart. But sometimes we may not be aware of the structural disease.
Yes.
In those patients, they can have some problem with hypotension.
safety wise adenosine.
Safety
will be
wise,
better.
adenosine is very safe.
Okay.
Some patient of pre-excitation, they come to OPD. They never had palpitation in the past, but their ECG shows pre-excitation. What you will advise for those patients? They should go for ablation or they can be managed medically?
What we should first thing what we should try at easily available tests which we should do in such patients, I would suggest is do a stress test. If at faster heart rates, if the pathway stops conducting, then we are relatively safe in advising such patients not to go for EP study, because at the faster rates the pathway is not able to conduct. The risk with such patients is if they develop an AF like the ECG which I showed, they may conduct 1:1 with a very fast rate to the ventricles and they can have hemodynamic instability. I have treated such 2 patients. One was a staff nurse, male staff nurse. He directly presented with AF with pre-excitation, very fast rate and hemodynamic instability, cardioverted outside and then sent to me. So what I would suggest is do a stress test. If at faster heart rates also, if the pathway is conducting, then it is safer to advise them ablation, because now the procedure itself is very safe. So, and in Indian patients, what we see is denial of symptoms is very common, because there are some patients which I have done EP study and ablation. Initially, they denied symptoms, but when during EP study, when we reproduce the tachycardia, they, "Ha sahib, असं होत होतं मला कधी कधी, पण मी दुर्लक्ष करायचो."
Regarding this WPW, I remember still there is a written in Harrison that use of this lanoxin or digoxin has gone down, I think.
Yes.
Initially that we have used many times. So in antiarrhythmic, many times digoxin was the drug of choice. So it was written that whenever WPW patient comes, suppose by mistake you give digoxin, patient may get ventricular fibrillation.
Yes,
that was one caution note. But anyway, use of digoxin has gone down. In atrial fibrillation also, in mitral valve disease, we used to give a lot of digoxin IV, but now as amiodarone has become available, its use has gone down.
In that second subset, I still use digoxin because sometimes these patients present to us with systolic BP of 80. So the only drug which we can use safely in such patients is digoxin. So it is drug which should be used selectively in some patients, especially AF with LV dysfunction, lower BPs. I think it is a very good for controlling the rate.
Good hint, people are forgetting lanoxin, digoxin.
There was a word on my, there was one box in my slides where it said that in patients with pre-excitation, do not use digoxin.
Yes.
But nowadays, in any ways,
But that is a good hint. Whenever patient has got hypotension, amiodarone again will cause hypotension.
Yes.
I think we can use digoxin.
One more drug which has come, I think it's not again very widely available in India, is ibutilide. It comes as with the brand name of Fibricor. This is also a good drug for patients who present with AF with pre-excitation. Suppose that patient is hemodynamically stable, then we can either use amiodarone with a beta blocker, or we can use this ibutilide. It selectively acts on the pathway. It does not act on the AV node. Amiodarone acts on sinus node, AV node, as well as the pathway.
I had one patient. She had a post-cesarean section, SVT. At that time, we could manage with azoxystrobin or something like that. But next time, I was worried. For same patient had come cesarean section again. But that time she had done ablation therapy. And so I was very much relaxed and patient was quite comfortable and no problem I had. So I'm very thank you for this ablation therapy. Thank you.
It's like a boon, sir. Right?
Yeah.
Patient gets cured. There are very few modalities with us which we cure the patient, like a device closure for ASD. That patient is practically cured for life. This is one more such modality.
Few words for Rajkumar Ghungre and few expectations from Dr. Rajkumar Ghungre, Dr. Vadgaonkar and Dr. Vattamar. With my personal experience of my family, Rajkumar Ghungre is a very cool, competent and brilliant interventional cardiologist. In a very, very crisis time, when my father-in-law, MLA Devsarkar, my wife's father, was admitted there, very, very skillfully he handled the pacemaker insertion when he was shifted from Pusat. And in all our ups and downs, his skill, his expertise, his coolness as a cardiologist, which are all behavioral human being things which are required to be an interventional cardiologist, are all incorporated well as a good human being in Rajkumar Ghungre. But I expect all his services in Parbhani at least once in a month. And in gossiping in the chair, he promised me. Now I have declared it, so he and his team has no choice, only has to discuss the days and all. So thank you, Dr. Rajkumar Ghungre, Vadgaonkar and Vattamar for monthly visit to multispecialty. I am expecting this after giving a world-class infrastructure. I don't know whether you have seen it inside or not. If you have not seen it, the team will take you to see the infrastructure. It is uncompromised with the Indian standard and American standards of Hospital Bureau. All standards are there. Once you see it, seeing is believing. You will attempt to visit every month. And our Parbhanikar will get a chance to serve. And all the chairpersons will be happy that we have cashed the person to Parbhani. Thank you.
Yes,
Thank you, sir, for the generous
what
words.
you rightly said, I think it's arrhythmia specialist. It's a quality for arrhythmia specialist.
I'll try to stand up to those generous words. Thank you, sir.
I would like to request all the chairpersons to felicitate Dr. Rajkumar Ghungre, sir. Thank you, sir, for the wonderful session. And I would like to invite on dais Dr. Ritesh Agrawal, sir, for honoring and felicitating our senior most chairpersons.
आता येतोय? able to hear you? Okay, okay. Hello?
For our next session, Dr. Pandurang Vattamwar sir is joining online to us on Zoom. He is practicing since last 15 years in Aurangabad as a neurophysician. He's the director of...
Am I audible now?
Yes, sir. Yes,
Hello.
sir. You're audible, sir. Hello.
Hello. Hello. Yeah. Hello, everyone. There is some technical issue. My either voice is not audible or some disconnection is there in the internet. I'm sorry for that. We'll go for next slide. As we know that intervention in neurology, the concept basically started in 1980s. But because of rapid advances in neuroimaging, like advent of DSA, roadmap, 3D rotational angiogram, and development of revolutionary medical devices, now the intervention has become the treatment of choice for most of these neurological disorders. And what are these neurological disorders where intervention is useful? One is ischemic neurovascular disorders, and another is hemorrhagic neurovascular disorders. Now I will go through the series of cases through which you can understand up to what extent that intervention is useful in all these neurovascular diseases. First, going through the ischemic neurovascular diseases, as you know, the acute ischemic stroke is one of the most common neurovascular disease which we see in our routine practice. This is the first case, 67-year-old male presented with acute onset of weakness in left upper limb and lower limb since last 6 hours. So he had weakness 6 hours prior to he presented to in our he got admitted in our hospital. He had severe dysarthria. Left upper limb and lower limb was grade 0. So this patient had acute infarct in thalamus as well as the internal capsule involving the internal capsule. MR angio was normal. This patient came in out of window period, that is beyond 4.5 hours. This patient was not eligible for thrombolysis, and patient had weakness and severe neurological deficits. Although the angio was normal, we decided to go for intra-arterial thrombolysis. So patient was taken to the cath lab, and immediately intra-arterial thrombolysis was given. Immediately on cath lab table, he started imbuing, and this was a video second day morning. There was no neurological deficits. In fact, he was shifted out of the ICU in a private room, and he was absolutely all right. So this is the advantage of intra-arterial thrombolysis. If the patient was out of window period, where we cannot give IV thrombolysis because patient came beyond 4.5 hours and the vessels were normal. In such situation, we go for intra-arterial thrombolysis. This is the second case, 58-year-old male. He had history of myocardial infarct, and for which he was thrombolized outside. He was admitted outside for around 4 to 5 days. Second day after discharge, that is 1 week after the MI, he had acute onset weakness in right upper limb and lower limb. And this time, this patient, presented within 3 hours to our hospital. He had a global aphasia. He was drowsy, and his MRI was showing right MCA evolving infarct, and right MCA was totally occluded. Now, in this case, although the patient came within 3 hours, there was a large vessel occlusion. In view of large vessel occlusion, IV thrombolysis can be given for such patient, but the mechanical thrombectomy is more ideal in such cases. So immediately after discussion with the relatives, intravenous thrombolysis, another issue in this case was he was thrombolized few days back at private hospital. So IV thrombolysis was also out of question in this patient. So immediately after discussion with the relatives, patient was taken to the cath lab. Here you can see there is complete occlusion of left MCA. This is internal carotid artery bifurcating into the ACA and MCA, and there is a cutoff, and there was complete occlusion. We decided to go for mechanical thrombectomy. This is a microcatheter and wire which was crossed beyond beyond the occluded segment. And now this is the thrombectomy device, which was also placed beyond the occluded segment. A check run was taken to check whether we are beyond that segment or not. And after thrombectomy, there was complete recanalization. And this recanalization was within 20 to 30 minutes, and patient started improving on table. And over a period of next 3 to 4 days, he improved completely, except for mild word for finding difficulty. There was no focal deficits. He underwent coronary angiography and coronary angioplasty 2 weeks after that, after this stroke event. So in acute ischemic stroke, based on these two cases, what are the pulse? The first 4.5 hours, intravenous thrombolysis is the ideal treatment. Alteplase or tenecteplase can be given. Tenecteplase has been approved in India by DCGI for initial 3 hours. And after 3 hours, up to 4.5 hours, alteplase is FDA approved. So tenecteplase is also safe. It can be given easily. It is given as a bolus. It is cheaper, and many places like at Parbhani, at remote areas where alteplase is easily available, but tenecteplase is not available. Tenecteplase is easily available, but alteplase is not available. In such situation, tenecteplase can be given. After 4.5 to 8 hours, or depending upon the vessels which are involved, whether it's anterior circulation or whether it's a posterior circulation or presence of penumbra, the patient can be taken for either intra-arterial thrombolysis if the arteries are open beyond 4.5 hours of window period, up to 6 to 8 hours. And mechanical thrombectomy is offered for patients where there is major vessel occlusion, like MCA occlusion, ICA occlusion, or AC occlusion. In such situation, mechanical thrombectomy can be offered. And because of these intravenous thrombolysis, intra-arterial thrombolysis, mechanical thrombectomy, the mortality, not only mortality, but also morbidity has decreased in various studies. This is third case. 78-year-old male presented with recurrent episodes of left-sided weakness. He had already 2 to 3 episodes since last 1 month, followed by recovery. And he was chronic smoker and hypertensive on medications. So his MRI was done initially, but the MRI brain was done. Angio was not done. We did an MRI brain with angio, which showed a carotid stenosis. This was the MRI. Here you can see the watershed infarcts in AC and MCA territory. And MRI angio was showing near complete occlusion of the right internal carotid artery. However, we went for DSA, but DSA showed it was not a total occlusion, but it was a severe stenosis limiting the flow, which could not be detected on MRI. So we decided to go for carotid angioplasty after discussion with the relatives. And this is the images after carotid angioplasty. Here you can see there is almost complete normalization of the carotid artery after carotid angioplasty. So whenever we see watershed infarcts, MCA, ACA watershed infarcts, or MCA, PCA watershed infarcts, we should suspect carotid disease. And most common site of carotid disease is at carotid bifurcation, where the carotid disease stenosis, extracranial stenosis is common. Another common site is intracranial portion of the carotid disease, carotid artery, especially the cavernous segment, where the carotid stenosis is common. MR angio is good for the initial diagnosis. If MR angiogram is totally normal, then there is no need for further investigations or further DSA as such. But if MRI is showing some disease, such patients need to undergo DSA, because MR angio can overestimate or underestimate. The case which I showed just now, the MRI was showing total occlusion of right ICA, but DSA showed that there was a flow, and that flow was sufficient even enough to go for intervention and carotid angioplasty. So DSA is required even if the MRI is showing total occlusion, to see whether any flow is there. So carotid angioplasty is indicated if the patient has symptomatic stenosis more than 50%, asymptomatic stenosis more than 70%, and it is safe even in elderly, even beyond 80 years of age also. So these are the usual guidelines for carotid stenosis, but usually we go for symptomatic stenosis, we go for carotid angioplasty and stenting for patients who have stenosis which is causing symptoms, and stenosis is more than 60 to 70%. Coming to vertebral artery angioplasty through radial route. This was the first case we did at Orion City Care Super Specialty Hospital in this region in Marathwada. Patient was a 58-year-old female and had recurrent posterior circulation strokes. She underwent DSA, and right vertebral artery showed a severe 98% osteostenosis. In this case, we went through radial route. The reason behind was that patient had significant ulcerations and fungal infection in the groin, bilateral groin, and we could not take the femoral puncture. So we thought we should go via radial route. Here you can see the vertebral artery, very severe stenosis at the ostium. This is the subclavian artery, and the catheter, this is the diagnostic catheter, went through the subclavian artery. And this is the guiding, and this is the after vertebral angioplasty and stenting. So vertebral and basilar, vertebro-basilar territory also, if the disease is severe, symptomatic, and recurrent strokes are occurring, for such patients can also be treated with carotid vertebral angioplasty and stenting. This is the fifth case, 43-year-old male, known case of diabetes, hypertension, recurrent right hemiparesis, even on dual antiplatelet. And on examination, there was mild drift in right upper limb. There were no deficits. MRI showed left MCA severe stenosis. Here you can see this is the left ICA, and there was a severe stenosis of left MCA. We decided to go for MC angioplasty and stenting. This is the balloon mounted stent, which was deployed in stenotic segment. And this is the post angioplasty. Here you can see there is complete, the patient is cured of the MC stenosis. So intracranial atherosclerotic disease. Intracranial means ICA, intracranial portion of the ICA and its branches. Intracranial portion of vertebral artery and basilar artery. So this is called as ICAD. So this is one of the leading cause of recurrent strokes, and quite common in Asian population. And intervention is indicated only if the stenosis is symptomatic, on best medical treatment. In spite of dual antiplatelet, the patient is having recurrent stroke, then only the intervention is indicated. So now dedicated intracranial stents and balloons are also available, Credo and Neurosped, with excellent results as compared to the other stents. Coming to the hemorrhagic neurovascular disorders, directly coming to the first case, 30-year-old male presented with acute severe headache and vomiting. BP was normal, there was neck stiffness. So clinical profile itself suggests that patient had subarachnoid hemorrhage. Here you can see there is a severe subarachnoid hemorrhage, extensive in the subarachnoid space. Patient underwent DSA. DSA is the gold standard for the diagnosis of DSA. Here you can see this is the 3D rotational angio, where you can see an aneurysm in anterior communicating artery. So anterior communicating artery aneurysm, we decided to go for coiling. As the aneurysm was narrow-necked, the neck was relatively narrow, we decided to go for single microcatheter coiling, and the procedure went very well. This is post-coiling. Aneurysm is completely embolized, and this patient recovered completely without any deficits and was discharged on 4th day, as patient did not had any major neurological problem after that. This is a second case, 56-year-old female presented with acute onset severe headache and vomiting. had one episode of seizure. Examination showed neck stiffness. There was no other deficits. Again, here you can see there was significant subarachnoid hemorrhage, especially on the right side. So the aneurysm is suspected in such patient. DSA was done at another hospital, and that was reported as normal. But we did 3D rotational angio. This is 3D rotational angio. Here you can see there is a blister and a small blister aneurysm, which can be picked up in many cases with 3D rotational angio only. And so in such patients, this 3D rotational angio is very, very important. And routine DSA, these blisters can be missed easily. And this was a blister aneurysm. And we decided to go for flow diverter stenting. Here, if you see the size of the aneurysm is so small, you cannot clip it, and neither you can coil it. So the only option remains is flow diverter stenting. So this is the procedure. Here, flow diverter was deployed across the aneurysm, and here you can see this is the follow-up, 3 months follow-up of this same patient. There was complete obliteration of the aneurysm, no recurrence. The patient is doing well. There are no neurological deficits, nothing. So blister aneurysm, the treatment of choice is flow diverter stenting. 67-year-old male presented with acute severe headache and vomiting. BP was quite high, 200 by 120. There was right third cranial nerve palsy with mild hemiparesis. Here you can see there is intraparenchymal bleed in the crux of the midbrain on the right side. And that is the reason patient had right third nerve cranial palsy and left hemiparesis. Although patient was hypertensive, the patient had a very high BP, it could be a hypertensive bleed, but the location of hypertensive bleed is not usual in this patient. So we decided to go for DSA, and DSA showed a small aneurysm, which was not a blister, but larger than blister. So this aneurysm in ICA was narrow, it was shallow and relatively wide neck. So it is not easy to put a coils in such a small aneurysm because with a wide neck, and it is not a blister aneurysm. It is a quite large aneurysm. The aneurysm is in a BCOM, and that is the reason patient had third nerve cranial palsy, and the location of bleed was near the third nerve. And in such cases, the treatment of choice is stent assisted coiling. Here you can see this is the stent, and this is the microcatheter through which the coils are being placed. Here you can see the coils are being placed. Yeah. You can see here the coils are being deployed inside the aneurysm. The aneurysm was larger than the blister, but not so large to coil. Simple coiling was not possible. So we decided to put a stent and coil. This is the stent assisted coiling, and this is the stent and coil. There is complete obliteration of the aneurysm. Patient improved completely and was discharged. This is the fourth case. 65-year-old female presented with acute onset headache and vomiting, and CT scan showed subarachnoid hemorrhage. Here you can see this is the basilar artery. These are PCA, and these are anterior inferior cerebellar arteries and PCA. This is giant aneurysm at the basilar top, and the PCA as well as anterior inferior cerebellar artery (ICA), both were arising from the aneurysm. Here you can see this is the giant aneurysm, and from the dome of the aneurysm, this PCA, bilateral PCA and ICA were arising. Here the treatment options are quite limited. Surgery is not possible because of posterior fossa. Clipping this area is not easy because there is likely that the PCA or ICA will get compromised and patient will land up in trouble. The only options which are available is contour device in such patients. So these are the complex aneurysm. In such complex aneurysm, we use either flow diverted with coils, contour device, or with or without coils, or derivo device, which is another form of flow diverter itself. And this patient, we decided to go for contour device. And here you can see there is a microcatheter which was placed inside the aneurysm sac. And this is the contour device which has been placed. It's an inverted umbrella type. You can see the device inside the aneurysm itself. Here, this is the aneurysm which has. These devices are specially structured in such a way that the flow within the aneurysm decreases significantly. The clots occurs within the aneurysm sac, and the aneurysm collapses over a period of 3 to 6 months. This procedure I did in Jan, second week of Jan. We are planning for follow-up images. We did a CT scan in between, CT angio, which showed partial collapse of the aneurysm, but we have not done a follow-up DSA at present. We will be planning at the end of 3 months or 6 months. So patient is doing fine. There are no infarcts. Bilateral PCA, posterior cerebral arteries, bilateral anterior inferior cerebral arteries are feeling very well, and there was no problem at all, and no issues. So this was the first case of contour device placement in Orion City Care Super Specialty Hospital at Aurangabad, and in this our region of Marathwada. Nearly about 100 plus cases has been done all over India, and out of these 100 cases, one of the case has been done in our Marathwada region at City Care Hospital. So this is the next case, 63-year-old female, acute onset headache and vomiting, one episode of seizure, BP was relatively high, but patient was conscious and oriented. We did a DSA. This is the rotational angio. Here you can see there is a giant aneurysm, giant paraphthalmic aneurysm, and we did flow diverter assisted coiling. Here you can see the very giant aneurysm, and these are the guiding catheters. This is the long sheath, guiding catheters, wire, and with the help of wire and long sheath, we went ahead. After this, these are the various views. Microcatheter was taken, which was placed into the MCA, which was used for deployment of flow diverter. And this another microcatheter was placed inside the sac of the aneurysm, and flow diverter was deployed across the neck of the aneurysm. Here you can see this flow diverter, faint stent-like structure. Once the flow diverter was deployed, the flow within the aneurysm decreased significantly. Here you can see there is a stagnation of flow within the aneurysm. And now we started deploying the coils. Because of the flow diverters, coil will not come inside the internal carotid artery. And the packing was done. Loop packing is sufficient enough in flow diverter cases, because flow diverter itself divert the blood flow away from the aneurysm. Here you can see the stagnation of the blood within the aneurysm sac. Here, this is the flow diverter, and these are the coil mass. So this procedure went uneventful. There are no procedure-related complications. So this is the complex aneurysm, giant aneurysm, treated with flow diverter and coils. So for subarachnoid hemorrhage, DSA is the gold standard. Aneurysm coiling option depends upon the size of the aneurysm, location of the aneurysm, and the neck of the aneurysm. And these are the single microcatheter coiling, balloon assisted coiling, stent assisted coiling, flow diverter stenting or flow diverter assisted coiling, and newer devices like contour devices or derivo devices, depending upon the aneurysm type. In some cases, wherever possible, we can sacrifice the artery where the aneurysm is arising. we try to if the patient is not affording, if even if we sacrifice the parent artery, the likelihood of complications are very less. Then in such cases, the parent artery sacrifices is also being done at few centers. So this is the next case, 19-year-old female, acute onset headache, vomiting, one episode of seizure followed by loss of consciousness. Patient had right hemiplegia with global aphasia and patient was drowsy. Here you can see a large bleed in left frontal region. And within this bleed, here you can see there is a bleeder within the mass of the bleed. So that is a clue that patient might be probably having AVM. So patient underwent DSA. The DSA showed a clear-cut AVM, and we decided to go for embolization. In such AVM, we embolize with onyx or squid. These are the glue-like structure material which we go through microcatheters up to the AVM and inject onyx or squid, and there is a complete obliteration of the AVM in this case, you can see, and this is the cast of onyx. This is 1 month follow-up. Completely recover, no neurological deficit. She is able to speak. She is able to, mild weakness is there. Other than that, there was no significant, that weakness has also improved. And this case I had done around 5 years back. Now this girl got married. She had a child also 1 year back. This is 7th case, 80-year-old male, presented with headache, word finding difficulties and confusion. MRI was done outside, which showed venous sinus thrombosis. Patient was admitted at Jalna and he was started on low molecular weight heparin. But in spite of best medical treatment, patient was not improving. In fact, he was deteriorating, and he was referred for further treatment. After admission, he underwent decompressive craniotomy because of significant mass effect and midline shift. Even after decompression, patient was deteriorating. Then we planned for DSA to rule out dural AV fistula. This is the MRI. Here, this is the GRE images. Here you can see a large blood clot in the left temporoparietal region. And venogram was suggestive of venous sinus thrombosis. The left transverse sinus, jugular sinus was not seen at all. But in spite of that, patient was not improving. So we went for DSA, and DSA showed large dural AV fistula. Here you can see this is the external carotid, and this is occipital artery, occipital branch of the external carotid, and these are the middle meningeal. This is the middle meningeal artery, and through this occipital artery and this middle meningeal artery, this is the fistula which was filling, and this fistula. This is the fistula which was filling. So we decided to go for embolization with this is the wire with microcatheter entering inside the middle meningeal artery. This middle meningeal artery. Yeah. And here you can see the fistula now clearly. And this is the squid embolization. We have to do it gradually so that the squid will form a solid structure and proximally, and then it goes distally, and the regurgitation can be prevented. So here the fistula is filling gradually. Here you can see. So this is the embolization of the rest of the fistula, and this is the cast. This is the cast of microcatheter is being detached. This is the very critical step, and this is the squid cast. Here you can see there is no fistula now. There is complete obliteration or complete embolization of the dural fistula. The patient got stabilized, started improving gradually. Meanwhile, in view of prolonged ventilation, ventilatory support, he underwent tracheostomy. And after 29 days of hospitalization, he was discharged on tracheostomy tube. So in non-hypertensive hemorrhagic strokes, always suspect underlying vascular disease like aneurysm, AVM, or AV fistula. And diagnosis for this is not MRI, not CT angio. The gold standard is DSA. DSA, you can identify what the pathology is there. You can identify the structures. You can identify the circulation. You can study the cross flow also. So DSA is the gold standard in such situation. Now it is the last case, 60-year-old male presented with road traffic accident, had head injury. He sustained a nasal bone fracture, and with the routine treatment, non-surgical, he improved. 2 weeks later, he started having right eye swelling and diminution of vision in the right eye. So this is the picture. Here you can see there is a exophthalmos with edematous right eye. We went for DSA, and DSA showed a carotid cavernous fistula. This is carotid cavernous fistula. So the blood flow from the internal carotid is directly going into the cavernous sinus and retroorbital structures. So this is the carotid cavernous fistula. We decided to go for embolization. Multiple coils were placed within the this fistula's tract, and there was complete obliteration of the carotid cavernous fistula. And this was the before embolization picture. And 3 days after embolization, the edema and exophthalmos completely subsided. His vision improved partially, but it improved only partially. Thank you.
Can you hear us?
Yeah, I'm able to hear now.
Congratulations, Dr. Vattamar. I'm Dr. Chandak.
Sir. Hello, sir. How are you?
Nice presentation.
Thank you, sir. Thank you.
In this procedure, I think even at higher center, Pune, Mumbai, very few people are doing. It's, I think, a good thing that person from our area is doing such an excellent job. I want to know that suppose for thrombolysis there is a window period, okay? So
Yes, sir. Yes, sir.
For this intervention, is there any window period? Suppose we refer patient from this area.
Yes, sir. Yes, sir. For acute ischemic stroke, window period is there, sir. For example, for anterior circulation, the window period is there for 8 hours. Up to 8 hours, we can do thrombectomy. Up to 8 hours, we can go for intra-renal thrombolysis as well. In certain patients, this window period may go up to 12 hours or 24 hours also. Recently, one patient with MCA occlusion was thrombolized at Parbhani and then was referred to me. The patient's son was a doctor. He was doing an internship. And after coming to Parbhani, we went for thrombectomy as well because the artery was not open. And such situations are there. We can do that also. There is called as bridging therapy. So if the thrombectomy center is not nearby, so if the patient is not able to reach a center where thrombectomy can be done within 3 hours or 4 hours, you can give IV thrombolysis and shift the patient. So that is called as drip and shift. So we can start IV thrombolysis, shift the patient. By that time, the clot will get, if possible, if the artery gets opened, then there is no need of thrombectomy. If the artery is still occluded, then thrombectomy will definitely help.
Okay. Means,
yes,
I think if we do early, that neurological damage will be avoided.
Yes, sir. Yes, sir. The ideal is golden hour. First hour is the golden hour. Whether for thrombolysis or whether for thrombectomy. So if we are able to do all these things in golden hour, then the patient will improve completely.
Okay, okay. Chalo, thank
Yes,
you.
sir.
Next time,
Thank you, sir.
see you in person.
Yes, yes, sir. Sure, sir. I'm very sorry I could not come in person there. Uh, but luckily I'm able to present through Zoom meeting.
One more question, sir.
Sir.
Hello, sir. Sir, what
Hello.
we'll use for intra-arterial thrombolysis? Like it is same.
Intra-arterial no. Intra-arterial thrombolysis, if we use alteplase, the maximum dose is 10 milligram. And if we use tenectase, the maximum dose is 6 milligram.
6 milligram. Okay.
Yes, yes.
Thank you.
Thank you.
Thank you, sir. Thank you for a wonderful talk on this topic. Thank you so much.
Thank you. Thank you very much. Thank you.
You can stop the sharing.
I will leave the meeting now. Thank you very much.
Thank you so much, sir. Vatamvar, sir. Now I would like to invite our next speaker, Dr. Prafulla Jatale, sir. His topic is role of nuclear medicine in PET-CT in oncology. He has completed his DNB from Tata Memorial and currently working as a in-charge nuclear medicine and PET-CT in United Sigma Hospital since 2013. Welcome, sir. Over to you, sir. And sorry. Chairpersons for the session, Dr. Nihar Chandak, sir, and Dr. Bashir Khan, sir. It was a bomb, I think.
First of all, I would like to thanks Praful sir, Vidya ma'am, medical college team, IMA Parbhani to invite me for this topic on role of PET-CT and nuclear medicine in oncology. I am a nuclear medicine physician in United Sigma Hospital, Aurangabad. Nuclear medicine is a specialized branch in which we do physiological imaging. In radiology, we do anatomical imaging, but in nuclear medicine, what we do, we inject a particular medicine, target medicine to the organ. Like if we are doing kidney scan, that's a DTPA scan, we inject DTPA in which is tagged with radioactive material like 99M technetium, and we see the function of that organ. So this is basic about nuclear medicine. I will start with PET scan. PET is a positron emission tomography. It is a study of human physiology by electronic detection of short-lived positron emission radiopharmaceuticals. And PET is used to evaluate metabolic, biochemical, and functional activity at cellular level. Now, what we do for the PET scan, we inject a short-lived radioactive tracer, that is FDG, fluorodeoxyglucose, which is having half-life of 110 minutes. It is injected IV to the patient, and it is this tracer is chemically incorporated into a biological active molecule, and there is waiting period of around 45 minutes for the patient. Till that time, that tracer will go into the target organ, and we take the patient to the scan. For PET scan, we get fluorodeoxyglucose from Mumbai. There is a cyclotron. First cyclotron was in Bhabha Atomic Research Center. Now in India, around there are only 8 to 9 cyclotron. From that cyclotron, FDG is produced, and which comes daily to us in the morning at our center. So what we do, we inject FDG, fluorodeoxyglucose, to the patient. It will go into the cell, and normally what happens, that glucose will metabolize further, but in cancer cell or inflammatory cell or infective cell, that glucose will not process further, and it will trapped in that cell, and this will be imaged by F18 radioactive material. So these are various radioactive material, F18 like and C11 and 13. This will emit positron, and it will collide to our detector, and imaging will be done by our PET scan. So basically, PET scan is done in 80% of cases in oncology. It is also done in few cases of neurology and cardiology. After injection and after having waiting period of 45 minutes, this is the whole body PET scan. The normal, wherever there is normal glucose metabolism, like brain, then myocardial muscle, and the excretory system is renal. So kidneys and bladder will be visualized. Apart from all this organ, whatever is abnormal, that is abnormal malignant cell or inflammatory cells. So this is the case of lymphoma. After the injection, you can see that there are various supradiaphragmatic and infradiaphragmatic lymphadenopathy. And after the chemotherapy, this has gone completely. So I will basically tell about role of PET scan in oncology. Patient preparation is that patient should be adequately hydrated. There should be fasting of at least 6 hours, so that blood glucose should not be more, because what we are injecting to the patient is fluorodeoxyglucose. So if patient's blood glucose is more, the scan will be of poor quality. PET scan is done in case of staging, if for the response assessment after chemotherapy or radiotherapy. In restaging, that is after the treatment, if there is suspected recurrence. In follow-up of the patient. In radiotherapy planning also, a PET scan is done for contouring and planning of radiation field. If there is cancer of unknown primary, PET scan has very important role, and to identify the site from which biopsy can be taken for the tumor. So if the patient is having cancer, and if we do unnecessary test, various tests like CT scan, chest, abdomen, pelvis, but if we do single PET CT scan whole body, it is a one-stop shop. It will give all the answers of our questions in oncology. First, lymphoma. In lymphoma, PET scan is done for staging, restaging, post-therapy evaluation. It has highest sensitivity in detecting focal marrow involvement. Any other test will not show marrow involvement in lymphoma, but PET scan will very beautifully show the marrow involvement. Interim PET is done after 2 cycles to see whether how is the response of that chemotherapy. If suppose response is good, it will carry out with the same line of management. So here you can see extensive lymphomatous disease, supradiaphragmatic lymphadenopathy, all the cervical, abdominal, mediastinal lymph nodes are there in lymphomatous disease. And after the chemotherapy, all the disease has gone anatomically and metabolically. In bone and soft tissue tumor, PET scan is used for staging. You can also use in osteogenic sarcoma, rhabdomyosarcoma, for primary bone tumor and metastasis, and for demonstration of sarcomatous change in osteochondromas. In breast cancer, it has no role in initial detection of primary and axillary lymph node, but it provides accurate metastatic staging. So M has very high sensitivity and specificity. It provides accurate metabolic information in locally advanced breast cancer and inflammatory breast cancer. And it shows us about high outcome after neoadjuvant chemotherapy. In colorectal cancer, NCCN guidelines has recommended the use of PET-CT as a problem-solving tool in the initial staging, especially whenever the liver lesions are of indeterminate etiology. It has more sensitive and equally specific as CT for extrahepatic disease. And it also predicts early response to NACT radiotherapy with high accuracy. Here you can see that on the CT scan, we can miss the lesion, or lesion is absolutely not visualized, but we have doing PET scan, we can see the hotspot, so we cannot miss the lesion. So this was a 73-year-old female. After the surgery, she was having rising CA level. So if a patient has done CT scan, lesion was missed, but on PET scan, lesion was picked up and she was managed accordingly. Here also you can see that there is absolutely no lesion, but FDG is showing hotspot. So this is a liver mets. In gastrointestinal stromal tumor, also PET scan has very important role in staging, in evaluation of treatment like immaterial misylate. So you can see in the above images, there is disease in the stomach and the liver, and after the immaterial misylate, the disease has gone. So good response to treatment. In cervical cancer, PET scan has important role to detect nodal metastasis when CT scan is normal. Nodal staging is very important in cervical cancer, and PET scan has very high sensitivity for nodal detection. It is valuable in treatment planning with EBRT and brachytherapy. In brachytherapy, it improves the tumor coverage without increasing dose to surrounding critical structure. So PET scan is important for the radiotherapy planning, and it has around accuracy of 92%, sensitivity of 82%, and specificity of 97%. Ovarian cancer, it is useful in detection of recurrent ovarian cancer whenever the patient is having a rising CA 125 level and patient is having negative CT scan or MRI. And PET scan has very high sensitivity of around 94% and high specificity. So if there is uptake, it is highly recommended that it's disease involvement. Here you can see there is patient of CA ovary having rising CA 125 level. You can see that paraortic lymph nodes and pelvic lymphadenopathy can be seen on PET scan. It's also useful in differentiating stage 3C from stage 4 from other stage with higher sensitivity and specificity. In pancreatic cancer, it has highest role, have a role for triaging patient for curative versus palliative treatment, depending on absence or presence of metastatic disease in locally advanced disease. For pancreatic cancer, primary modalities MDCT or MRI with or without MRCP. In gastric cancer, FDG PET scan has very limited role because there is a physiological uptake in the stomach, so lesion can be missed. Also, if there is signet ring cell or mucinous adenocarcinoma, FDG scan has less specificity because there is less glucose metabolism in that cells. But if there is a case of CS stomach with peritoneal mets, PET scan will definitely help because CT scan can miss the peritoneal disease involvement. In anal cancer, as compared to the conventional imaging, It alters the disease in 20 to 25% of cases because of detection of distant mets. In cholangiocarcinoma, workup by CT and MRI with cholangiopancreatography is done, but PET scan has higher sensitivity for detection of intrahepatic cholangiocarcinoma, and it has very low sensitivity for extrahepatic cholangiocarcinoma. PET scan has very important role in head and neck cancer. It is role is in distant mets and second primary in locally advanced head and neck cancer. And it changes the prognosis and line of management in most of the cases. Accurate response assessment of chemoradiotherapy to plan salvage surgery in patient with advanced disease. However, PET scan is not recommended before 8 weeks, because if patient has gone radiotherapy, there are inflammatory cells which can take up FDG uptake. So there is high chances of false positive rates. So if patient has undergone radiotherapy, we recommend to do PET scan after 8 weeks. Negative predictive value of PET scan after 8 to 12 weeks is around 95%. PET scan is best modality for detection of recurrence in head and neck cancer. It has negative predictive value of around 100% in predicting absence of distant mets and second primary. This was a 64-year-old male has undergone laryngectomy, and patient was having dysphagia. You can see the uptake in the laryngeal area. It was suggestive of a recurrent disease. PET scan has very important role in unknown primary, and it changes the management in around 39% of patient. There are most of the patient of head and neck malignancy with cervical lymphadenopathy. They have undergone pan endoscopy, biopsy, but there is no fetal results. But PET scan can detect the site of primary. Here I will show an example. A patient was having a bilateral cervical lymphadenopathy. Patient has undergone CT scan, but on CT scan there is a very subtle enhancement which can be missed, but on PET scan you can see very obvious uptake. So this was a case of CA nasopharynx which was picked up on PET scan. Patient was undergone biopsy and it come out to be CA nasopharynx. In thyroid cancer, PET scan has very limited role in well differentiated cancer, but whenever there is iodine negative scan, iodine 131 negative and thyroglobulin level is rising, PET scan has important role because it will shows the uptake. In generally iodine 131 cancer, CA thyroid iodine scan is done, but whenever there is negative iodine scan and rising serum TG level, PET scan will give the answer. It will show the metastatic disease, whether there is lung mets, cervical lymphadenopathy or bone mets. PET scan will tell us the answer. PET scan has also important role in CNS lymphoma because it takes uptake around 2 to 2.5 times higher than physiological uptake, and it will show us the lymphomatous involvement. In lung cancer, it's best modality for differentiating tumor from adjacent atelectasis, in identifying chest wall invasion, in detection of pleural mets, in staging of mediastinal lymph node, which has higher sensitivity and specificity than CT scan, and it's best modality for bone metastasis. If there is brain mets suspicious, then we recommend for MRI. PET scan based radiotherapy planning changes the treatment plan in around 50% of the patients. So you can see the monitoring response to treatment. CA right lung, 63-year-old male patient, stage 3A cancer, has undergone 4 cycles of chemotherapy. The lesion in the right lung has regressed in metabolism completely and significantly in anatomy. Small cell lung cancer, highest sensitivity for the distant met. You can see distant bone lesion very easily. In esophageal cancer, it's useful for nodal staging and distant mets, and it changes the treatment plan in around 16% of the patient. It's useful in evaluation of neoadjuvant chemotherapy and radiotherapy by distinguishing residual viable tumor from fibrosis and necrosis. In renal cancer, it's useful in detection of metastatic disease and restaging. PET scan has important role in testicular cancer in imaging modality for detection of viable tumor in residual mass after chemotherapy, and it is accurate in 100% of masses if the mass is more than 3 centimeter. In melanoma, PET scan has important role for nodal and distant metastatic staging. If the PET scan has higher uptake, it correlates with the poor prognosis in HCC, hepatocellular carcinoma, prostate cancer, and low-grade lymphomas. So the clinical impact of FDG PET scan is that it's more accurate, it avoids unnecessary testing, it's better treatment of management in oncology. This was all about the role of PET scan in oncology. I will just shortly cover, there is a role of PET scan in cardiology where we can use for the viability assessment of that myocardial muscle. This is the myocardial perfusion imaging where we inject patient system EB scan, that is thallium, to the patient, and this thallium will go into the myocardial muscle, and which we can image on the gamma camera. And we image on short axis, anterior, inferior, septal, and lateral wall. And after we have done thallium scan, we do PET scan on another day or same day, depending upon the tracer availability. We prepare the patient and keep patient fasting for 4 hours. And we inject fluorodeoxyglucose and do imaging of that myocardial muscle. There are various steps for the myocardial muscle imaging of giving oral glucose and insulin depending upon the blood sugar level. But the basic is that we do these above images are the rest, that is thallium images, and below images are the metabolism, that is FDG images. If suppose there is no uptake on the thallium image and there is uptake on the FDG, so we tell to the cardiologist or CVTS surgeon that that myocardial muscle is viable, so he will intervene with that vessel and he will do accordingly, manage the patient. If suppose both the vessels are not both the myocardial region are not viable, he will not do anything and he will keep on medicine. This, if there is mismatch, then there is a viability. If there is match, there is a scarring of that myocardial tissue. So if there is mismatch in the PET and thallium image, the survival probability of that patient increases. The another role in case of cardiac PET is that pyrexia of unknown origin. If the patient is having fever of more than 21 days and he has undergone all the tests and we are not able to identify what is the source of infection, PET scan will definitely tell you the answer that where is that source of infection. So this was the case. Patient was having fever of more than months and a patient has undergone FDG PET scan. There was a diffuse uptake around all the myocardial muscle. That was patient was having pericarditis and patient has undergone management according to that disease. So PET scan is a one-stop shop solution. If we are doing PET scan and if you are giving answer to that oncologist that you can take biopsy from that lymph node, then it will avoid unnecessary intervention and do biopsy, and it will give all the answers. Thank you. Any question? Thank you.
Sir, good afternoon. I'm Dr. Chandak.
Yes.
I'm a practicing surgeon here, laparoscopic surgeon. Sir, I had a question. Where can we get a false positive uptake?
As I have said that if patient has undergone recent radiotherapy, so there will be false positive uptake because there will be inflammation. If patient has undergone any biopsy procedure, if you are a surgeon, you are doing biopsy or you intervene, then there will be inflammatory reaction at that cell. So it will show false positive uptake.
Sir, without any prior intervention, may that be biopsy or may that be radiotherapy, any infective focus may also give
any infective or inflammatory process. Wherever there is high glucose metabolism, it will show high means false positive uptake.
Is there any SUV max breakpoint?
No, there is no SUV max breakpoint because the SUV depends upon the that tumor, if whether it is well differentiated, poorly differentiated. If suppose a patient is having mucinous CA, then it will show low uptake, even if it is cancer. So there is no SUV cutoff. Previously, it was told that SUV is 3.5 cutoff, that if it is more than 3.5, it is malignant. But presently, there is nothing like that, because even if it is 2.1 SUV, and
it
if
may be
it can be positive, all depends on the biopsy. Because mucinous CA and low-grade carcinoma, they will show less glucose metabolism.
So it will just help us to detect the site and
Yes, diagnose.
final by biopsy.
And also for the response assessment. If suppose
Response assessment.
it will be best for response. How was the SUV at the baseline, and after the treatment, what is the SUV? So it will help for the surgeon or oncologist to take the further decision.
Okay.
For that.
Sir, secondly, I wanted to ask, is the delay in the scan, will it affect the report? For example, the dye has been given and there is a delay in the scan.
Okay.
Will it affect the report?
No, it will not affect, because when we ideal time for scanning is that after the injection waiting period is of 45 minutes.
Okay.
Till that time, what will happen, that radio tracer will go into the target organ and it will clear from the blood through urine. If suppose patient is taken delayed, so what we do, we see the counts on the computer. We will increase the counts time. If the patient has one injection 45 minutes before and we have taken the patient for the scan.
Yes.
So for a normal scan, it takes around 7 to 8 minutes, whole body scan.
Yes.
If suppose we are delayed by around half an hour, so that scan time will increase that scan time.
Yes.
So if it is taking 8 minutes normally, we will do for 12 minutes. So the counts means that radiation coming from the body will catch on the detector. It will not affect that much. If you are doing much delay, 2 or 3 hours, then scan quality will be poor, because that tracer will decay with the time.
Sir, half-life you said 110
10
minutes.
minutes, 110. It's
110.
almost 2 hours.
Okay.
So that is the challenge for us, because that tracer will be coming from Mumbai also. So we schedule all the appointments priorly, 1 day prior. Yep, schedule all.
Thank you, sir.
Yes. Yes, sir. Yes. Yes. So in cardiac imaging, nuclear medicine has 2 tests, stress thallium. In stress thallium, what we do, we give thallium. Now in Harrison it is thallium, but nobody do thalliums. We do with maybe methoxy isobutyl isonitrile, system maybe. But generally all the physician means in Mumbai also they write down thallium test. So stress thallium is a test where we should where we see the stress inducible ischemia. Means if there is a culprit vessel, whether there is significant stenosis or not. So what we do first a rest study, and after that we do the stress study, and we see whether there is a perfusion defect in the scan. If the defect is significant, that lesion is has to be targeted or it has to be solved. This is the first part. Then second is viability. In viability, we don't do stress. We just see how is the perfusion of that myocardial muscle. If suppose in rest perfusion is normal, then our answers for the cardiologist is solved that it's viable. But in suppose rest imaging, there is a defect. It can be viable or it can be scarred. So we have to confirm it from the PET scan. So in all the patients, we don't do PET scan. We do PET scan if there is a defect on the rest imaging. So in PET scan, what we see, if we see that if there is a defect in the rest imaging, whether in that area there is glucose metabolism. If suppose there is glucose metabolism, that area is viable or hibernating myocardium. So we tell accordingly to the physician or surgeon that you should intervene in that. No, ideally PET scan directly is not advised, because a single PET scan will also not give answer, because PET has to be correlated with rest perfusion or rest thallium study. So both studies should be done for the complementary. So for the viability, this rest and FDG, and for stress inducible ischemia, we do rest thallium and stress thallium, and we give answer.
Sir, one online question is there. Investigation of choice for pancreatic inflammation.
For pancreatic inflammation, we don't do PET scan for that, MRI or CT scan.
What is the situation for uncontrolled diabetes mellitus?
for doing PET
How
scan.
how the test will be functioning, or how will you test him?
For uncontrolled means basic question is that for the PET scan, if blood sugar is more, we uh, don't do test for that patient. If suppose blood glucose is more than 200, so what will happen that if glucose is more, what we inject fluorodeoxyglucose, so that fluorodeoxyglucose will not go to the target organ. It will be in the blood because there will be competition between normal glucose and what we are injecting. So ideally, all the patients who are having high blood glucose, we postpone that patient because scan quality will be poor and there will be muscle uptake. So because of that muscle uptake, we don't do patients with higher blood sugar level. We tell to get a consultation diabetologist and control the blood sugar level and do the scan. Thank you.
Chairpersons Dr. Nihar Chandak sir and Dr. Bashir Khan sir, I request you to felicitate our speaker, Dr. Prafulla Jatale sir. And yeah, I wish to invite Dr. Mahesh Kade sir on dais for the felicitation of chairpersons. For concluding the clinical sessions and today's CME, I invite Dr. Arun Daithankar sir, our senior most physician of Dr. Prafulla Patil Hospital, HOD of Medicine Department, for the vote of thanks.
Good evening to everybody. We are at the concluding part of the today's CME. This CME, for making successful this CME, I thanks our patron, Dr. Praful Patil sir and Dr. Vidya Patil madam, with their constant efforts and suggestions to our team to make this CME very successful. So I thank both of them. I also thank IMA office bearers. Without their help and giving assistance to this CME would not have been performed. Nonetheless, our today's various speaker, they have given us a very good knowledge, enlightenment, and this will be helpful in future to improve the healthcare in our hospital at Parbhani. I also thank to our delegates, because without delegates, the CME could not been possible. So I also thanks the all delegates which has participated to make this CME very successful. And I also thanks to our team, various team, food team, then the team which is involved in the arrangements of the lights and all. So this is, I also thank to the so I'm glad to announce that there are almost, we have received registration of 350 delegates. This is a good, 200 online and 150 offline registration. It's a very remarkable thing. And I hope in future also, whenever this type of CMEs will be arranged, same, we will gather with the same enthusiasm here, and we will continue to improve our knowledge, skills, and devotions to improvement of the patient's care in Parbhani region. With all these things, and I also thanks to the food department, Fern Group, they have prepared a very delicious and tasty food. And our team at the Prafulla Patil Hospital, all of them have worked very well, and their contribution is also necessary and for success of this CME. Then I also thanks to the MQR pharmaceutical company. They have sponsors food to this CME. Okay. With all these things, I conclude, and once again, thanks to all for making this CME successful. Thank you.
Not but least, I must mention the name of Dr. Sagar More and Dr. Vijay Bonde, who had made the online registrations and audio-visual well successful, so that all the online and offline people, they can enjoy it uninterruptedly. So their expertise and their techno-savviness is really has to be appreciated. So word of appreciation for both clinical secretary for their complete audio-visual uninterrupted exposure to the all delegates. Thank you so much.
सर एक फोटो को या सर चांडक सर प्लीज मैडम देशमुख सर बक्कट सर प्लीज कम ऑन द स्टेज Oh.